Good morning, ladies and gentlemen. We have the dignitaries here and welcome you all to the National Conference on Moving Mental Health Beyond Institutions, organized by the National Human Rights Commission, NHRC India. We have among ourselves the gracious presence of Dr. Bharti Praveen Pawar, Honorable Minister of State for Health and Family Welfare as a chief guest, Mr. Justice Arun Mishra, Honorable Chairperson, National Human Rights Commission, Dr. Gyaneshwar M. Mule, and Mr. Rajiv Jain, honorable members, Mr. Justice M. Kumar, former member at NHRC, Secretary General Mr. Bharat Lal, National Human Rights Commission, and Mr. Sudhansh Pant, official on special duty and Secretary Designate, Ministry of Health and Family Welfare. Shubham Karoti Kalyanam Arogyam Sukh Sampadam Mam Buddhi Prakasham Chadeep Jyotir Namo Astute. दीप ज्योति शुभ करे, कल्याण करे, आरोग्य करे, सुख संपदा प्रदान करे। आइए कार्यक्रम का शुभारंभ इसी भावना के साथ दीप प्रज्वलन करने के साथ ही आरंभ करते हैं। मैं रिक्वेस्ट द डिग्निटरीज to please take their seats on the dais to begin with the proceedings of this conference. Dr. Bharti Praveen Pawar, Honorable Minister of State for Health and Family Welfare, as the Chief Guest, Mr. Justice Arun Mishra, Honorable Chairperson, National Human Rights Commission, Dr. Gyaneshwar M. Mule, and Mr. Rajiv Jain, honorable members, and Mr. Justice M. Kumar, former member NHRC, Secretary General Mr. Bharat Lal, and Mr. Sudhansh Pant, official on special duty and Secretary Designate, Ministry of Health and Family Welfare. May I request Secretary General NHRC to please welcome Dr. Bharti Praveen Pawar, Honorable Minister of State for Health and Family Welfare, and the chief guest by presenting a planter. May I also request Mr. Lal to please welcome Mr. Justice Arun Mishra with a planter. Thank you, sir. May I now request Mr. Devendra Kumar Nim, Joint Secretary NHRC, to please welcome Dr. Gyaneshwar M. Mule, Honorable Member NHRC, with the planter. May I request the Joint Secretary to also welcome Mr. Rajiv Jain, Honorable Member NHRC, with the planter. Mr. Nim is requested to present a planter to former member NHRC, Mr. Justice M. Kumar. May I also request Mr. Nim to welcome Mr. Sudhansh Pant, official on special duty and Secretary Designate. Okay. Thank you, sir. May I request Mr. Nim to present a planter to Secretary General, NHRC, Mr. Bharat Lal. Thank you. May I now request Mr. Bharat Lal, Secretary General, NHRC, to deliver welcome address and give an overview of this conference.
Good morning to you all. Chief guest, Honorable Union Minister of State for Health and Family Welfare, Dr. Bharti Praveen Pawar, Honorable Chairperson, National Human Rights Commission, Mr. Justice Arun Mishra, honorable members, Mr. Daneshwar Mule, Sri Rajiv Jain Saab, and former member, National Human Rights Commission, Sri Justice M.M. Kumar, distinguished delegates, experts from mental health institutions, senior officers from Government of India and states, and ladies and gentlemen. And more importantly, I also welcome the people who have joined online from throughout the country. Indeed, it's a privilege for me to stand here and extend welcome on behalf of National Human Rights Commission to this national conference, Moving Mental Health Beyond Institution 2023. I think importance of the conference you know better than me. As we all know, mental health issues is one of the most critical health issues of our times. At the outset, on behalf of the Commission, I extend a warm welcome to Honorable Minister, who has joined this conference despite parliamentary session. As we all know that we have dealt with parliamentary issues, that at this point of time, sparing 1 hour here, I think it's a very big. Thank you, ma'am, for being here, and that shows you. Well, friends, as we all know, Justice Arun Mishra, Honorable Chairperson, National Human Rights Commission, he has given a new direction to the Commission, and his compassion, his empathy, and taking up these issues, I think is quite remarkable. I am here since last 20 odd days, and I have seen the kind of leadership he provides. And I think on behalf of Commission, we are grateful to have a chairperson like him. Sir, I take liberty to welcome you because you are the host, and this has been organized at your behest, at your initiative. As we know, Dr. Daneshwar Mule Saab, he has been an esteemed colleague, and he has done throughout life wonderful work in foreign service as a diplomat and here in the Commission. Similarly, Mr. Rajiv Jain, we all know, honorable member, both have been guiding force, in fact. And let me share here that the presence of such august member in the Commission, it gives a special character to the Commission. Their sensitivity, their guidance, and their support, I think we are learning a lot, and whatever we are doing is because of their presence. Sir, welcome to both of you in your own conference. I also welcome former member National Human Rights Commission and former Chief Justice, Jammu and Kashmir High Court, Justice M.M. Kumar. In fact, let me share that both the book which we are going to release, Honorable Minister is going to release, and report, and the whole this exercise has been done at his behest. Sir, we are very grateful to you for your guidance and your support. And welcome to this gathering. Due to some sudden development, my esteemed colleague, Mr. Sudhans Pant, who is going to take over as Secretary Health from 1st of August, he could not join, and he has other officers from Ministry who are here. On behalf of the Commission, we welcome all of you, especially the professionals and officers from state government and mental health institutions. So thank you all for being here. Let me give just a small overview of this conference actually. As you know that Government of India has taken a number of initiatives over the last couple of decades, especially National Mental Health Program 1982, District Mental Health Program, and then Manpower Development Scheme for establishment of centers of excellence, and establishing postgraduate departments in mental health specialists. And of course, as we all know that Mental Health Care Act 2017 is a landmark, and that has started this journey. National Human Rights Commission has been playing an important role in assuring and promoting awareness on mental health among various stakeholders, especially state and UT governments. The Commission has also taken initiative to understand the grassroots level issues affecting the implementation of Mental Health Care Act 2017. As we all know that way back in 1997, Honorable Supreme Court In fact, it mandated National Human Rights Commission to be involved in the supervision of functioning of mental health institutions, especially at Agra, Gwalior, and Ranchi. In 2022, Honorable Chairperson gave a new impetus to the mental health issues. He requested the Chief Justices of Allahabad, Jharkhand, and Madhya Pradesh High Court to monitor the functioning of the mental health institutions, hospitals, and arranged to send quarterly reports to the Commission. The Commission headed by Justice Sri Arun Mishra, along with members and senior officials, visited all 4 of these institutions personally to have first-hand knowledge of the condition and functioning of these institutions. Thereafter, Commission requested our special rapporteurs to visit and collect information of the government mental health care established throughout the country and give a report, recommendation, and to remove its shortcomings. Commission also held various workshops in each institution to discuss key challenges and issues and formulate a plan for their efficient function. Sir, after detailed analysis, the Commission issued notices across the country calling for detailed action taken reports. The Commission has prepared a report as well as a book to further enhance the understanding of mental health and the shortcomings and issues related to implementation of Mental Health Care Act in the country. The book, which today Honorable Minister is going to release, the book Mental Health Concern for All, in context of Mental Health Care Act 2017, and the status report, the status of implementation of Mental Health Care Act 2017 has been prepared. Due to time constraint, I am not discussing the content of these 2 reports, the book and report, and I will request you to kindly read, kindly go through, and I think from here we'll take it forward. Well, the idea of organizing this conference started in 2022 to create an environment for better health, mental health condition. In this period, the Commission has been monitoring various mental health institutions in the country. As you know, mental health is an integral part of health. It is more than absence of mental illness. It is the foundation for well-being and effective functioning of individuals. It includes mental well-being, prevention of mental disorders, treatment and rehabilitation. In this endeavor, the union and state governments, mental health institutions, and experts are partners. Moving beyond institution, encourage early intervention and prevention strategies. By providing accessible and proactive community-based care, we can identify mental health concerns early and intervene before they escalate. The most important part continued working with people to enhance their understanding of mental health issues. Today, experts, researchers, practitioners, and advocates from various fields related to mental health are assembled here. They'll share their insights, research findings, and best practices, fostering a better understanding of mental health challenges and potential solutions. I'm sure that this conference on mental health will provide an excellent platform to raise awareness about mental health issues, breaking the stigma surrounding the mental illness. Once again, on behalf of the Commission, I welcome you all to this conference and have a meaningful day. Thank you very much.
Thank you, sir. Mr. Justice Arun Mishra, Honorable Chairperson, National Human Rights Commission, has been having a lot of concern for human rights, both as a judge in the High Courts and the Supreme Court, and now as the Honorable Chairperson of the National Human Rights Commission. Besides addressing the concerns on various issues of human rights, he has made concerted efforts to address the challenges being faced by the mental health care system in the country. He, along with the honorable members and senior officers of the Commission, not only visited the mental health care institutions in Gwalior, Agra, and Ranchi, but also ensured that the Commission, through its special rapporteurs, visited all the 47 mental health care institutions in the country to have a first-hand account of the challenges and way out for their resolution through this national conference. May I now request Mr. Justice Arun Mishra, Honorable Chairperson, NHRC, to please deliver the keynote address.
Honorable Minister of State for Health and Family Welfare, Dr. Bharti Praveen Pawar, my esteemed colleague Mule Saab, Jain Saab, former member Justice M.M. Kumar, Secretary General Shri Bharat Lal Ji, my other esteemed colleagues, Dr. Mahajan, member of the core group, officers of the central and state government, experts of the mental health institutions, persons from media, civil society, distinguished invitees, ladies and gentlemen. We have gathered here. It is a crucial moment in our collective efforts to address one of the most pressing issues of our time, mental health. It affects everyone, regardless of background, profession, or socio-economic status. It is an issue that knows no boundaries and demands our unwavering attention. I welcome experts, practitioners, other stakeholders from various fields to engage in vital discourse by facilitating an open exchange of knowledge and ideas. Today we find ourselves in an era marked by unprecedented challenges. The fast-paced nature of modern life, coupled with the impact of global events, has taken a toll on our mental health. Stress, anxiety, depression, and other mental health conditions have become all too common, affecting individuals of all ages and backgrounds. 1 out of 10 persons suffer from one or different kind of mental disorder. We face the suicide of approximately 13,000 students every year. Besides, we find suicides in jail, semi-armed forces, armed forces, and others. Abuse of elders and workplace stress is to be cared for. Depression is one of the leading cause of disability. In recent years, there has been increasing acknowledgement of vital role mental health plays in achieving global development goal, as illustrated by its inclusion in the sustainable development goals. We must strive to eliminate mental health stigma, which still prevails in the society with this disease. Encouraging open conversation and foster understanding and compassion is a requirement of the day. We require empathy towards mental illness, not mere simple sympathy. Dignity in mental health, ill health condition is to be protected at all costs. We aim to achieve dignity through the Mental Health Care Act of 2017. 2017 is a human-centric, human rights approach oriented act which brought paradigm shift in mental health care and aimed at protecting the human rights, and it decriminalized also the suicide attempt. Addressing mental health requires a comprehensive approach encompassing health care, education, public policy, and social support system. We need integration of mental health, substance abuse, general medical care, and hospital and community care, which are poorly coordinated at present. Mental health is to be given the same importance as physical health. Mental hospitals should have a close-knit team of psychiatrists, clinical psychologists, social workers, psychologists, nursing staff. In a welfare state, it is the state's obligation to provide medical facilities to every human. That is imperative by virtue of Article 47 of the Constitution of India. Hospitals should run to perfect standards, promoting quality care with quality rights. providing psychological support and interventions, including digital one, and work for suicide prevention. Without mental health, there is no health. We require to mobilize efforts to raise awareness of mental health issues. We must integrate mental health education into our schools, colleges, and workplaces, setting up of healthy boundaries with social media is also necessitated. The approach to mental health and techniques of psychiatry has changed. Psychologists have innovative tools and methods. The latest research is of blood test. They determine mood disorder by virtue of RNA biomarkers. Transcranial magnetic stimulation is also being done. Australia and England are pioneers in the field of research work. We need to modernize infrastructure and approaches in mental health establishment, allocation of resources to update mental health services and research is necessary to make mental health a reality. We face obstacles in implementation of the Act of 2017 due to non-establishment of state mental health authority in some states and mental health review boards for a district or a group of districts. Framing of state mental health rules and regulation is still required as prescribed under sections 45, 73, 122 and 123 respectively of the Act. Registration of all hospitals is necessary under section 65 of the Act, which is yet to be achieved. There are limited number of educational institutions and seats for professional mental health courses, leading to a limited number of mental health professionals. We need to increase the MD, MPhil diploma seats. The severe shortage of doctors, staff infringe human rights of mentally ill patients. Most institutions are working with 30 to 40% staff. There is a necessity for a lady psychiatrist or psychologist for female patients. A hospital is not a place where cure patient should be allowed to stay even for a single extra day. The problem restricts the hospital's ability to cater to the needs of new patients who need urgent intervention. In some visits undertaken by the Commission to mental health centers, it was noticed that often the number of patients was higher than the sanctioned strength, and large number of those patients who had already got cured continued to stay in these centers, and medical facilities and hygienic standards were much below acceptable standards. Besides, no serious coordination was visible among the various agencies such as district administration, the police, mental health, court, center officials to health centers, and official to facilitate halfway homes or return of cured patient to their families. We hope there is a better coordination among authorities to streamline procedures and improve this situation. The report indicates that there are approximately more than 2,000 cured patients in the mental hospitals. There should not be even one cured patient in a hospital. Hospital is not a place for a cured patient. But unfortunate situation is that half of them are housed in West Bengal only, in 4 hospitals, more than 900. This is a travesty of justice. We are using these hospitals to keep fit persons, those who do not require treatment. This situation must be looked into by all of us. I am giving the figures, though I was not proposing to give it earlier. The establishment cannot keep a patient once the patient has fully recovered as per their rights, statutory and constitutional. Statutory right is provided under section 19(1)(a) and (b) of Mental Health Care Act 2017. It results in the unlawful detention of fully recovered patients as not having a family or not being accepted by the family, or homelessness is not a criteria precedent to the release of the patient. Section 19 says you have to still release them if they are not being accepted by the family. The courts and the police have also to ensure help for union and families as per the mandate of section 100, 101, 102 of the Act. When the court can send them to the mental hospitals under section 100, the power to do an act includes the power to undo it. The Ministry of Social Justice and Empowerment, Government of India issued to state government and union territories guidelines for discharge of mentally cured or fit for discharge patient from mental health institutions, and guidelines for state government for setting rehabilitation homes. Central government has also floated a scheme, Deen Dayal Disabled Rehabilitation Scheme, revised guidelines with effect from 1/4/2018, which specifically makes provision for persons who have been successfully treated for mental illness. The project for halfway homes, which the Government of India funds, is aimed at 1. Providing necessary alternatives for the persons who have received the treatment for mental illness but do not require hospitalization. 2. Filling in the vacuums as families and communities still hesitate to accept such persons. 3. Providing vocational training so that such persons can fend for themselves and are otherwise constructively occupied. 4. Ensuring continued access to healthcare facilities if required by the cured patient. 5. Reintegration of such persons with their families by counseling and community at large. For want of implementation of the aforesaid welfare scheme by the takers and by the authorities, we lack halfway homes, rehabilitation and occupational therapy units to house recovered patients. There is need for funds. Hospitals are unable to provide basic amenities to patients, including nutritious food. Calories differ as per the data collected from 1500 to 3300 in various hospitals. Diet is to be managed appropriately. And drinking water, comfortable bedding, even pillows are not provided. Hygiene and fresh clothes, recreation facilities must also be provided. Bad condition of toilet and unhealthy foul smell in the wards creates inhuman situation to live. It is violative of mandate of section 20, suffices to say so. When we can have modern infrastructure in these fields, why we cannot provide the mental hospitals? I fail to understand. There are only 47 mental hospitals in the country. We can do it. Overnight we can do it. We can plan overnight. But I do not know what is the hitch. Lack of proper infrastructure, mental health institutions resemble a lock-up-like situation. Patients are not permitted to go out. Even recovered persons are not permitted to go out. That is a travesty of justice. Where we are? Are we treating them or keeping them in lockup? There needs to be more CCTV surveillance and security personnel to check behavior and effective control of staff and patients. There's dearth of emergency services. Drugs should be kept in-house. We must address the underreporting of events such as adverse effect of medication drug reactions and deaths of patients in violent incidents between patients. There is a lack of digitalization of medical records, which poses a risk of facilitating well-informed communication for future references. The problem of misrepresentation of mental illness by criminals defeats the course of justice and deprive utilizing facilities by genuine patients. I may share one experience. I asked criminal at Ranchi, How long you have been here? 9 months. How long you will be here till I get the bill? I do not know how to improve the situation. The lack of participation of mental health institution in the district mental health program adversely impacts the assistance that may augment institutional capacity and promote community awareness. A responsible network of civil society organizations and NGOs for intellectually disabled patients and persons suffering with depression should be developed. Large areas and gardens are attached to the hospitals. There is need for sound management of these areas and also prevent the encroachments. Large number of apps are available for mental health guidance. Generally, no national standard for evaluating mental health apps exist. The apps provides anonymity, accent outreach, and ensure services availability and advice 24/7. National mental health program Telemanas also cater to the need. Sensitization of health workers and community at large is necessary. Experts must be provided exposure to international and national level research and new methodologies being adopted. Individuals with sound mental health can contribute positively to their families, workplaces, communities. We are not in a blame game here, but our intent is that situation must improve through joint effort. And we achieve the goal envisaged by the wonderful Human-Centric Act of 2017. That is unparalleled act anywhere in the world, but still there's a distance between cup and the lip. Let us foster interdisciplinary collaboration among healthcare providers, policymakers, researchers and educators and community leaders. By working together, we can develop holistic situation that addresses the multifaceted aspects of mental health, ensuring that no one is left behind and realizing a dream of Sarve Bhavantu Sukhinah, Sarve Santu Niramayah, Sarve Bhadrani Pashyantu, Ma Kaschit Dukh Bhagavit. Jai Hind.
Thank you, sir. The National Human Rights Commission has been publishing books on various issues of human rights, including mental health care, to raise concerns and spread awareness. In a series of such publications, the Commission has published a new book and a report. The book is titled Mental Health, Concern for All in Context of the Mental Health Care Act 2017. The book carries significant aspects of mental health, such as the mental health of children, women, elderly persons, LGBTQIA+ community, prison inmates, among others. It also significantly talks about the mental health policies and laws in India to make it serve the purpose of a reference book. I have the honor to inform that we have among ourselves the august presence of Mr. Justice M.M. Kumar, former member of the NHRC, who tremendously contributed in shaping this book. May I now request Honorable former member, Mr. Justice M.M. Kumar, to please present the book to the Honorable Minister and Chairperson, NHRC, to release it. Thank you, ma'am. Thank you, sir. The Commission has also prepared a comprehensive report on the status of implementation of the Mental Health Care Act 2017. It is an outcome of the visits of the Commission and its special rapporteurs to the mental care hospitals and institutions in Gwalior, Agra, and Ranchi, and 47 mental health care institutions in different states of the country. May I request Honorable Minister and the dignitaries on the dais to kindly release the report on the status of implementation of the Mental Health Care Act 2017. Thank you. Dr. Bharti Praveen Pawar, Honorable Minister of State for Health and Family Welfare, is a medical professional and has been active social worker also. She brings along with her the experiences and challenges being faced in the health sector on the ground, both as a medical professional and as a social worker. She has served as a member of a standing committee on health and family welfare and also as a member of consultative committee on Ministry of Skill Development and Entrepreneurship. She joined the Council of Ministers as a Union Minister of State for Health and Family Welfare on 7th July 2021. May I now request Dr. Bharti Praveen Pawar, Honorable Minister of State for Health and Family Welfare, to please deliver her inaugural address.
नमस्कार। आज के इस कार्यक्रम में उपस्थित जस्टिस अरुण मिश्रा जी, श्री भरतलाल जी, जस्टिस कुमार जी, डॉक्टर ज्ञानेश्वर मुले जी, राजीव जैन जी, सभी मान्यवर, मीडिया के प्रमुख, नेशनल ह्यूमन राइट्स कमीशन आयोजित इस कार्यक्रम में मूविंग मेंटल हेल्थ बियॉन्ड इंस्टीट्यूशंस इस विषय पर इस राष्ट्रीय सम्मेलन में आप सभी के बीच उपस्थित होकर मुझे बहुत प्रसन्नता हो रही है कि ये भी कार्यक्रम आयोजित करने में NHRC ने बहुत बड़ी उपलब्धि कराई है। हम उनका सबका अभिनंदन करते हैं। मैं सराहना करती हूँ कि नेशनल ह्यूमन राइट्स कमीशन हमेशा से ही मानव अधिकारों की रक्षा, मानव अधिकारों के संबंधित विषय के प्रचार, संरक्षण, उसकी अकाउंटेबिलिटी और ट्रांसपेरेंसी ये सुनिश्चित करने के लिए और राष्ट्र के भीतर मानवीय गरिमा और न्याय, इसके लिए संस्कृति को, हमारी सभ्यता को बढ़ावा देने के लिए महत्वपूर्ण भूमिका आज NHRC निभा रहा है। साथियों, जैसे हम जानते हैं कि मेंटल हेल्थ इज इंटीग्रल पार्ट ऑफ हेल्थ। मेंटल हेल्थ किसी भी व्यक्ति की भलाई और प्रभावी कामकाज की नींव है और इसीलिए हमारी भावनात्मक, हमारी मनोवैज्ञानिक, हमारी सामाजिक भलाई इसी में शामिल है और यह निर्धारित करने में भी मदद करती है कि हम तनाव को कैसे संभालते हैं। जस्टिस मिश्रा जी ने बहुत सारी बातें उठाई जो सोचने विचार करने के लिए जरूरी है कि हम किस तरीके से इस तनाव को संभालते हैं और तनाव को बढ़ने के बाद किस तरीके से मेंटल स्ट्रेस और मेंटल डिसऑर्डर के रूप में एक बड़ा डिसऑर्डर सामने आता है, तब संभालते हैं कि अगर काश इसको पहले ही शुरू में हम कंट्रोल कर पाते। प्राइमरी, सेकेंडरी, टर्शरी केवल नाम नहीं है, ये स्टेप्स है। और आज हमें छोटी छोटी बातों पर, सर मुझे आज भी याद है कि मेरे घर में एक छोटी बेटी आई थी, नर्सरी की एग्जाम थी। सर नर्सरी के बच्चों को भी टेंशन है कि कल मेरा एग्जाम है, मुझे पोएम बोलनी है टीचर के सामने, तो हम किस दिशा में जा रहा है ये भी सोचने वाली बात है कि हम हमारे बच्चों पर क्या इतना स्ट्रेस दे रहे हैं जिनकी उम्र खेलने की है। शायद जस्टिस साहब आप तो यू आर लकी कि आपके समय में टेंशन शब्द भी नहीं हुआ होगा, राइट? यहाँ पे जितने सीनियर से तो मैं पूछना चाहूंगी कि शायद टेंशन शब्द मतलब अलग है, यह शब्द ही अलग है, था ही नहीं, उपयोग ही नहीं करते थे। और जो भी देखो, संकट के बिना कोई जीवन नहीं है, समस्या के बिना कोई जीवन नहीं है, और हर समस्या का समाधान है, ये भी तो जीवन है। तो इसे भी हमें समझना चाहिए। भगवान जब समस्या देते हैं तो उसके पहले भगवान समस्याओं का समाधान देते हैं। इसे देखने की ताकत हम सब में है, लेकिन हम शायद उस दृष्टि से देखते नहीं है। तो मुझे लगता है कि ये तनाव को हम किस तरीके से संभालते हैं और दूसरे से कैसे संबंधित होते हैं हम, और हम क्या विकल्प चुनते हैं, इस बात को लेके मानसिक स्वास्थ्य संबंधी सभी हमारी सामाजिक, हमारी आर्थिक, हमारे एज, सेक्स, सभी बियॉन्ड उस स्थितियों की परवाह किए बिना जीवन के सभी क्षेत्र को ये मेंटल स्ट्रेस, मेंटल हेल्थ हमारी प्रभावित करती है। मानसिक बीमारी से प्रभावित अधिकांश लोगों को यह समझने में मुश्किल होती है कि वे इससे पीड़ित है, या फिर वो इस समझने के बाद भी उस इलाज से बचते हैं, क्योंकि मानसिक बीमारी को आज भी समाज अलग दृष्टि से देखता है, अच्छी दृष्टि से नहीं देखता है। और इसीलिए यह महत्वपूर्ण है कि मानसिक बीमारी से प्रभावित लोगों को मदद लेने और उसका उपचार का लाभ उठाने के लिए हमें प्रोत्साहित किया जाना, उसे प्रोत्साहित करना है, और जिससे हमें मानसिक स्वास्थ्य स्थितियों से सीधे जुड़ी कुछ शारीरिक स्वास्थ्य समस्याओं को भी नियंत्रित करने और उस चुनौतियों को सामना करने में आसानी हो सके। Friends, it is important to mention here that as per the National Mental Health Survey of India conducted through NIMHANS Bengaluru in 2016, the prevalence of mental disorders in adult over the age of 18 years is about 10.6%, which is very, very bad. आदरणीय प्रधानमंत्री जी के नेतृत्व में देश में मानसिक स्वास्थ्य के मुद्दों को समाधान के लिए कुछ उल्लेखनीय कदम उठाए हैं। देश भर में मानसिक स्वास्थ्य की सेवाओं को और उसके लिए बुनियादी ढांचों को विस्तार करने के लिए प्रयास किए गए हैं। प्रधानमंत्री जी के कार्यकाल में मानसिक स्वास्थ्य को एक महत्वपूर्ण सार्वजनिक स्वास्थ्य चिंता के रूप में जाना गया है, अधिक ध्यान दिया गया है, और उसके लिए मिशन मोड पे काम किया जा रहा है। इसमें हमारी मानसिक स्वास्थ्य सुविधाओं की संख्या बढ़ाना हो, हमारे यहाँ ट्रेनर्स हो, डॉक्टर्स हो, उसमें जो एक्सपर्ट्स हो उनके प्रशिक्षण देना हो, मानसिक स्वास्थ्य सेवाओं को प्राथमिक स्वास्थ्य देखभाल में भी उसको शामिल करना हो। प्राइमरी लेवल पे जब गांव-गांव में सुविधा नहीं होती है टर्शरी केयर की, लेकिन प्राइमरी हेल्थ केयर में भी उसका समाधान मिले। 2014 में जब हमारी सरकार सत्ता में आई तो हमने नेशनल मेंटल हेल्थ पॉलिसी पर काम किया, और मेंटल हेल्थ केयर एक्ट 2017 में मानसिक बीमारियों से प्रभावित व्यक्तियों को कानूनी अधिकार प्रदान करने के लिए भारतीय संसद द्वारा पारित एक ऐसा ऐतिहासिक कानून बनाया, और यह मानसिक स्वास्थ्य उपचार और देखभाल के लिए यह कानून जोर देता है, जिसके बारे में आदरणीय जस्टिस साहब ने बोला है। फ्रेंड्स, इन दिस कॉन्फ्रेंस experts shall discuss the challenges in the implementation of Mental Health Care Act 2017, needs to address the infrastructure and human resources aspect of mental health establishments, rights of person with mental illness, including reintegration and rehabilitation and latest trend in critical care of mental health, international perspective, and the way forward. भारत में मानसिक अस्पताल जरूरतमंद व्यक्तियों को व्यापक मानसिक स्वास्थ्य देखभाल प्रदान करने के लिए संरचनात्मक रूप से तैयार है। इन हॉस्पिटलों की संरचना और कार्यात्मक पहलुओं को हमारे नागरिकों के लिए एक सर्वोत्तम देखभाल सुनिश्चित करनी चाहिए। मानसिक बीमारियों से पीड़ित लोगों के सशक्तिकरण की दिशा में काम करना बहुत ही महत्वपूर्ण है और ये अभी नीड ऑफ आवर है, हमारी जरूरत है। साथियों, देश में अच्छी दवाइयां, सुलभ सस्ती दवाइयों का भी उपलब्ध करवाना हमारे लिए उतना ही महत्वपूर्ण है। मानसिक स्वास्थ्य देखभाल सुविधा प्रदान करने के लिए भारत सरकार ने देश में राष्ट्रीय मानसिक स्वास्थ्य कार्यक्रम नेशनल मेंटल हेल्थ प्रोग्राम NMHP लागू किया है। NMHP के जिला मानसिक स्वास्थ्य कार्यक्रम में DMHP जो डिस्ट्रिक्ट लेवल पे इस घटक को हम आज 738 जिलों में ये कार्यान्वयन करने के लिए हमने मंजूरी भी दी है कि जिला लेवल, जैसे हम PHC का CHC का सोचते हैं तो जिला लेवल से ही इसे एक बॉडी मॉनिटर करे, जिसके लिए हमें NHM के माध्यम से सभी राज्यों को, सभी यूटीज को सहायता प्रदान की जाती है, तो बजट भी प्रोवाइड करते हैं। ये सवाल हमेशा सर पार्लियामेंट में आता है कि सरकार क्या मानसिक स्वास्थ्य को लेके गंभीर है, चिंतित है, क्या उपलब्धियां करवा रही है? तो हम बोलते हाँ, सरकार ने पॉलिसी भी लाई है, काम भी किया है और डिस्ट्रिक्ट लेवल पर हमारे जो अस्पताल है उनमें हम साइकेट्रिस्ट हो, दवाइयां हो, ये सभी देने को हम लोग प्राथमिकता देते हैं। और इस माध्यम से, इस कॉन्फ्रेंस के माध्यम से मैं यही अवगत कराना चाहती हूँ कि ये सुविधा है, आपको उसे पहुंचाना है। अगर कोई नीडी है, अगर कोई जरूरतमंद है तो आपको उसको सही दिशा में सहयोग भी करना है। CHC, हमारी CHC है, प्राइमरी हेल्थ केयर है, तो DMHP द्वारा ये सुविधाओं में उस पेशेंट को उसकी दवाई, उसकी आउटरीच सेवाएं, उसका ट्रीटमेंट, ये सभी शामिल है। और यही नहीं तो टर्शरी केयर तक, टर्शरी लेवल की सुविधा प्रदान करने के लिए हमने 25 ऐसे केंद्र स्वीकृत किए हैं जो उत्कृष्ट केंद्र है, जिसमें हम काम कर रहे हैं। इसके अलावा सरकार ने मानसिक स्वास्थ्य विशिष्टताओं में 47 विभागों में PG के कोर्सेस द्वारा PG को शुरू करवाया है, जिससे कि ये स्ट्रक्चरल भी मजबूत होगा और उसका लाभ विद्यार्थियों को पढ़ाई के साथ पेशेंट को भी होगा। और ऐसे 19 मेडिकल कॉलेजों में ये शुरू करवाया है और कुछ इंस्टीट्यूशंस में। हमारे 22 एम्स जो कुछ बने हैं, कुछ प्रोसेस में है, उस 22 एम्स में भी मानसिक स्वास्थ्य सेवाओं का प्रावधान किया गया है। एक अलग डिपार्टमेंट उसको रिसर्च बेस हो या टर्शरी केयर बेस हो, उस पर काम करेगा। इसके अलावा हमने आयुष्मान भारत, प्रधानमंत्री जन आरोग्य योजना जैसी बड़ी योजना है, उस पे भी मेंटल हेल्थ को समावेश किया है। मुझे ये बताने में खुशी है कि आदरणीय प्रधानमंत्री जी के नेतृत्व में और आदरणीय स्वास्थ्य मंत्री डॉक्टर मनसुख मांडविया जी के मार्गदर्शन में हमने 2022 में नेशनल टेलीमेंटल हेल्थ लॉन्च किया। प्रधानमंत्री जी का कहना है कि हमें टेक्नोलॉजी का उपयोग करना चाहिए। जहां हम नहीं पहुंचते हैं वहां टेक्नोलॉजी के माध्यम से क्या हम जुड़ पाएंगे? तो हम जुड़ पाएंगे। ये कोरोना ने हमें सिखाया है। कोरोना ने हमें इतने सबक सिखाए, उसमें से एक है ये टेलीमेंटल कंसल्टेशन। और आज हम जब रिव्यू लेते हैं तो देश में, पूरे देश में 42 टेलीमानस सेल स्थापित किए गए हैं। और टेलीमानसिक स्वास्थ्य सेवाएं शुरू करने के बाद हमारी जो हेल्पलाइन नंबर है, उस हेल्पलाइन पे अब तक 2 लाख से अधिक कॉल प्राप्त हुए और उसका समाधान करने के लिए हमारी टीम ने काम किया। ये उपलब्धि है। किसी ने सोचा नहीं था कि डिजिटली भी हम जुड़ सकते हैं, किसी को मेंटली हम सपोर्ट करते हैं और उन लोगों से भी हम बात करते हैं। अगर सर आपके भी कभी टीम जाएंगी तो ये टीम से जरूर मिलना, उनके अलग अनुभव है। बहुत छोटी बातें होती हैं, लेकिन हम बहुत ही गलत, अलग तरीके से निर्णय पे आ जाते हैं। ये भी हमें सोचना है कि किसी को काउंसलिंग करते समय किस तरीके का ट्रेनिंग देना होता है। तो ये हमारी हेल्पलाइन के जो 2 लाख हमने मदद की है, नंबर पे कॉल आए हैं, तो ये भी एक हमारी उपलब्धि रही है कि कोरोना के बाद ये काम भी अच्छे से शुरू हुआ है। साथियों, जहां तक जैसे मैंने पहले ही कहा कि बच्चों के लिए, बच्चों का मानसिक स्वास्थ्य, इसके लिए भी हमारे मंत्रालय के साथ साथ, हेल्थ डिपार्टमेंट के साथ साथ अन्य मंत्रालय भी काम कर रहे हैं, जिसमें खास करके मैं कहूंगी कि शिक्षा मंत्रालय ने मनोदर्पण नाम से एक सक्रिय पहल शुरू की है। मनोदर्पण जिसमें छात्र, शिक्षक और परिवारों को मानसिक स्वास्थ्य और भावनात्मक कल्याण के लिए मनोवैज्ञानिक सहायता प्रदान करने के लिए गतिविधियों की एक विस्तृत श्रृंखला शामिल की है। मनोदर्पण पहल के तहत शिक्षा मंत्रालय की वेबसाइट पर एक वेब पेज बनाया गया है, जिसपे परिवारों के लिए मनोसामाजिक समर्थन के लिए क्या करें, क्या नहीं करें, इसको इस वेब पेज पर अपलोड किया है। मनोदर्पण के तत्वावधान में बच्चों के मानसिक स्वास्थ्य और मानसिक कल्याण पर नियमित वेबिनार भी आयोजित किए जाते हैं। जो भी यहाँ पे पेरेंट्स होंगे या फिर हमारे मित्र परिवार, हमारे रिलेटिव्स, उसमें ये बातें हमें बोलनी चाहिए, क्योंकि ये ऐसे वेबिनार में हमने सहभागिता लेना आवश्यक है। तो ये वेबिनार भी आयोजित किए जाते हैं। और इसी प्रकार हमारी मिनिस्ट्री ऑफ सोशल जस्टिस एंड एम्पावरमेंट के तहत हमारे दिव्यांग भाईजनों के लिए ये विभाग भी इसी दृष्टि से, क्योंकि वहां पे उनकी मनोभावना से जुड़े अनेक सवाल होते हैं। उनको यह फील होता है कि मेरे लिए क्या यह सुविधा नहीं है। तो ये मंत्रालय भी उस दिशा में काम कर रहा है कि उन्हें भी सहायता मिले, सहयोग मिले, ट्रीटमेंट मिले, जो भी सुविधाएं हैं उनके लिए वो देने के लिए ये काम करे। साथियों, ये बड़े दुख का विषय है कि मानसिक स्वास्थ्य समस्याओं वाले व्यक्तियों को अभी भी अधिकांश देशों में मानव अधिकारों का महत्वपूर्ण दुरुपयोग झेलना पड़ता है। इसे भी हम काम करें। देखभाल की आवश्यकता वाले लोगों और देखभाल तक पहुंच रखने वाले लोगों के बीच भी अभी भी बड़ा अंतर है। शिक्षा एवं रोजगार के दौरान भी मानसिक बीमारी को हीनता से नहीं लिया जाता है। ऐसी अनेक बातें हैं जो छोटी हो सकती है, लेकिन बहुत गौर करने वाली बातें हैं, जिसके कारण एक मेंटल स्ट्रेस के लिए शायद हम सोचते नहीं है, लेकिन वो स्ट्रेस क्रिएट होता है। तो ये छोटी छोटी बातें हैं जिस पे हमें काम करना आवश्यक है। इस कॉन्फ्रेंस के माध्यम से वो चर्चा मैं अपेक्षा रखती हूँ कि वो जरूर होगी। और यही समय है, दिस इज द राइट टाइम, कि जब हम जागरूकता को बढ़ावा देने पर ध्यान केंद्रित कर सकते हैं कि मानसिक स्वास्थ्य शारीरिक स्वास्थ्य जितना ही महत्वपूर्ण है। और इसके लिए हमें जस्टिस सर ने बिल्कुल सही कहा कि हमेशा हमें दवाओं के और एडमिट रहने की आवश्यकता नहीं है, संस्थानों में रहने की आवश्यकता नहीं है, लेकिन जिस तरीके से आज काम हो रहा है उसे भी गौर करना है। इस समय पेशे और सेवाओं के रूप में मनोचिकित्सा और मनोवैज्ञानिक परामर्श हमारे उभर रहे हैं, और हमारा मानना है कि मिलकर हम इसका मुकाबला भी कर सकते हैं। एनएचआरसी अपने स्थापना काल से ही वार्षिक पत्रिका मानव अधिकार नई दिशाएं इसका संपादन कर रही है, और जो एक बहुत ही सराहनीय प्रयास है। मैं उसका अभिनंदन करती हूं कि पत्रिका के माध्यम से देश में मानव अधिकारों का संवर्धन हो और संरक्षण, इस दिशा में संवेदनशील प्रयास किए जा रहे हैं, जिसमें इस पत्रिका का भी महत्वपूर्ण योगदान है। और जाते जाते मैं यही कहूंगी कि हमें समस्याओं का समाधान ढूंढते ढूंढते ये परिस्थितियां कैसे संभालनी है। ये सब प्रॉब्लम्स, ये सब इट्स अ पार्ट ऑफ लाइफ। मैं तो मानती हूं इट्स अ पार्ट ऑफ लाइफ, बट हाउ टू टैकल दिस प्रॉब्लम इज अ आर्ट ऑफ लाइफ। सो ये आर्ट आप लोग सीखोगे तो शायद ये समस्या भी कम आएगी। और इसके लिए आदरणीय प्रधानमंत्री जी ने अंतर्राष्ट्रीय योगा डे को कितनी अच्छी तरह से पूरे विश्व में फैलाया है। आज 150 देश में ज्यादा अगर योगा सेशन चल रहे हैं, मेडिटेशन हो रहे हैं, इसकी वैल्यू अलग है। हमारी संस्कृति हमें सिखा रही थी, सिखा रही है और सिखाएगी, और इसको हमें आगे लेके जाना है। हम अगर योगा मेडिटेशन के रोज के हम प्रयास अच्छे करेंगे तो शायद मेंटल स्ट्रेस को टैकल करना भारतीय लोग सबसे अच्छा, सबसे ज्यादा विश्व में संभालते हैं, ये मैसेज जाएगा। और इसे बढ़ावा देने की भी आवश्यकता है। हमारी आयुष मंत्रालय आज उस दृष्टि से उस दिशा में काम भी कर रही है। सर, कुछ योगा सेशंस डेली हमारे स्कूलों में भी लिए जा रहे हैं। एक बार मैं बहुत ही इंटीरियर में नॉर्थ ईस्ट में प्रवास कर रही थी, वहां पे हेल्थ एंड वेलनेस सेंटर था। तो जाते जाते मैंने गाड़ी रोकी और मैंने कहा बस 2 मिनट के लिए मैं देख के आऊं। वहां पे एकदम छोटे से शेड में कुछ महिलाएं योगा सेशन कर रही थी, और वो सारी सीनियर सिटीजन्स थी, कुछ 70, 75, 80, 85 तक की थी। तो मुझे इतना अचरज हुआ कि वो वहां पे रोज योगा करने आते। तो मैंने पूछा आप रोज करते हैं? तो बोले हाँ। और उन्होंने कहा कि पहले हम यहाँ के बैठते थे और जस्ट चिट चैट गपशप लड़ाते थे और चले जाते थे घर पे, लेकिन ये प्रधानमंत्री जी ने शुरू किया, ये करो, तो हम लोग करने लग गए। तो अभी अच्छा रिजल्ट मिल गया कि जो पेन होते थे, जो दुख होता था चलने में, जॉइंट पेन, तो वो नहीं हो रहे। ये रिजल्ट है। और उन्होंने उसको अभी एक गांव के समक्ष एक उदाहरण प्रस्तुत किया है कि हम कर रहे हैं तो आप युवाओं ने भी करना है। और वो सारी महिलाएं बड़ी खुशी से वो योगा सेशन चला रही थी, कर रही थी। कोई ट्रेनर नहीं था। पहले 10 दिन ट्रेनर आया, सिखाया, आसन सिखाए, उसके बाद वो खुद ही कर रही थी। तो मुझे लगता है अगर गांव-गांव में ये सुविधा पहुंच रही है, हमारा प्रयास पहुंच रहा है, तो जरूर हम इसमें भी कामयाब होंगे कि भारत एक दिशा दिखाएगा कि मेंटल स्ट्रेस को कम कैसे करना है। और ये ताकत भारत में ही है। ये विश्वास आदरणीय प्रधानमंत्री जी ने दिलाया है। हम जब हमारे वन अर्थ, वन फैमिली, वन फ्यूचर को देखते हैं, वसुदैव कुटुंबकम की भाषा को संकल्पना को परिभाषित करते हैं, मुझे लगता है कि हम मेंटल स्ट्रेस, मेंटल हेल्थ को भी उतनी ही अच्छी तरह से समझेंगे, उस पर काम करेंगे। और मुझे उम्मीद है कि हम सब मिलकर देश में जागरूकता के साथ साथ देखभाल के मानक को उच्च स्तर तक बढ़ा सकते हैं, और जिसके लोग हकदार हैं, उनका अधिकार है, और लोगों के उनके जीवन में मानसिक स्वास्थ्य के इस महत्व को समझने में हम मदद कर सकते हैं। फिर एक बार सभी को मैं बहुत धन्यवाद देती हूँ और वही पंक्तियां दोहराती हूँ कि सर्वे भवन्तु सुखिनः और सर्वे सन्तु निरामयाः। सर्वे भवन्तु सुखिनः मतलब सभी सुखी हो, और सर्वे सन्तु निरामयाः है कि सब रोग मुक्त रहो। धन्यवाद। जय हिंद, जय भारत।
Thank you, ma'am, for your insightful thoughts on the issues of mental health care and the steps being taken by the government in this regard. May I now request Mr. Bharat Lal, Secretary General NHRC, to please present the mementos to the dignitaries on the dais. First to the Honorable Minister. Thank you. May I request Mr. Lal to present a memento to the Honorable Chairperson. To the Honorable members, Dr. D.M. Mulle, a memento. Thank you, sir. To Mr. Rajiv Jain, Honorable Member NHRC. Thank you, sir. To our former member, Mr. Justice M.M. Kumar. Thank you, sir. Thank you. Ladies and gentlemen, there is always a person behind the planning, coordination, and execution of all such events. And in this context, I would mention the name of Mr. Devendra Kumar Nim, Joint Secretary NHRC, and request him to deliver the vote of thanks.
Thank you, Jamini ji. Honorable Minister of State for Health and Family Welfare, Dr. Bharti Parveen Pawar ji. Honorable Chairperson, National Human Rights Commission, Justice Sri Arun Mishra ji. Honorable Members of NHRC, Dr. D.M. Mule ji and Sri Rajiv Jain ji. Honorable Secretary General NHRC, Sri Bharat Lal ji. Honorable Justice, former member of NHRC, Sri M.M. Kumar ji. Honorable Chairperson and members of State Human Rights Commission who are present here, respected Additional Chief Secretary, Health Secretaries of States, respected mental health institutions, directors, HOD, professors of all the mental health institutions and private health institutions also, for example, Kadabam, Mr. Sandesh Kadabam from Kadabam Hospital, Bengaluru, and doctors and head HOD from Gangaram Hospital, from the Psychiatry Department, all the NGOs who are working in the mental health sector, all the CSOs and individuals working in the mental health sector, ladies and gentlemen, very good morning to all. I feel privileged and honored to propose a vote of thanks for this important conference on mental health, and which is named as Mental Health Beyond Institutions. On behalf, first and foremost, on behalf of National Human Rights Commission and all the members from the mental health fraternity present here, and state governments and SHRC, I express my sincere gratitude and thanks to Honorable Minister of State for Health and Family Welfare, Dr. Bharti Parveen Pawar ji, for her gracious presence and also inaugurating the conference. I also thank her and express my gratitude on behalf of NHRC to release the book and report on the mental health. I express my sincere thanks and gratitude to Sri Justice Arun Mishra ji, Honorable Chairperson, though he always says that he is the host, why you thank him, but I would like to thank for the guiding support, always motivation us, and from the speech, his speech, you can understand how concerned he is about the human rights and rights of others. फॉर एग्जाम्पल आई विल दो वो मुझको डांट सकते हैं बाद में कि क्या आपने क्या कहा, लेकिन आपको एक एग्जाम्पल आज का ही देना चाहूँगा. दैट्स व्हाई आई एम थैंकिंग हिम. Justice M.M. Kumar is the former member of, honorable member of NHRC, and because he has contributed in the book on mental health, he always, I think 8-10 times he directed me to invite Justice M.M. Kumar. Because he has contributed in the book, I forgot 2-3 times, but he always daily he was asking me whether you have invited, you have spoken to Justice M.M. Kumar, though he had already spoken himself to with Justice M.M. Kumar, but he reminded me again and again that he should be invited for the conference, for the inaugural session of the conference, and you can understand the concern of Justice Arun Mishra sir, Honorable Chairperson. I think I would request all for the great applause because I express my sincere thanks and gratitude to honorable members of the National Human Rights Commission, Justice Dr. D.M. Mule and Sri Rajiv Jain ji for motivating us, for guiding us to successfully conducting this conference. I express my sincere thanks and gratitude to Secretary General Sri Bharat Lal ji for motivating us and always guiding us to improve the quality of everything in office, in our official work. I express my sincere thanks to all the directors of mental health institutions who have come here on our request, and they will be participating all the 4 technical sessions, and we are confident that this conference will bring about some special changes and special outcome of this conference on the mental health sector. I would be failing in my duty if I don't thank media, print media and electronic media for coverage of this event. I also would like to thank all my colleagues, Sri Manoj Yadav, Director General, Registrar Law, Sri Sujit De, my colleague, Joint Secretary Madam Anita Sinha, all the officers and staff of the NHRC, and all young research consultants of NHRC, specifically who have contributed in printing of book, printing of report, and conducting of this conference. I would like to name three, 4 young consultants: Akanksha Sharma, Architi Batra, Dimpi Laskar, Sajid Mohammed, and all. Thank you very much. Thank you all.
Thank you, sir. Ladies and gentlemen, we will now take a break for tea and begin with the discussions in the first technical session after 25 minutes.
No, I understand.
Honorable Chairperson, National Human Rights Commission, to kindly take his seat on the dais and chair the session. May I also request Dr. Pratima Murthy, Director, National Institute of Mental Health and Neurosciences, Bengaluru, to kindly take her seat on the dais and co-chair the session. With the permission of the chair and co-chair, may I now request the 5 panelists in the session also to please take your seats on the dais. Mr. Rajesh Agrawal, Secretary, Department of Empowerment of Persons with Disabilities. Ms. Preeti Vaidya, Kinara Vruddh and Matimand Seva Trust, Pune. Dr. Jayati Simlai, Director, Ranchi Institute of Neuropsychiatry and Allied Science, Kanke, Ranchi. Dr. Neha Garg, Director, National Health Mission, Mental Health. And Dr. Sandesh Kadamams, Director, Kadamams Hospital, Bengaluru. May I request, ladies and gentlemen, to please maintain silence and keep your mobile phones in switch off mode or in the silent mode. We have already exceeded a bit of time, but nevertheless, I request the Honorable Chairperson, National Human Rights Commission, Mr. Justice Arun Mishra, to chair and conduct the proceedings of the session.
With the permission of the chair, I'd just like to initiate the proceedings for this very, very important technical session. In terms of opening remarks, let me say that in some ways my professional association with the NHRC is as long as my professional association as faculty at NIMHANS. Way back in the 1990s, the first report on quality assurance in mental health was actually commissioned by the National Human Rights Commission. I remember Justice Mallimat was the person who kind of pivoted the whole thing. And we actually carried out the first assessments of all the psychiatric institutions in the country. To put it in one line, it was as if time had stood still in these institutions. It was a very, very pathetic human rights kind of situation where there was so much overcrowding, people were locked up in cells, food was being pushed under the cell doors, people did not have any kind of private toilet facilities. There were a lot of jail-like, even worse than jails. Jails had improved, but the mental hospitals had not improved. So it was that kind of situation, and the report that came out of it actually catapulted into action after the Erwadi fire tragedy, where you will all remember that several people who were chained actually died. And then the Honorable Supreme Court took note of the fact suo moto and asked for these report proceedings and recommendations to be looked into. The decade that followed, actually again, with the active intervention of the Apex Court and the NHRC, there were a whole set of rapporteurs who actually went to certain state governments with the larger mental hospitals, not only interacted with the hospital administration, but also with the state governments. And certainly, they brought about various changes which were subsequently evaluated in another NHRC report in 2008, a decade later. And with that kind of oversight, with kind of monitoring that was happening, the resources, the financial resources to these institutions had increased, at least to many institutions had increased. The budget for food, sometimes it used to be as low as 8 rupees per day. And that was really very, very difficult to get any kind of food. So based on a caloric requirement, there were some changes made in the quality of the food and in the way the food was served. Overcrowding was reduced. In many places, uniforms had been discontinued and involuntary admissions had come down. There were better rehabilitation facilities. And this was conveyed, but it was also very clear that if there is no monitoring, there is a tendency to slide. Subsequently, in 2015, the National Human Rights Commission commissioned another report called the Technical Report, and this time it went down to the states. And when we went down to the states, because as we've heard that several developments that have occurred, the mental health policy, the Mental Health Care Act is in place, but when you actually went down to the states, even though there was a national survey, there was an inadequate understanding of the magnitude of mental illness, of the kind of resources that are available at the state level, but we only knew that certain innovations had been taken by some of the states to actually improve mental health care. Today we heard that in 738 districts, there is a district mental health program. So we have come some way in all this. The focus of shifting care outside of mental health institutions to also looking at mental health care in least restrictive settings in the community, in primary health care, has been a delightful shift, has been a very important shift, and of course, it comes with its own set of challenges. We have, as the Honorable Chairperson said, we have a very progressive Mental Health Care Act. In fact, the WHO in 2005 published a resource book on mental health, human rights, and legislation, which included a checklist of 175 specific items to be addressed in mental health legislation and policy. Our Mental Health Care Act addresses more than 50% of those items in the checklist. So that's very good. In terms of its conceptualization, in terms of the way it kind of dictates the steps to be taken, in the way it is rights-based and focuses on treatment in the least restrictive setting. But one must remember the origins of this act. Of course, we had the Indian Lunacy Act earlier, which was replaced by the Mental Health Act of 1987. But even several decades later, when a review was taken, the Mental Health Act, the provisions under the Mental Health Act had not been set up, even in 25% of the states 2 decades later. In contrast, we find that the pace of change has certainly increased with the Mental Health Care Act. So we need to listen to what is the pace of change, what has occurred. I know there is a status report on the fact of, where else it needs to go. So we will look at both the challenges in the provisioning and actually in the implementation of the act in both spirit and in actual action. We must also remember that these acts need to protect the rights of people, give them the rights that are due, but at the same time must not restrict access to care, must not make practice of mental health care treatment delivery restrictive in any fashion. The second thing is that the Mental Health Care Act came as a response to the UNCRPD, which was concerned with the rights of persons with disabilities. A few countries across the globe felt that people with severe mental illness needed care and protection in protective institutions, and it was that particular reason that actually drove the formulation of a new act. So now we need to see how is that doing the right kind of things for persons with severe mental illness who cannot make their own decisions. But with that come a whole set of challenges, right from the definition of mental illness to the professionals who will deliver care. Should we become restrictive and regulate care in all kinds of settings? Should we allow care to be reached by more people so that stigma can be reduced? How should we proceed in terms of constitution of the review boards? What are the complexities that state governments are facing? And of course, in terms of capacity to consent, advance directives, nominated representatives, what are the challenges? What are the needs of caregivers? Because in India, whatever else is said, the family is the primary caregiver to a person with mental illness. How can we support caregivers in this process? And of course, we will look at challenges in research as well. So if we can take a broad human rights perspective to the way we see the implementation of the Mental Health Care Act, define how we can make it promotive to access to care and less restrictive, I think, sir, whatever points you made in the morning will be fully served. Finally, as you said, how do you take care to the doorstep of people? How do you destigmatize mental illness? How do you improve care? Needs to be the major focus of the presentation. In that connection, may I invite the first speaker for today's session to take the floor. I now invite Mr. Rajesh Agarwal, Secretary, Department of Empowerment of Persons with Disabilities, to take the floor, please. I understand we're behind time, so I request all speakers to be very conscious of the time and limited to the time given to them. Thank you.
Thank you. Honorable Chairperson, dignitaries on and off the dais. I'm an engineer and a bureaucrat, so amongst the experts, I feel like a absolutely lay person. So my talk will also be on the same lines. Since centuries, madness and insanity, they were associated with a lot of superstitions and very cruel, inhuman treatment. But in 18th, 19th, especially after 1850s actually, the public discourse changed, the legal and health frameworks sort of improved, and we have seen more humanized systems develop. But even today, and the terminology changed from basically badness to mental illness, and now we focus more on mental health aspects. But in India especially, and a lot of other countries also, there is still stigma attached to this. You know, in government surveys, since many years now, when we turn 45, the government makes annual physical health checkup compulsory. And internally, we all are very happy about it that we are forced to do this annual physical health checkup. I am from Maharashtra cadre, so 8 years ago, one of our chief secretaries, who had earlier worked in health sector, so he said that from this year onwards, for IAS and IPS officers of Maharashtra, we'll do a mental health checkup also. You know what happened? The vernacular press had a field day. So Marathi press, the headline was, in many newspapers actually, की त्या IAS अधिकाऱ्यांच्या mental health checkup होणार, अर्धे वेडे निघणार. The translation is, half of these guys will turn out to be mad. And we were also actually worried in internal discussions that what kind of questions the psychologist will ask us, what will be the right answers. The psychologist says कि problem है हमारी नौकरी तो नहीं चली जाएगी types. So there is a stigma attached to it. So I am sure if the same question is asked to all of us in this room, get a free physical health checkup, all of us will say yes, why not? But if the same offer is let us all get a mental health checkup done, many of us will try to pull out of this. We will have internal hesitation. So there is a stigma attached to it. And depression these days is on the rise. Their society is becoming more stressful. And it can come all of a sudden. 4 years ago, my son decided to do MS in US after his BTech here. So I and my wife went to airport, Delhi airport. At night we left him at the airport. When we were coming back, just a notification popped up. So I saw his Facebook message. हम तो उड़ गए. That time maybe this song was popular amongst the youth. And comments from his friends that you are lucky you escaped and so on. Immediately it hit me. And just like an on-off switch, I went into full-blown depression. Absolutely full-blown. I would go to office, but I could not sit still for even 5 minutes and all. So here the family support is extremely important. So the family was extremely supportive, and my youngest nephew, 22 years old, he sort of became my mentor. He said कि मैं आपके साथ रहूँगा शाम को and so on. And after about 10-15 days, he basically told me कि फूफा जी इसमें कोई बुराई नहीं है, मैं आपकी साइकोलॉजिस्ट के साथ एक मीटिंग फिक्स करता हूँ. एंड ही टोल्ड मी कि मेरे बहुत से दोस्त भी फिजियो ये साइकोथेरेपी सेशंस में जाते हैं और उसका फायदा होता है. सो यंग जनरेशन knows about this much more than we do. But then luckily, in about 20 days, again it was like an on-off switch. Suddenly one morning I got up and the depression was gone. So it can hit all of us at any point of time. There's no absolutely shame in admitting this, and one has to take medication if required. One has to take therapy sessions if required. And frankly, the family support is extremely necessary. Here, basically, the family support helped me in avoiding medication and avoiding therapy sessions also. But if that is required, there should be no hesitation. That is where the society should move towards. And frankly, I said I'm a lay person, so I won't quote too much data because the doctors can then point out inconsistencies in my data. But I guess there is enough data now that globally as well as in our nation, amongst the youth 15 to 29 age group, the stress is on the rise, the suicides are on the rise, and that's where the helplines like the Honorable Minister was mentioning, Telemanas and others, they do become helpful apart from other things. I'm happy to see that NHRC has organized this and also made this conference very inclusive. I'm happy to see the sign language interpreter here. We have 21 disabilities in the country. So I'm only 9 months into this sector. It was very new to me. But I found that probably the deaf kids and the deaf youth, they find themselves most isolated amongst the 21 disabilities. They look normal. And so in the society, in the housing complex, lifts and parks, they don't face that discrimination. But they face a challenge of lack of communication. 2 months back, and we keep on doing that, so we organized a session of school kids and their parents, kids who were deaf and parents who were non-deaf, and teaching the parents some basic 100-200 sign language, basically signs. So I asked a 6th-7th year girl, 6th-7th class girl, and in sign language, through an interpreter of course, that her parents are being taught sign language, how does she feel? He said, बहुत अच्छा सर कि मेरे पेरेंट मेरे से तो बात ही नहीं करते, मेरे भाइयों से बात करते हैं, तो मेरे से बात करेंगे तो बहुत अच्छा लगेगा. Then I asked her कि should we teach sign language to your brothers? Then she said कि दादा को elder brother को मत सिखाओ, वो बेकार है. And she said छोटे भाई को सिखाओ, वो मुझे प्यार करता है, हम दोनों गप्पे मारेंगे. So even within family, the lack of communication, that really hits deaf kids very badly, and they do face more mental health challenges and more suicidal tendencies than others. So communication within family is the key, and then obviously within class and other society, but within family is the first thing. We issue now, there have been surveys, census and other surveys, national health surveys. So our data shows about 2.2% persons with disabilities in the country. The census data said that. WHO data, generally they say 5 to 10% in society. But a better indicator I have is the number of UDID cards issued. Just like we have Aadhaar, UID, we have UDID cards, unique disability ID cards. And we have issued about 95 lakh so far. About 4 lakh are with mental illness classification. In 21 disabilities, we have a different classification of what was earlier called mental retardation, now we call it intellectual disability. So MRID, and there is a category MI is different. So we have 4 lakh persons with MI diagnosis in our database. But our database has 95% people who have more than 40% sort of disability defined. So if 4 lakh is like full-blown cases, there will be multiple number of these as mental illness cases, but to lower degree in the country. So that's what the actual data shows. And hopefully by next week, I will be releasing public domain. We have data up to block level, so 750 districts and about 8,000 blocks in the country, 21 disabilities, gender-wise, age classification-wise. So I will be releasing those numbers in public domain by next weekend. We are just polishing those sort of data sets. And that will be very useful to many people in this room and outside also to do a lot of research on this, that which are the hotspots in the country where mental illness is increasing, sex-wise differences, age-wise differences, and so on. For example, the intellectual disability graph does show a strong relationship with areas where we have pollution issues, except even water pollution issues, etc. The data actually shows that. So similarly, the MI data will be very useful to a lot of people. I was looking at some US data, and the graph shows that 50 years ago in the US, 90% MI patients used to be in hospitals, 10% in prisons. Today the graph is reversed in US. 90% MI persons are in prisons, 10% in hospitals. Maybe it is how your health system and the health insurance system operates there. But despite being a developed nation, overall the whole legal and health framework can actually result in not so desirable outcomes. Frankly, we would like that more and more people stay at home and get treated. Those who cannot, they'll end up in hospital, and nobody lands up in prison. That should be the sort of best societal outcome. The mental health care issues are primarily health department issues, but we have, for example, in COR, our NIMHR is coming up, Mental Health Rehabilitation National Institute. So rehabilitation includes, obviously—
Sir, 2 minutes, please.
Yes, please. And the therapy and the counseling. It includes a lot of community involvements. It includes even yoga and meditation, occupational therapy, physiotherapy, and very important, skill and vocational training. Especially people who in adulthood suffer from MI, lose jobs, then it's extremely important in rehabilitation that again we make them productive member of society and the dignity comes back to them. Bringing back that dignity is very important. And frankly, that from my side, as I said, I will just tell you 2-3 stories, a personal story, and basically health department, us, I'm very happy the judiciary is taking a lot of lead in this. In this room we have state commissioners of persons with disabilities as well as human rights. So all of us need to work together to ensure that all persons who have mental health issues, they get the best of treatment, they get community involvement and family support. Thank you so much.
Thank you very much, Mr. Rajesh Agarwal. May I now invite Ms. Preeti Vaidya, Kinara Vriddha and Matiman Seva Trust, Pune, to address us.
Good morning, everybody. Honorable Chairperson, NHRC, Mr. Justice Arun Mishra ji, and honorable guest on the dais. I, Preeti Vaidya, founder trustee of Kinara Vriddha and Matiman Seva Trust, Ahirwadi Kamshet, I'm going to speak about challenges and implementation of Mental Health Care Act 2017. I would like to tell you that since last 14 years, we are running an old age home for mentally retarded and mentally challenged people, and halfway home since last 2 years. And today is the most important day for mental health because there are many challenges in implementation of the Mental Health Care Act 2017 will go by as follows. Nowadays, the ratio of mental illness is increasing day by day, so the challenges in the implementation of the mental health are also high. Let us see the challenges one by one. General awareness of mental illness. Commonly considering the mental illness is like a crime in most society and community. According to mental health institutions, halfway homes, there are lack of funds to implement the manpower and infrastructure. Rights to live in community, not to be segregated from the society, to provide support, including legal aid facility, exercising his rights to living in the family home for those whom it is not possible for a mentally ill person to live with his family or relatives, or where the mentally ill person is abandoned by his family or relatives. To provide the establishment of less restrictive community-based establishment, including halfway homes, group homes, and like person for who no longer treatment, restrictive mental health establishments such as long-stay mental hospitals. Practically, it is a challenge, as a separate halfway homes should be there with a separate trained manpower to take care of mental health patients. Appointments of non-qualified committee members, general body members who do not have adequate mental health education or proper education of mental health. Planning, designing and implementation programs for the promotion of mental health and prevention of mental illness. To plan, design and implement public health programs to reduce suicides and attempted suicides. Developments of human resources and trainings. Human resources requirements of mental health services by planning, developing, implementing education and training programs to increase human resources, improve skills to available human resources. To train all medical professionals in public healthcare establishments and all medical professionals in prisons or jails to provide basic emergency mental health care. Make efforts to meet internationally accepted guidelines for the number of mental health professionals on the basis of population. Mental health has remained to low priority. Priority should be given with the budgetary provisions. We should spend less than 1% on its total health budget on mental health. Manpower development, training programs, awareness programs to execute this act. Appointments of non-qualified and skilled should be avoided. It challenges. Right to get medical insurance for treatment of mental illness on the same basis as available in physical illness. Some of the states taken from the cold storage in 2016 as same non-controversial bills were required could be passed to improve legislative productivity. Immediate treatment to the mental illness patients who reside in rehabilitating halfway homes, etc. from the nearby mental hospitals. To fulfill the needs of halfway homes, etc. to treat the mental illness with psychologically. Support to caretakers and to plan or any training to the reduce their mental stress. Education to mental health patients such as they are human beings, not criminals. Finally, to give the best service treatment considering themselves as a gentleman halfway homes or rehabilitation centers needs adequate funds to fulfill their basic requirements. There are so many challenges to face, but according to my experience with these mental health patients since last 14 years, above the basic challenges, I think. Once again, I thank the National Human Rights Commission and the concerned organization to have the opportunity to contribute my small opinions. Thank you.
Thank you very much, Ms. Preeti Vaidya. May I now invite Dr. Jayanti Simlai, Director of the Ranchi Institute of Neuropsychiatry and Allied Sciences, Rinpas Kanke, to make her comments.
Which is the pointer? This is the pointer. No pointer नहीं सब slide change करना है तो. Okay.
Johar. On the rights of persons with disability in 2007. Now this new law, it is a major shift in the way mental health care is delivered and aims to protect and promote the rights of the people during the delivery of healthcare services. And one cannot be forced to receive treatment. A capacious individual with mental illness cannot be forced to receive treatment, and admissions can be independent or supported, which initially used to be your involuntary admissions. Next, state mental health authorities and mental health review boards will play an important role in this act. The first time in India's history, now Mental Health Care Act has been described as a right to care, unlike physical health care. Next. Now, in the definition of mental illness, where we talk about disorder of thinking, mood, perception, orientation, memory, impaired judgment, also as an effect of the drugs or substances that a person uses, but not mental retardation. Next. This definition appears to be restrictive because certain disorders like conversion disorder, phobia, panic disorders, personality disorders do not come under this. And as per MHCA, we are supposed to diagnose a mental illness as per the International Classification System or the DSM. So it's a dilemma whether to follow ICD-10 or should we follow MHCA. Next, the admission process, sometimes it is not possible to make a single diagnosis in a single interview. And for admission into a mental health establishment, we will need a regular observation and serial mental status examination, which is not available as per the law. Now, admissions to the mental health establishment is possible under 86, 88, 89, or 94. And sometimes, in order to stop progression, we could admit the person before and save from deteriorating. But this condition is not possible. With the new act, we have to wait for the person to deteriorate so that we can admit the patient then. Another is, suppose a person with mental illness who has severe depression, and in his advance directive, he writes that he doesn't want an antidepressant, he doesn't want ECT. So how do we treat him? We all know ECT. I've been in this field for last 28 years, and I've seen the role of ECT in the mental hospital setup, how it improves the status of the patient who has been suicidal, who has been refusing food. So this has helped remarkably and has shortened the time period. So here we are in a dilemma. What do we do? Now, treating a psychiatrist should be the clinician's judgment purely, which is not here as per the Act. Next, even when admission is involuntary or supported, we need to always look at the advance directive and consent of the nominative representative to assess the capacity periodically and treat. Now, it is time and resource consuming and hindrance to patient care and discharge of duties by the psychiatrist. When a person is admitted as per 89, I don't think there is a need to look into the advance directive. The board has a say in admissions, but the psychiatrist is only responsible for the discharge. The onus is on him. So what is the status of the homeless recovered patients? Where do they go? And who are the stakeholders? Next. Assessment of capacity. As per Section 81, the central authority has to appoint an expert committee to prepare a guidance document for assessment of capacity, which has not been formed in most of the places. Here, the person with mental illness may have capacity, does not want treatment, and the mental health professional cannot help him. And even after admission, even if he needs treatment, we cannot help him. Next. If a person with mental illness does not have capacity and if the nominated representative is not available, then a person cannot be treated, psychiatrist cannot help unless a nominated representative is appointed by the board. This will lead to loss of time, a lot of paperwork, adding to the problem of the already scarce resources and the valuable time in treating the patient. Next. Advance directive, it is difficult to determine whether a person with mental illness at the time of making the advance directive had the capacity to do so in the past. Also, we do not know whether it was certified by the psychiatrist at the time of making the advance directive. Next. Even if he did have the capacity in India, we are not sure how capable he is is capable of making a correct healthcare decision, and how many of them will conform to the standard guidelines of treatment, which is really debatable in India. Advanced directives can be revoked, amended, cancelled innumerable times. Is it really practical to implement? Next, nominated representative. One can never be sure about the intentions, education and understanding of the nominated representative. We have more of a rural population in India, and their capacity to act in the best interest of the mentally ill person. In our culture, responsibility of giving care to a person with mental illness is of the entire society, of the entire family, sorry. So if we just put the pressure on one single person to take care of the person, this will disrupt the family relationships, which is again a point to think for a long time. Now, next, person with mental illness can be admitted against his wish upon application by a nominated representative, and that can cause an anger or hatred towards the nominated representative, which is usually a relative. If the NR is not active in the best interest of the patient, then the person can apply to the board for revocation of NR. Now, this actually, in practical way, a psychiatrist should be given independent charge how to treat the patient, because the psychiatrist only knows what is the status of the patient. Because we are doing series of mental status examination, we are doing psychological tests. So he is in charge of the status of the patient. Next. Now, in case of persons with mental illness who have been staying in the hospital for a long time, they have regained the capacity to take decisions, and the request for discharge, family members will not take them. So how do we keep them safe outside the mental health establishment? Next, rights of persons with mental illness. Section 20 says we cannot subject to compulsory tonsuring. In our institute, we get many patients who are brought by police in a dirty, disheveled state with infections, cuts and wounds everywhere. And in order to treat them, we need to clean them up. So this is actually not feasible, whether to go for cleaning of the hair, the scalp or not, So we are in a dilemma. Then we also talk about the rights to wear a personal clothes. Now, in a big mental setup, RENPAS, where we keep more than 550 patients, anytime it extends to 600 also. So there, when we have a uniform, then there is uniformity, and we can easily identify the patient and prevent your escape and from suicidal attempts. If they are wearing their personal clothes because the other staff are coming in their ordinary clothes, it's very difficult to identify them.
Madam, 2 minutes.
Registration before issuing of mental health to the mental health establishment, they won't be inspecting physically, unlike the previous year where they were inspecting it physically. Now, ma'am, I would like a few more minutes because this is important, ma'am.
I know, but please speed up because everybody else has to be heard. The next session is also being heard.
Next, please. Section 78 says that proceedings before board are to be judicial. So any psychiatrist who has a mental establishment should appoint a lawyer, which is again costly. Next, offenses. Here, if a patient comes to a hospital, if it is not registered, then we can only treat the person for 72 hours. Then the psychiatrist in the dilemma to look for a hospital which is already registered. So whether he is going to treat or whether he is going to think of shifting, that is the thing. Now, next. Now in Jharkhand, the posts of mental health professionals and supporting staff which are vacant are being in the process of filling up, and it will be filled up soon. New posts should be created at the district level so that awareness, sensitization, training programs do not interfere in the routine OPD work which we are running in RENPAS, which is also being conducted. There are no mental health professional, excepting a psychiatrist, like a clinical psychologist or a psychiatric social work in medical colleges of Jharkhand. Next, District Mental Health Program, it was initially directly under supervision of RENPAS. Presently, we are increasing the coordination with the DMHP programs. There is lack of facility of issuing disability certificates in the district level, which needs to be addressed. All medicines that to be distributed should be available at the DMHP center. I think they are doing work on that. Next, halfway homes, a total of 17 Nari Niketan and old age homes are there in Jharkhand. The facilities are limited, and people who have recovered, they will be placed here. So, because they are usually not taken by the families, or they are brought by police and they have forgotten their name, their address. So such facilities have to be upgraded. Now, next, about the current State Mental Health Authority, which was formed in 2019, we have had several meetings. Nomination of the member from the Department of Law is pending. Rules have been modified. Draft of Jharkhand State Mental Health Care Rules, according to the suggestions of the central government, was approved by the Department of Health and has been sent to central government for approval and notification. Next, regulations. Jharkhand State Mental Health Regulation has been approved by Department of Health Personnel Administrative Reforms. Few suggestions were given by Legal Affairs, and corrected draft is submitted for further action. And the process is going on. Mental health review boards will be formed after the Jharkhand State Mental Health Care Rules are done. The website, we are in the process of renewing these certificates. Conclusion, next. The MHCA has a positive approach towards the rights of the persons with mentally ill. However, this act needs a revisit so that we can save time gap in treatment of the already available person with mental illness and make useful utilization of the resources. In future, the fear is that persons with mental illness who have right to refuse treatment and who have poor family support will become a risk and liability to the society and government, like the Western world, where we often hear about shooting in schools and in public. They are none but mental patients who have refused treatment. Thank you. Next.
Thank you. Dr. Neha Garg, Director, National Health Mission, Mental Health. Your comments, please, ma'am. Okay, enough space. Yeah, that's good.
A very good afternoon, Honorable Chairperson and Chair, respected Co-Chair Dr. Pratima Murthy, co-panelists and all the delegates who are here today. Keeping in view the shortage of time, I will directly start with my presentation. The focus I've kept is on the administrative structure and framework and the challenges that are being faced in implementation of a Mental Health Care Act at that level. So just to start with a brief features, we've all spoken since morning that this is a landmark act, and internationally also this is one act that covers the WHO or the international standards that have been set, and it is a right-based act for patients with mental illness. Considering the past history that we have heard since morning, I think the time had come for such an act where patients with mental illness are treated as individuals who have rights to decide their course of treatment. The positive features that are there in this act is bringing the concept of advance directive and provision for nominated representative. There are certain challenges that we see, as we heard also, with regard to that, but this is definitely a step in the positive direction. The definitions of mental illness, mental health care, and determination of mental illness have been, there has been an attempt to clearly define these concepts, which was again needed because there were different interpretations of these concepts. It also brings in the role of different departments of Government of India, Ministry of Health, Ministry of Social Justice, Ministry of Education, and also the other non-healthcare professionals such as police and judiciary into a collaborative setup for the working of this act. The restrictions that have been imposed by this act include forced sterilization, separation of mother and her child below 3 years of age, use of ECT on minors and on adults without anesthesia, psychosurgery without informed consent, and chaining up of individuals with mental illnesses. Next slide, please. The subordinate legislations that have been brought about at the central level by the Government of India under this Act include 3 sets of rules and 1 set of regulations that have been, the rules were formed in 2018 and the regulations in 2020. Next slide. The Central Mental Health Authority was constituted in 2018. The period of a Central Mental Health Authority is 3 years, and it has duly been reconstituted last year, and 5 meetings have been held till date. Next slide. The basic roles of Central Mental Health Authority. So Central Mental Health Authority is the nodal body that is implementing this act at the level of Government of India. So its responsibilities include registering of all mental health establishments that come under the ambit of the central government, developing quality and service provision norms for different types of mental health establishments under central government, supervising the mental health establishments under the central government, maintaining a national register of clinical psychologists, mental health nurses, and psychiatric social workers based on the information that is being collected by the state authorities. Then training of persons, again training of persons beyond those providing mental health care, including enforcement officials and other professionals with the provisions and awareness about this act, and advising the central government on all matters relating to mental health care and services. Next slide. Under the regulations that have been issued by the Central Mental Health Authority are the standards for mental health establishments. So these standards focus not only on the healthcare aspect, which is the infrastructure and the human resources, but also on the human rights aspect. It includes ensuring that the living conditions are comfortable, hygiene, cleanliness, and sanitation are maintained, there is proper floor space, equipments are procured properly, there is adequate number of health professionals who can provide proper treatment and who are properly trained. Similarly, usage of alternate methods in place of restraint to de-escalate crisis situation, protection of dignity of the patients, compliance of the mental health, the provisions establishment under the Right of Persons with Disabilities Act, provision of proper nutrition, provision of potable drinking water and comfortable surroundings, and also opportunity to experience cultural activities, recreational activities, and have time to relax and leisure. So these are the standards that we expect from mental health establishments that would be registered with the Central Mental Health Authority. Next slide. Now coming to the states. So this is an act which is enacted by the central government, but most of it is being implemented by the states. So in the states, we have the State Mental Health Authority, which is a very important aspect and very important part of the Mental Health Care Act. So similar to this Central Mental Health Authority, the State Mental Health Authority is performing the work of registering the mental health establishments that are present in the states and developing quality and service provision norms for these mental health establishments. They also supervise the working of these mental health establishments in the states. Another important job of the State Mental Health Authority is registering the mental health professionals, the clinical psychologists, mental health nurses, and psychiatric social workers who work as mental health professionals in the state, publishing the list of these registered mental health professionals, and then again training similar to Central Mental Health Authority, and discharging other roles as assigned by the state government. Next slide. Then the mental health review boards. These mental health review boards are envisaged to be formed at the level of district or at the level of cluster of districts, depending on the population. So these are again to be constituted by the state authorities, and their role is to register, review, and modify or cancel the advance directive. So we had questions about, we had some comments on what to do with an advance directive in certain cases. To appoint a nominated representative where it has not been appointed, then receive and decide on applications from a person with mental distress or his nominated representative in charge of mental health establishments. So if there is any kind of application or complaint against a mental health establishment, visiting and inspecting the person's with regard to these, the enforcement of this act. Conducting inspection and conducting of inquiry by the board for the protection of rights under this act, and imposing penalty if any violations are there. Next slide. So coming to the status, so present status, state mental health authorities have been formed in 25 states, which seems to be less given the 5 years. But with regard to the last act, this is more than what was formed within enactment of 5 years of the last act. Mental health review boards have been formed in 20 states. The state mental health rules have been approved for 10 states, and 9 of those approvals have come within the last 1.5 years. So we see that there is an awareness and there is a tendency from the states also to focus on this aspect. We've received 7 sets of rules in the last 1.5 years from the states for approval. Next slide, please. Now coming to the challenges. So what this act does, it gives us an ideal framework. But when we have frameworks, it takes time to set them up. So we have to set up authorities in all the states, review boards at almost all districts, and then rules have to be formed by the states. So this takes time. It is a time-consuming procedure, but I believe that if we spend time now, the results will be better later on. Then mental health establishment. So the ambit of mental health establishment under this act is very wide. There is a need to create this awareness about what comes under the ambit of a mental health establishment, to create the awareness that these mental health establishments need to register, and also that they maintain the standards. Then mental health professionals. Human resources is a very important aspect. We have human resources on the lower side in the field of psychology in India. But this act also very precisely defines these professionals. So any change that might come in would have an impact on who actually is a mental health professional. For example, the new education policy discontinued MPhil, which is actually a condition for becoming a clinical psychologist or psychiatric social work under this act. The same is under examination and under change, but as of now, that is how things stand. Then also registration, because some of these professionals are also required to register with their professional bodies. But when they're practicing as mental health professionals, they also need to register under this act with the state. The next is the intersectoral collaboration. So again, collaboration between state and center is a challenge, because every state, though we have a model set of rules that have been formed by the center, every state has certain specific needs that need to be seen and the rules to be framed according to that. Collaboration with the law enforcement. There are certain duties that are cast upon law enforcement officers by this act, so educating them about this act. Collaboration with Ministry of Social Justice through the halfway homes. Then there is also a need to ensure upward and downward linkages. So things do not end with tertiary care and with mental health institutions. Unless and until there is early diagnosis and screening of these patients, and after discharge, they go back to a community that is receptive, that is supportive, and the medication and the treatment at home continues. There is no use of having the best possible institutes as well. In fact, internationally, there is a tendency to go back from the tertiary towards primary and secondary healthcare in mental health, integration into the primary healthcare, and actually decreasing the number of beds in tertiary care. Lastly, as you're all aware, stigma and lack of awareness. So families are not receptive, caregivers are not aware of their roles, community is not accepting. So awareness about the act, awareness about the rights of the individuals with mental health cases is very important to actually, efficiently and effectively enact this. So these are the challenges with regard to this act, but I would like to say, as I mentioned, that integration with primary and secondary healthcare is extremely important. We heard in the morning that we have 738 districts where care is provided for psychiatric issues at secondary care. But also there are 2 initiatives of the Government of India which are very important for ensuring these linkages, for ensuring community support, for reducing stigma. Next slide. So first is the Ayushman Bharat Health and Wellness Center, which is the unit at the lowest level, at the primary healthcare level. Earlier, mostly it focused on reproductive and child healthcare services, but since 2018, the services have been expanded to include mental health care services as well. So it plays the role of involving the community and spreading awareness. So screenings can happen at the community level, referral can be done in time, and follow-up of the patients who are discharged and are present in the community. There is also availability of teleconsultation with specialists close to the home so that the patient doesn't have to travel. They also can distribute drugs that have been prescribed to these patients at tertiary care centers. So the drug list is maintained, and our community health officers stationed at these sub-centers can actually dispense drugs to the patients while they live their homes, in their homes in community. And as Honorable MOS stressed in the morning, focus on wellness. Yoga sessions are regularly carried out in these health and wellness centers. Next slide. The second initiative is the National Tele-Mental Health Program, Telemanas. So it brings mental health care right down to your phone. You have, even when you're in your house, you just have to dial a number and you get connected to a professional counselor. And if need be, the case can be escalated. If it's a serious disorder, it can be escalated to a mental health professional. And we can see that since 10th October 2022, in fact, I checked today in the morning, we've reached 210,000 calls as of date. Next slide. This is just to show the Telemanas calling mechanism. There is a number that you call on, you get connected to a counselor, and if need be, you get connected to a specialist through eSanjeevani, which is something that is in process, or you are directed towards in-person services at your district mental health unit or at the tertiary mental health institutions. So that is it. Thank you so much. Yeah.
Thank you, Dr. Neha. The last speaker for this session, Dr. Sandesh Kadabam, Director, Kadabam's Hospital, please.
Good afternoon to all. Good afternoon. My respects to the Chair, Justice Arun Mishra, Honorable Chairperson in HRC, the Co-Chair, Dr. Pratima Mukti Ma'am, Director NIMHANS, dignitaries on the dais and off the dais. Can I have my slides up, please? So, while I was invited to be one of the speakers and in this event, and I said to myself, there is something that I have to introduce. Amongst all you stalwarts, high-ranking officials, secretaries, professionals, I think there's a little that I need to introduce Kadabams and introduce Sandesh here. I'll just spend a minute here. Kadabams has been in existence for the last 30 years. We've run various mental health centers, facilities, programs. It ranges from preventive and promotive mental health, as Mind Talks. We have the hospital, the halfway houses, the addiction centers, now supported living as well. All of this started because it was a need within our family. So we actually are a family. The one that you see in there is my aunt, who did not get the help back in the late 90s of what the inspiration was. But what really shaped up, while that stood as our inspiration, what really stood up is the advent of professionals from day one in Kadabams. The first employee happened to be a licensed psychologist as Ms. Saraswati. To that of in 1997 to 2009, Dr. S.M. Channabaswana holding the fort as our medical director, and then there's been no looking back. So we've gone on to build various programs, build various facilities. Next slide, please. Today, we have the opportunity to operate our centers in Bangalore, in Hyderabad, and we're also partner service provider for the whole of the Maldives. Next slide, please. Coming into the theme of the challenges in MHCA implementation of MHCA 2017, I'll bring in a very honest perspective as a private mental health establishment to this gathering today and to this panel. I believe there is a lot that a lot many more private mental health establishment providers who are in there, who are delivering services in various forms out there in this country. I would like to give due credit to the Act. It's a very it's proactive. It's got the framework of one of the best around the world. We go back to any advanced countries around the world, this Act's very, very similar. So it's got the right framework. Now with, I have just highlighted the three key takeaways that to me are, what the Act stood out for is the mental health establishment. The recognition of mental health establishment and the functions of mental health establishment is rightly recognized in this Act, which is the clarity on the admission and how the admission procedure needs to be followed. The support system in rendering the services of mental health, though services like the MHRB, I'm sure it's in evolution. I did hear the co-panelists talk about certain restrictions and it needs to evolve, but I presume that there is a structure that is in place. I now like the fact that there is going to be audit of services and not just licenses that we have to go after. And finally, it gives us an opportunity to report everything that has happened in the month, in weeks, depending upon the scenarios that is, in the format such as, namely the restraints, the sectioning, and the minors admission. And it's been of a great boon for the patients who are informed, patients who are self-seeking for help. Their rights are codified. There is clarity to their advance directives and the nominated representatives. I do again recognize and emphasize the fact that it's an evolution. I mean, we will evolve. The Act has just come in, and I'm sure that will take place. ECT and the other aspects of the cases are more explicit and verbalized. To me, I also feel it is a clarity for the implementing agencies. There is systems, there is procedures. I will throw light on it as I go into the other slides as to where I see its prominence. Next slide, please. While it does help family and professionals, I want to bring out a few concerns and dwell into it as we go along in the other slides. It may come across as a bit of a repetition with respect to family, as it's been spoken at breadth by my other panelists. I personally believe the family is not recognized while they play an integral role in our country. Our social structures are still very intact. It's just not here. I believe so. It's around in any eastern part of anywhere in the east of this world. The family structures, they play a very important strength. And the Act somewhere does not give support to families who are wanting to help their loved ones to seek treatment. I assume with the state rules and the different modes and types of treatment being recognized in facilities, there is going to be some more clarity to this. But I did want to bring out this concern for this panel. Professionals. I think psychiatrists already did mention this, and I echo the similar views. Today, psychiatrists are made as the face of many aspects of the violation of this Act without actually providing them the support system. And this, the Act has probably taken away the confidence for the professionals to focus more clinically and then look at it mostly from the legal aspects, the documentation. It is quite challenging. And I could tell this with confidence because of my training in the UK, and I'd seen this in the early parts of 2008-9, working in NHS administrative roles. There is immense support given to the professionals where similar act is in place, where the professionals have a great support. And here, I feel the professionals are left to fend for themselves. So which should throw in some clarity as we go along. Next slide, please. I'm breaking down the implementation challenges. On my left, everything that I mentioned is a due recognition of the proactiveness of this Act. And it's a blessing to see psychiatric emergency being recognized in MHCA 2017. When we initially launched Psychiatric Emergency Helpline in Bangalore, in 2017, we were questioned what is psychiatric emergency helpline to, what this really would mean. But to see it being recognized, it's a real blessing. But the challenge is, of course, is not everybody understands what psychiatric emergencies are, where you have to look back at the support of the police or the agencies. It's limited. So there's no organized support system. And 108 is truly ill-equipped to handle psychiatric emergencies, and we don't really expect them to be the forefront seekers. How have we mitigated this? We've mitigated this with PET. PET is our reference to psychiatric emergency team, which is a constitution of a psychiatrist who's the head of the treating team, with a clinical psychologist, psychiatric social worker, a psychologist, and an admin representative. We have the admin representative and the nurse to ensure that we have to do the documentation between the police stations because we are a private service provider. So this is how we have overcome these challenges, but as it gets defined, as many officials in the society are informed, I think there would be an ease. Mental health services is a recognition because the mental health establishment and mental health services, I presume, is going to be a positive. Like any other general healthcare sector, I think private mental health service providers is on the rise, and there is a significant contribution from the private mental health care service providers. The acts and the agencies we would like to see it a little more less restrictive and supportive as we go along. But there's always a need to collaborate across with partnerships and the governments. Next slide, please. Nominated representatives, I'm not going to dwell too detail because this has already been brought up. My reference here is family cannot be considered as a party with some sense of suspicion. Families do play an integral role. Families do need to be involved in the treatment as we go along. But today, the nominated representatives does not explicitly mention it, as there would be a need for clarity, especially for individuals with the acute and the subacute nature of illness. Next slide, please. Mental Health Review Board is, here's again a personal experience being a member of the Mental Health Review Board in Karnataka for the Bangalore and the Mysore districts. Of course, today the scope of our board spans out into about 17 odd districts there, but there are appointments from multiple other mental health review boards. I feel I'll emphasize on the first point here. Understanding the roles and responsibilities of the board as in the Act is interpreted by individual boards differently. As we see we've been fortunate enough to be one of the first few boards to be set up as being part of Karnataka in India, but then the point is there is a need for formal training for the board. So there's this common interpretation and the common delivery of the service. I think the common checks and balances that could be in place. Next slide, please.
2 minutes.
Yes, ma'am. Here's the hope. I would say there is a need for continued care. There is emphasis to this. There is care beyond hospitals, and that is true. We have seen that in our halfway houses. We've seen that in the assisted living spaces. We've seen that in our community living spaces. The structured, less restrictive community living is going to be the way forward for certain individuals with different natures of illness. And in continued care, I would like to draw attention to the need for community order. The community order would play a critical role, especially for individuals where there's so much emphasis on community-based treatment. But if there is no guidelines of how these individuals have to live in the community, be compliant to medication, be primarily because of their insight or lack of insight, and the rest, we are only staring at a very difficult situation with more disability because of just the community-based treatments. The need for innovation in care, I'm a strong believer of the fact that there has to be something in between the custodial care to that of community homes, step down, skill enhancement, a community that houses, that gives people to explore what they wish, really not want to explore, just live along. I did not mention, but we're also in the due process of building homes where family members with the individuals can also live along. So, it's really about building communities. And finally, the last one, I really would look for help, and it's a request on behalf of every individual with mental health condition. There needs to be something done about the employment for these recovered individuals with mental health problems with certain sense of issues, because it's not easy to get jobs, it's not easy to place them and partner them. It's been an ongoing challenge. The next slide, please. One final reference here. The addiction and mental illness, the Act considers psychiatric illness in people with addictions on similar grounds. The issues to me are totally different. The requirement to, and the treatment approach, the recovery, reintegration for people with addictions is totally different from what it would be for persons with psychiatric illness. I would have loved to delve a little more into this. For paucity of time, I'm not going to do this, but I feel this is one area that we as private mental health establishments would need certain clarity, and we will, we're following in line with how it is being laid out right now, but as more clarity comes in, it's going to be only better. Next slide, please. As a personal personal experiences of stigma. I think stigma stays not only just for recovering individuals, it's also there for mental health professionals and people like us who deal and we work with mental health, in this field of mental health itself even today. So we've destigmatized it. I'll draw reference only to one of it, which is called Mind Talk. So we say Mind Talk is there in schools. With schools, what we've built in is a school mental health curriculum which engages children from the younger age groups to first grade to the 12th grade and made emotional wellness a way of life. We've been able to pick up many more instances, situations which would have ideally not been picked up if it's just a counselor going into school. This is done in partnership with the CNTW Trust of the NHS UK, who's a nodal agency for the school curriculums there. And we do have events, so we open it up for mental health and LGBTQ, mental health and music, mental health and movies. These are communities that we're building within the society where they feel therapy, treatment is a lot more accessible. Thank you very much for your kind attention. Thank you.
Thank you very much. We've had very, very insightful comments by our five panelists today, ranging from stigma and the importance of addressing stress, the importance of family support, to training, to budgetary provision. So what stems from all these five panel discussions is that the framework of mental health care is far beyond what the Mental Health Care Act addresses. It needs to focus on positive mental health care, support and care to people with stress, and only limit the use of institutional care, which inevitably is necessary in any society. We've discussed everything from definitions of mental illness to the setting up of the Central Mental Health Authority, the State Mental Health Review Board, to support for carers who look after patients with mental illness. There appear to be a whole host of challenges for the care within institutions, to treatment orders, to monitor care and support in the community. These challenges perhaps would need to be identified in a proper manner, arising from what has been discussed. And perhaps we need to have a plan of implementation, both with government agencies as well as in a consultative framework, to see how many of these provisions can be made again to facilitate care and support rather than be restrictive. And I believe that this should be done in a time-bound manner so that we don't have the same problems that we had. It was also very good to listen to a lot of new innovations, and it's important, I think, to provide feedback and course correction to what needs to go ahead. One of the colleagues also mentioned insurance, and I think that's another very important area which need to be looked at in addition to supporting caregivers. The chair tells me that we can take at the most 1 or 2 questions before we wind the session up. So if there are any pressing questions anybody would like to ask with respect to challenges and implementation of the Mental Health Care Act. I see one hand at the back, sir. Please introduce yourself, and the other hand here.
Hello, madam.
We'll take the hand at the back first, sir.
Hello, madam.
No, I had a hand there.
Yeah.
Yes, please.
Ma'am, this is Dr. Rahul Saha. I am an associate professor in Safdarjung Hospital. Regarding the implementation of Mental Health Care Act, since we are in a tertiary center, we are having serious mental illness patient and who are mostly resistant. So what we are facing problem is person basically who are teenagers. Since after COVID, the depression has increased and most of psychiatric illness are before this mental health care, we were able to give ECTs to the young teenagers, and now it's serious mental illness. It has been restricted, and we are not able to use that, and which results in more delay in the treatment and more poorer prognosis. Since we know that mental illness early onset has poorer prognosis, and not giving proper treatment actually worsening their symptom. So not giving, we are by restricting a particular mode of treatment which has been proven to be very beneficial, is actually increasing the stigma of that treatment. So first thing. Second thing, in this mental health care act, there is no provision for discrimination by any employer for who removes a person for mental illness. Because in our Safdarjung Hospital, what we are having that a lot of people come for treatment, mostly in the corporate sector. I'm just giving one example. One of our patient was had an episode of depression, and he is a pilot in Indigo Airlines. And the Indigo people have actually sacked him. They told him that until you are taking treatment, we cannot allow you to fly. And he has not been getting salary, and he has been continuously coming over and so there's no such provision for discrimination. We talk about the human rights of people, but when we remove a person from a job, and it leads to a more human right violation. But there is no such provision in Mental Health Care Act against the penalization or any such kind of benefit that has to be given for their discrimination of the mental illness. I strongly believe that a treated depression is far more safer than untreated depression. Because we don't penalize the authority, then what will happen that people who are actually suffering from depression and any mental, they will not seek treatment. So these are the 2 points I was providing. Thank you.
Thank you very much. So we had another hand here. Yes, please.
Thank you, ma'am. My name is Ranjan Dwivedi, and I am a special rapporteur with the NHRC. Now, there were two small issues I want to raise. See, all interventions, they have a cost implication. And in a resource-constrained situation, you always have to weigh interventions vis-a-vis the cost implication as also the ease of intervention. Now, ma'am, I also went around with the Honorable Chairperson and separately, independently, to hospital. What I realized is, there's an excessive thrust on medication and, simple things like medication, yoga, and, which when I talk to doctors privately, they say that they probably have a much larger role in addressing these things because the issue of medicines in mental health is very unsettled in many cases. And it causes huge problems, dependencies and so on. So one is this, that low cost, easy to implement measures where you don't need too much technology, we have ample manpower, like yoga, meditation, all that. I mean, that needs to be emphasized a lot more than is being done right now. And the second thing was, which I mentioned in my report also, that you see, the moment you call these institutions mental health institutions, when a person is carrying a bill, Mansik Chikitsalaya, he or she can never get out of this mental bind that there's a problem with me. So these institutions should just be called wellness institutions, and this, they use the word mental health or Mansik Chikitsa. I mean, there has to be some alternative nomenclature. Otherwise, a person will always be stuck over there. And you go to any city, you ask them, ki Mansik Chikitsalaya, acha, Pagal Khana? Haan, wahan pe. So at a very, very gross macro level, I think, we probably need to take a big stride away from what's being done right now. Thank you, ma'am.
I just got reminded of a French quote which goes, plus de change, rien de change. The more we change, the same things remain. So I think these are questions that societies kind of grapple with over generations, and I think we need to constantly revisit them. But I thank you both for pointing out both the complexities in some of these areas, because it's not very, very simple when it comes to the treatment of severe mental illness, including, for example, something that the chairperson mentioned, The right to remain in an not to remain in an institution is something that the chairperson mentioned. But if there are no good facilities in a community and the person wants to stay in an institution, that itself can be another very complex situation. So, and I think the point that there are simple strategies that we need to first, take and make sure that we implement in the continuum of care is also very critical. So thank you all very much. There's no time to take further comments, but I'll hand it over to the chairperson to make his concluding remarks.
Because we are running out, we have already run out of the time. We may make just few points. One, the states where state health authorities have not been constituted, I request that those states, persons, their representatives from those states are here to constitute it at an early date. At least we have 3 such states. Review board, 8 states have not constituted. Rules and regulations have not been framed, except in rules are probably in 4 and regulations in 3. So we are not on the implementation. We have not yet started the implementation of the act, provisions of the act, which is the best act in the world. So we have to focus on this. Some rules are pending for approval for the central government, some states have pointed out, or regulations are pending. I request central government authorities to process them in case they are still pending, because our data was collected little 5-6 months ago. There might be some progress in this. And then registration is a must, was pointed out rightly. How many institutions are registered? Let us verify for ourselves. How many are government hospital or central institutions are running without registrations out of this? So that is one issue. Halfway home is a mandate under section 19. Community healing is a right and halfway home is a right. Person cannot be detained for even a single day as per mandate of section 19. Otherwise fine comes automatically. It is penalty provision is there for violation of the act. And for that we have not constituted the requisite bodies, and then halfway homes are a must. It is not very difficult to have halfway homes for these hospitals which we are running, because they have lot of land, lot of property. Then legal aid is also must for family reunion. Except 9 hospitals, there is no legal aid provision made out of 47, of which we have collected the data. And then there is a need for cooperation between the Jharkhand, Bihar and Bengal. I was told that Jharkhand refused treatment of Bihar patient only on the ground that Bihar government has not remitted the amount to the concerned hospital to Jharkhand. This is not a good situation. This is a sheer violation of the human rights. Merely that government has not contributed the money, we cannot refuse a human to be treated or send them back to their state. It was a report came to us that we have sent the Bihar patient to Bihar. It's not good. So we have to take care of the situation. Such a good act and such a scheme of Deen Dayal scheme of 2018, which has been formed by the central government, it still remains uncomplied with. I fail to understand when central government is ready to give the money for halfway homes. What is the hitch for these hospitals and the state government to utilize that fund? Made available by the central government. Why every hospital should not have halfway homes? We can have that. It's a matter of, taking a step. It's not a halting place. We are on the stepping stone today. Let us take a jump and implement this. This is the purpose of why we have collected here. So I congratulate all the speakers, particularly for a school program. I will share with him what they are how they have formatted it. we want that it should be little emotional health of a student should be taken care of. There's so much burden put on the students, and unfortunately we feel pleasure only in putting burden and emotional stress on our children by sending them to the school which are not actually bothering about their emotional stability and their rights. Probably so much burden is not there in British entire British Empire today, which burden is there in on the Indian children, you see, at the primary level or lower, less than primary level, you see. Let them grow up. Let them have emotional stability. Let them not become a rack. Let them not be computers. Let them be a thinker, scientist, and innovative to make innovations. Thank you very much.
Thank you, sir. May I now request Mr. Manoj Yadav, Director General Investigation, NHRC, to please present a memento to the chair and co-chair and the panelists of the session. Please. Dr. Pratibha Murthy. Mr. Rajesh Agrawal, Secretary, Department of Empowerment of Persons with Disability. Ms. Preeti Vaidya. Dr. Jayati Simlai. Yeah.
An opportunity to talk to Harsha.
Thank you, sir. May I request all the panelists to kindly share their papers with us. And with this, we come to the conclusion of the first technical sessions. We now begin with the second technical session. The theme is infrastructural aspects and human resource of mental health establishments, way forward. The duration of the session is about 1.5 hours. May I request Dr. V.K. Paul, member Niti Aayog, to kindly take his seat on the dais as the chair of the session. Humble. May I request Dr. V.K. Paul, member Niti Aayog, to kindly take his seat on the dais as the chair of the session. May I also request Mrs. Preeti Sudan, member Union Public Service Commission, Member Niti Aayog, who is the chair of the session, has guided the country in dealing with COVID-19 and the various challenges the pandemic brought with it, particularly those impacting health. Mr. Sudan has earlier worked as the Secretary of Union Ministry of Health and Family Welfare and saw through the preparations dealing with the COVID-19 pandemic. Now, I hand over the microphone to the chair and the co-chair of the session to take the proceedings forward.
Thank you very much. Good afternoon, namaste. Honorable Chairperson of the National Human Rights Commission, India, honorable members of the NHRC, distinguished panelists on the panel, distinguished invitees, participants representing academia and the societal cause of our nation. I'm truly honored to be here. The importance of mental health has been stated and restated in this meeting today. We will look at an important aspect related to ensuring optimum, high-quality care of individuals with mental health issues and problems. I'm joined by Madam Preeti Sudan. I've had a great association with her, working together as team, and I would like ma'am to drive the discussion, and I'll be very delighted to come in the end to sum up and give some of my personal ideas and reflections. Over to you, ma'am.
Thank you, Dr. Paul. Where is the button for this?
The black one. I think behind the flower.
There's none here. Okay. Right. So, Honorable Chairman, NHRC, Honorable Members, and thank you very much for calling us. And it's an honor to be here, especially with Dr. Paul. He's always guided us in health ministry and done a yeoman service to this country. I have a very distinguished panel here sitting on my side, some old associates, some new. And to the distinguished audience, I would say that welcome to this session. So 2-3 things I'd like to say. Since, we have overshot time, let's just stick to the 5 minutes allotted. In fact, let's try to stick to just 3 minutes each. Why I'm saying is because let's not repeat what has been said earlier. We've been talking, we've heard, actually Dr. Paul and I came together, we heard the the speakers of the last session only, but I'm sure all of you who've been here have heard them. So let's not try to repeat. So from my side, I just want to say that, let's concentrate on our topic, which is infrastructure aspects and human resources in mental health establishments, way forward. Now, the infrastructure aspects and human resource issues have already been highlighted by the last 2 sessions. So what could be the way forward? And the complexity has been brought out by the previous speakers. You see the complexities of multiple needs of mental health patients, of, setting up of the Central Mental Health Act, of various bodies that have been envisaged in the Act. Then the very good, I think, the District Mental Health Program, which is part of NHM, which Neha spoke on briefly. What I would like to say is that how do we move forward? Let's concentrate in this session on this aspect. So we would like to hear from the panelists on how, transdisciplinary framework could help, integrating the various, I would say, Ayurveda, homeopathy, Siddha. How do we strengthen primary health care? The health and wellness package envisages 12 services. Mental health is one of them. How do we integrate that? How do we sensitize, caregivers, frontline workers, families, youth clubs, say ASHA workers, locally trained volunteer? Should we have them? Yes, if you, Dr. Paul will recall, and I would like to take great pride that it was, in just a matter of weeks that the government actually they made IGOT services available for COVID volunteers, for doctors, so we were able to retrain everybody. So why not include the mental health module also here? Let's talk about that. Then mainstreaming emotional learning in school curriculum. One of the previous speakers did speak about it. Now we already have health and wellness ambassadors program in schools. It's already there, but we need to emphasize that. Giving visibility in political agenda, why not? Having Gram Panchayat on mental health issues. Beti Bachao, Beti Padhao scheme we started with Gram Panchayat on the issue. Using technology, of course, we have, Telemanas. Let's go forward on peer learning. And our Nimhan's former director, Gangadharan, has done great work in it, so he can speak about that. So this is something we'd like to hear. Now over to the first speaker. I would invite Mr. Arun Singh, Additional Chief Secretary, Department of Health, Jharkhand, to kindly share his views, please.
Good afternoon, dear friends. Dr. V.K. Paul, Mrs. Preeti Sudan, Dr. B.N. Gangadharan, Dr. R.K. Dhamija, Dr. Hemant Datta, Dr. Shivraj Bali, Dr. Rajesh, Honorable Chairman of NHRC, my dear friends. Let us go to the presentation. So this is basically focused on the infrastructural aspects and human resources. I will be making a presentation regarding the present status and what we intend to achieve. Next. Next, please. So basically, infrastructure and human resources comprise of the mental health service delivery mechanism, which is strengthening and upgrading of the existing mental hospitals to center of excellence. We have RINPAS, as Dr. Jayati Simlai has already presented. Then strengthening of the mental health training for expanding the community-based services, working towards destigmatization of mental health. Then the issue of budgetary considerations, and unfortunately the funds under the National Health Mission for Mental Health Program have been reduced. So that needs to be addressed, though the state government has increased the budget as far as the state support is concerned. Then how to enhance the mental health workforce, as has been discussed, the mental health workforce. We don't have competent and experienced manpower to handle these mental health issues. Then how community resources needs to be mobilized to engage the community through awareness and mental health stigma and the myths. We have in our state a lot of stigmatic practices, Dayan Pratha, Chudail Pratha, so that needs to be addressed. Then how to integrate with the primary health care and health and wellness center, as Dr. Mrs. Preeti Sudan was focusing on the health and wellness centers and the yoga kendras and the introduction of Ayush in the health system and enhancing the operations under the Ayush. And then the issue of mental health research, because that is one area which needs more focus and involves different stakeholders, including policy makers, practitioners and advocacy groups. Next. So the psychiatric setup is basically physical infrastructure, human resources and other issues. And as is, you can see on the slide, this physical space and then sustainable and eco-friendly institution, pharmacy and specialty services, digital medical records, how to increase the human resources, how to increase the PG seats, We had a discussion in Dehradun also on that issue. Dr. Paul was there. United Registry Portal for all the psychiatric and mental health co-workers. Integration of telemedicine. Government of India has started Tele-Manas. In the state also we have started the services. I would be focusing on and informing you about that initiative of the state government also. And then the portal for knowledge and research. Other issues involve the institutionalization process, vigilance and follow-up of discharged patients as elaborated by our Honorable Chairman, regarding the patients who have got well but they are still in the institutions and they need to be sent back, but there are certain issues involved in sending them back, since one doesn't know about their addresses, even they have forgotten their names also. So it is a big challenge for us. Despite that, we are under the process of rehabilitating them, sending them to halfway homes or Nari Niketan. And then the community support system for the rehab patients, and the stigma attached with the mental patient when he goes back to his house, and the social taboos which restrict and which are not welcomed by the family members. Next, please. The physical infrastructure, as I have already mentioned regarding the physical infrastructure, this also involves the skill development rehabilitation centers. Next, please. Next. Human resources. India is currently short of 27,000 doctors in this sector. So how to increase the number of PG seats and reserving certain number of MD seats in those states with grossly inefficient human resources. United Registry Portal for all psychiatrists and mental health care workers, providers can present a clear picture of the status of human resources available. A portal for knowledge and research work, as I've already intimated regarding the need for the research in this sector. And then integrating the mental health program with the telemedicine like Tele-Manas and other ways of using the information technology to enhance the mental health services by enabling the remote consultation and therapy sessions for patients in remote locating. Next, please. The management of human resources way forward, basically reallocation of health staff for expanding of mental health services, upgradation of skills, recruitment and training, mental health specialists to work in collaboration with general health workers and provide them with the supervision and support, and multidisciplinary approach in collaboration with community organization and integration and adoption of new technologies, as I have already mentioned. Next, please. So basically, when we move in this beyond institution, vigilance and follow up the discharged patient, because once we discharge the patient, then he needs to be closely followed up so that what is his progress and how he is doing in the normal atmosphere, normal climate, normal life. Then rehabilitation of discharged patient at the community level through the halfway homes and Nari Niketan, community support system for the rehab patients, and create comprehensive support network and promote early intervention and prevention strategies by forming partnerships, collaborations with community organizations, schools and healthcare, and create community-based responsible group for neutral health. And in this, the presentation done by the Bangalore group was perhaps very, very useful, and I would like them to come to our state also, and we would like to involve with them. Next, please. So this is basically the RINPAS, the Ranchi Institute of Neuropsychiatry and Allied Sciences. Next, please. So we have started, instead of just a mental, when we talk about mental health camp, then there is a stigma with the name itself, mental health camp. So we have given a new name, Tanav Mukti Shivir. So Tanav Mukti Shivir we are organizing on every Saturday in all the CHC and the district hospitals. And they have been very, very positive results of Tanav Mukti Shivir. And we are involving the students also. We have started a concept of stress managers in the Shyama Prasad Mukherjee University in Ranchi. And 30 such stress managers have been trained and given certificate by the RINPAS so that they can de-stress their peer groups. And then the camp outcomes, as mentioned they are collecting feedback and experiences from participants, assessing changes in stress levels and mentally well-being, and identification of the areas for improvement in future camps. Follow-up and aftercare is very, very critical, so that the person who has been advised and given the consultation doesn't fall back into the same trap. Next, please. So this is a platform for sharing experiences which can reduce mental stress, because mental stress, basically what we are feeling is mostly located in urban areas where we have industrial issues, where we have the employment issues or the educational issues or social issues which are more in the urban areas. So we are focusing in our urban agglomerations which are having dense population, which are big, like Jamshedpur, Ranchi, Dhanbad, Bokaro, Hazaribagh, Devghar. So these places we are focusing so that we can take care of them, though such issues can crop up in the rural areas also. And how to increase awareness about mental health, we are dovetailing the mental health program along with RINPAS, along with the state government support, so that we can build up, and how to create awareness through the IEC activities, through radio jingles and posters, pamphlets, and understanding of the stress management and strategies for coping with daily life, and building a supporting community network for long-term mental health care. Their peer group, the students, our professors, our doctors, they are already being trained for this handling the mental issues. And we have also in the RINPAS, we have the rehabilitation camps in which we go for skill upgradation, please. Skill upgradation of the person who are in the RINPAS institute, so that and we have opened their bank accounts, so that whatever they produce gets deposited in the bank account, and when they get well, then that they take back their bank account. And you would be pleased to know that certain patients have earned as much as 10,000 rupees. So that is a matter of happiness for them. And we have we had 300 such patients who had become well, and out of those 300, we have already dispatched 262 patients back home after great effort, because a lot of such patients didn't know even their name.
Half a minute, please, Dr. Arun. Yeah. Sorry.
So I'm already going to complete it. This is the last slide. Next, please. Next. Yeah. So these are the rehabilitation and skill upgradation. So stitching, weaving, pottery, they are all involved in these activities, and they are making good things. And we are trying that the government purchases such items which are required for government purposes. So that is what I had to say as far as the human resources and the infrastructure was concerned. We will be waiting for the remarks and the question and answer session. Thank you very much.
Very rightly, you have pointed out on need to address social customs and prathas, have contextual strategies. I'm sorry that I am insisting on time because we are 1 hour late. And what I'll do is I'll just tap my pen to give advance notice to the speaker. And I now request Dr. R.K. Dhamicha, Director, Institute of Human Behavior and Allied Sciences, Delhi, to please give his address.
Good afternoon, everyone. Honorable Chairperson, Professor V.K. Paul, and Co-Chairperson, Madam Preeti Sudanji. Honorable Chairperson, National Human Rights Commission, and members NHRC, distinguished panelists, academicians, psychiatrists, friends and delegates. It's really an honor and privilege to be here to share our experience and our model of IBHAS. IBHAS, as you know, there was a discussion earlier in the session that Mansik Chikitsalaya and Manorog Chikitsalaya and the mental words should not be there in the hospitals. So, thinking that in mind in late 80s and early 90s, the institute, the mental hospital Shadra was renamed as Institute of Human Behavior and Allied Sciences to destigmatize the word mental health, so that people can be freely access these facilities at the hospital, which is a clinical based academic institution. So obviously that was something kept in mind by our predecessors, and the name Human Behavior and Allied Sciences. It's not only in Delhi, there's an institute in Goa also. and there's institute other mental hospitals also in the similar lines. So I'm happy to share that this concept was earlier taken up in Delhi, the Hospital for Mental Disease Shahadran. Next slide. So, outlining next 10 minutes, I would be touching upon the current status of human resource and mental health infrastructure in India. Then I will discuss about the IBHAS model for mental health care beyond institutions, as is the theme for today's conference, the moving mental health beyond institutions. What are the issues and challenges and what are the way forward? I also have a 2-minute video to show the audience about the IBHAS model of taking mental health care to the communities at the level of communities and as well as the schools. Next slide. Next slide. So, what is the human resource as of now today? If you talk about the world distribution, the high-income countries had 12.7 psychiatrists per 100,000, the upper middle 2.1, lower middle 0.5, the low-income country 0.1, and in India we have only 0.55 psychiatrists per lakh population. This is a figure data, published data from the WHO. So that is where we are today. The shortage of, the psychiatrists and the mental health professionals. Ideally, we should have at least in the middle income, upper middle income countries, and at least 2 per 100,000 population. Next step. Next slide. So talking about the total numbers, absolute numbers, we have around 9,000. This is Indian Psychiatric Association figures. Present ratio is 0.75, 0.55 to 0.75. We have around 1,000 new psychiatrists coming up every year. The ideal would be, as I mentioned, 2 per 100,000. How many we need more annually? This is around this is 27,000 shortage. And how much time will it take? This is 17 years, assuming there would be incremental in the number of seats in DNB as well as MD psychiatry. Next slide. Next slide. So this is a very favorite slide of Professor Paul also. Where are we today? MD Medicine, if you think about 418 colleges and 5,000 seats. MS Surgery, 4,700 seats. MD Psychiatry, only 1,326 seats. And that also has come up recently in last few years. Next slide. So institutes, 47 including 46 plus including IBHAS 47. The bed strength, less than 1.5 per 100,000 patients. Mental health nurses, 0.166. Clinical psychologists, 0.047. And with now discontinuation of MPhil in clinical psychology, we are going to have acute shortage again. Psychiatric social work, 0.033 per 100,000. Patient also need in totality, apart from this mental health care, we also need holistic care, the social and rehabilitation needs. So that is something we have to look for this. As we talk about human behavior, there is a difference in social behavior and a civic behavior. We Indians are very good in social behavior, but very poor in civic behavior. So that's something which we need to improve upon. Next slide. So in terms of what we actually need is 3,200 clinical psychologists, 4,000 psychiatric nurses, 3,000 psychiatric social work. Total number is around 117,000 and shortfall is more than 100,000. And what we are doing is around 500 each, psychiatric social workers, clinical psychologists and psychiatric nurses. So that is a huge gap. And with the treatment gap of 70 to 80%, this gap in human resources is enormous. And that is humongous, and we need to work on this to have that kind of a shortage filled up. Next slide. So the act has already been talked about since morning, and that mandates all of us to work to implement this. And IBHAS is also doing its bit in implementing this. Next slide. So we can't escape without talking about the mental health care budget in India. So this is out of the total budget allocated, 0.8% are direct expenditure on mental health. Resource allocation of 40 crores for the states for a total of 738 districts now in very, very grossly insufficient, and that needs to be increased up. Additional funds have to be mobilized to ensure availability, accessibility and affordability of mental health care for the masses. Next slide. So now I'm talking about the IBHAS model of taking the mental health care to the community. Next slide. So this is one of the largest neuropsychiatric care services in Asia. So we are actively involved in DMHP as well as our own mobile mental health unit. We have innovated MMHU network across the 11 districts of Delhi. We also run clinics for the homeless, mentally ill population like in Jama Masjid. We also have, as the Honorable Chairperson was alluding, that each mental health institute should have a such halfway home or long stay home in the hospital for the persons who have been cured and not required to be in the hospital. And we are the first hospital mental health institution which was given accreditation for NIBH. Next slide. So Dr. Neha Garg alluded to Telemanas. So IBHAS is very active in that. We are playing the three roles. One is, of course, the cell for the Delhi state. We also are the regional coordinating center for 5 states, which include large states like Uttar Pradesh, Uttarakhand, Himachal Pradesh, Gujarat, Jammu Kashmir, all these things in addition to Delhi. And we also are a mentoring institute for many of the centers providing services under Telemanas. Next slide. So this is a model halfway home or a long stay home at IBHAS campus running for last 6 to 7 years. Next slide. So this is our mobile mental health unit, which has 11 ambulances and more than 40 mental health care workers, which are providing service at the doorstep for rescue as well as for the shelter and bringing them to the hospital if required. Next slide. We also have started lately a school mental health initiative. This is a pilot project involving 20 government schools of Delhi, where our mental health counselors are providing service, and if required, the children are counseled and the professional help is provided in the school by IBHAS. Next slide. Now talking about a couple of slides around issues and challenging. There are only 3 centrally run mental health institutes in the country which are directly run by the central government. Most of the central health institutes do not have adequate staff inpatient beds. That has already been covered. Next slide. So there is a need for continuous training in clinical psychology. Unfortunately, the MPhil has been stopped temporarily, but we are working to change the nomenclature and get back to the tweaking of the act as well as restarting of the course. The community alternative models like IBHAS needs to be integrated, and within the infrastructure of mental health institute inside the hospital, the HR and the infrastructure should be provided, increasing the budgets for the sound and the equitable distribution of resources in all at the national level. Next slide. So, madam, this is a 2 minutes video to show the IBHAS model as the theme of this conference is there. Can you sound, please? With that, I'll take leave. Thank you very much for your kind attention.
Thank you, Dr. Saab. We all acknowledge that IVAS is a model for compassionate, sensitive mental health care. And thanks for pointing out how guided community care and school initiative needs to be in place and how it can be replicated. Of course, human resource requirement and budget is a huge constraint. I now request Dr. V.N. Gangadharan, with whom we have worked a lot, and he's I would say, an authority on mental health. Presently, he is National Assessment and Rating Board President. Over to you, Dr. Saab.
So, respected dignitaries of the National Human Resource Commission and the two colleagues of mine who are chairing, with whom I have had the good fortune of working together, both as the director of NIMHANS then and now, of course, as the president of the assessment board in the National Medical Commission. For sake of brevity, I would like to avoid using the slides. The slides are available on circulation in the group. It has to be very short, and Madam has told me that not to take more than 3 minutes. For each minute,
sorry.
For each of the minute, I am flagging one issue. There are 3 issues I am flagging in this for actionable points related to the theme that we are talking about. Both the Honorable Minister and one of our colleagues from the audience alluded to the fact that yoga has to be a very important contributor to wellness, and more so in the management of mental disorders. And NIMHANS has had a time-tested model of utilizing the evidences that are available for practice of yoga for care of the psychiatric patients. And a substantial amount of research has also happened, both in terms of treating the patients, helping the caregivers, and developing biological models for demonstrating the effects of yoga and so on and so forth. It has established a yoga center with which as many as about 50 patients in the outpatients benefit every day, and many of the inpatients also benefit from the yoga services. And it has now grown on to become an integrative medicine department. Why I am alluding to this is some 2 years back, under the chairmanship of our current director, Dr. Pratima Murthy, a meeting was held with all the mental health establishment of each of the states, and close to about 20 of them participated, and a workshop was held how to integrate yoga into the healthcare services of mental health establishments, and a protocol was written up, and how much would be the expenditure if you are going to add mental health services in mental hospitals, and how many would be willing to participate in getting it established if funds are available, and so on and so forth. A good discussion happened, and I'm sure one of the joint secretaries of the health also was there in that meeting. And at the end of it, a protocol was written. I am sharing it with my colleague, Dr. Vinod Paul, for taking it forward. And approximately a budget of about 10 centers that said they would get it started, and close to about 35 lakh rupees per year is what they were expecting to be able to get this for the entire year for each of these hospitals. So I'm sure this is one issue where I want an actionable point, that yoga to be integrated in mental health care services, which could be recommended from this group. The second point is, which also was alluded to, relates to the human resources. In all the mental health establishments run by the state, we have close to about 45,000 beds, of which we would possibly be using about 25,000 beds for purposes of training, teaching, producing human resource, whether it is psychiatrists or otherwise. By virtue of my role as the National Medical Commission's one of the presidents, I know there need to build human resource, and one of the factors is to utilize clinical material, and we know close to about 20,000, at least 15,000 beds in many of the state-run mental hospitals are not being used for any human resource generation. And this is something that could be another actionable point, that all psychiatric hospitals run by each of these states should be able to have a provision developed with whatever may be the resources available. I'm sure my colleague Dr. Pratima Murthy would be willing to get this thing guided in a way in which NIMHANS, which was a mental hospital, went on to become a premier psychiatric training institute. And this conversion could make a lot of human rights changes and care of the patients in the hospitals. This is the second point I'm alluding to. And the third point is Telemanas has been rolled out. Telemanas is an excellent platform for training and as well as providing services to all the subjects. And my previous colleague, Dr. Damija, mentioned in his slides that there are close to 1,250 postgraduates trained every year. And of course, this is in psychiatry, but of course in other fields as well, psychologists, social workers, and somewhere, some places also psychiatric nurses are being trained. It is imperative today, there is a need to have telemedicine training to these people. And Telemanas can be a good platform which should be exploited by the people who have been putting it into use. I'm again appealing it to Dr. Pratima Murthy and Dr. Naveen, who is actually the person behind, Professor of Psychiatry at NIMHANS, who is the person behind running these Telemanas services and all over the country. So here is an opportunity. Every MD student in their second year or third year, depending upon how you're going to be working it out, at least a 15 days to 2 months posting, which is a virtual posting. He would still be doing all his or her clinical work, but at the same time receiving all these calls escalated from the triaging group of the Telemanas services, which gives both a person who is available for service, and also this person actually gets trained in telemedicine in respect to mental health services. So in summary, take home message on 3 actionable points. One is introducing yoga in psychiatric hospitals. There is a way forward, and the document I have shared it with Dr. Vinod Paul. Second is developing training programs in mental hospitals where at this point of time the beds are not being used for producing human resource. And third point is using the telemedicine or the Telemanas platform to augment the skills that are to be introduced into all the psychiatric trainees, and of course psychologists and social workers were required. With these 3 points, I thank the organizers for letting me in, and the slides are available. More details are of course can be shared. For sake of brevity, I have stopped using the slides. Thank you, madam. Thank you, sir, for letting me speak in.
Thank you so much, Dr. Saab. And very well pointed out, wellness in healthcare is almost non-negotiable now. Yoga and meditation needs to be mainstreamed, and the need to tap unused beds to increase PG seats, and of course that every MD student should be posted in the Telemanas cell. It will be a win-win situation both for the patient and the student. Thank you very much. Now I request Dr. Kshitij Bali, Honorary Finance Secretary, IMA, to please share his views with us.
Thank you. I would like to thank the National Human Rights Commission to invite us, IMA, here in this particular conference. A special thanks to our chairperson, Dr. V.K. Paul, and co-chairperson, Mrs. Preeti Sudhat. Ma'am, I'll stick to the point because I would be mainly speaking about, IMA, the role, what we can do in helping the government to achieve the goals. And also about doctors, like what problems we face, especially with mental patients and the infrastructure aspect. So a lot of things are going to be repeated. Can I have my slides, please? The next one. So what we feel is the ground reality. Mental health can affect every stage of life from childhood to adolescence, adults and old age. In India, there are 3 psychiatrists per lakh population. We have around 10,000 psychiatrists in our country of 140 crore population. So there is a gross disparity between the number of doctors available and the number of patients who are going to be there. So we think that around about 2,500 to 3,000 psychiatrists are needed annually. As per WHO statistics in India, only 10% of the people with mental disorders receive any kind of treatment. There are 43 mental hospitals there in the country with a combined bed strength of 20,000, so it's grossly less as compared to the number of patients who are going to be there. 85% of the mental health is still provided by the private sector. There are 398 departments of psychiatry in various medical colleges, so we need to increase the number of seats here so that we can, stop the fill up the gap. So what are the problems of infrastructure and human resource in mental health establishment? I'll go very fast because we don't have so much time, and it will be a repetition also. There is insufficient resources and funding. One of the primary issues is lack of adequate resources and funding dedicated to mental health services in hospitals, especially private and government both. This leads to understaffing, limited facilities, and reduced capacity to meet the growing demand of healthcare. So we can't give healthcare with limited resources. We need to improve them. Limited access to specialized care. Many hospitals, especially private, lack mental health units, resulting in patients not receiving appropriate care from mental health experts. The lack of access can contribute to longer waiting time, delayed treatments, and reduce overall quality of treatment. Stigmas and lack of awareness. There are stigmas surrounding mental health issues. They are labeled as pagals, which often, I think the mic is gone. The stigma surrounding mental health issues often discouraging individuals and their families from seeking help and aggravating the problem. Addressing this is paramount. There is inadequate training of healthcare staff, especially paramedical staff. So healthcare professionals, especially those outside the mental health, even we are not aware of mental health issues which we might be facing in our patients. So sufficient training should be given to recognize and address mental health concerns effectively. This can lead to misdiagnosis, inappropriate treatment, and missed opportunity for early intervention and help. Overcrowding and lack of privacy. Hospital environment can be overcrowded, especially private, chaotic, lack in privacy, which can exacerbate the patient's mental health situation. So creating dedicated calm spaces for mental health care is essential for patient well-being. Outdated facilities and technologies. Some hospitals have outdated facilities and technologies which hampers the delivery of modern evidence-based medicine health treatment. Upgrading the infrastructure and adopting innovative technologies can significantly improve the patient outcome. Integration of mental health and physical health care. Many hospitals' mental health care remains isolated from other medical services. This leads to fragmented care of mental patients with comorbid conditions. So you can have a patient who's got a cardiac element with depression or with psychosis also, which we as practitioners would not be knowing. So integration of mental and physical health services is crucial for comprehensive patient care. Lack of follow-up and aftercare. After discharge, patient often faces challenges with accessing follow-up care. Realizing this issue is vital to prevent relapse and ensuring the smoother transaction from hospital to a community care. So what are the solutions which we think are? One is increasing the funding and resource allocation, which is a must. Establishing dedicated mental health units, training and awareness programs, especially for paramedical staff and even for us who are not actually doing, again, we're not dealing with mental health patients. Patient-centric designs for healthcare by creating private spaces for mental health care patients. Technology integration by upgrading hospital facilities with modern technologies which improve healthcare services and patient outcome. Collaborative care models by implementation of care models that integrate mental and physical health services. Continuity of post-discharge care and access to a follow-up service after discharge is paramount. Telehealth, as already mentioned, government is doing exceptional work. So we would request them to help us out so that the private sector can also get involved in this. Crisis intervention unit. Dedicated crisis intervention units within mental establishments can provide immediate support to individuals facing acute mental health crisis. Yesterday itself in Gangaram Hospital, we had a mental patient of depression who stabbed a neurosurgery doctor in the private OPD. So we as doctors would request that, something like this should also be taken care of. Safety of doctors, especially who are not trained, who are not into a mental hospital, should be, of paramount thing. Accessibility, ensuring accessible facilities for individuals with disabilities will promote inclusivity, healthcare design, and create a welcome environment for all patients seeking mental health services. So physical infrastructure means building design. So mental health establishments should be designed to create a healing and safe environment for patients. They should be equipped with appropriate amenities, comfortable patient rooms, recreation spaces. Safety measures, again I talked about, ensuring safety of the patient is crucial. Adequate measures should be taken to prevent self-harm or harm to others, including careful planning of facility layout. installation of security systems and regular risk assessment. Accessibility. Mental health facilities should be easily accessible to people from all walks of life, especially all those who've got physical disability. So technology, I would not be mentioned because electronic health records are already there, so which can be utilized, and cross references are easy to be done for these specific patients. Next slide, please. Next one. So where do we stand? IMA, Indian Medical Association. So we are an association which is the largest representing organization of modern system of medicine in India, founded in 1928. We are having a membership of more than 4 lakh doctors spread over the entire country. We have 1,760 local branches in almost entire district of India. We are actively involved with the central and state governments in implementation of various social medical schemes like anti-tuberculosis, pulse polio immunization programs, promotion of organ donation, promotion of blood donation camps, antimicrobial resistance, medical ethics, National Initiative for Safe Sound, Committee for Elderly, Committee for Disaster Management, playing a crucial efforts in fight against child sex abuse, HIV control programs, IMA Safe Child programs are there, Safe Motherhood, Stop Sex Selection projects, and Charter Protection Skills, especially for patients who complain about hospitals and treatments which are there. So IMA has educational wings like IMA CGP, College of General Practitioners, Academy of Medical Specialties, in which fellowship courses are provided by us to members to serve the community. IMA can collaborate with the government in spreading awareness and knowledge via such programs, especially in mental health. So we can be helped there. So these wings can also publish information, materials, and educate people regarding mental health and stigmas, thus reducing the stigma around the mental health. IMA is running, several paramedical courses. We are doing diplomas in medical labs, X-ray technicians, OT technicians, medical record, cardiology, dialysis, blood banks, courses in CT and MRI. So IMA can also train paramedical staff in the field of mental health, so that these people can actually help you guys and the society in treating these patients. Next slide, please. So I'll just flip through the next one. So these are our projects. Aao Gaon Chale, 1,700 branches. We adopt one village, and regular health awareness is given under IMA monitoring. Vaccinations, anemia is taken care of. Health camps are being given. More than 1,040 villages have been adopted by IMA. We have more than 20 lakh people who have already benefited from this scheme, so we can be beneficial with the government in case we are invited by offering our services there at the village. Next one. So COVID management, the services and sacrifices of doctors throughout the country was appreciated by none other than our Honorable Prime Minister. So we had around about 2,000 doctors who martyred and who gave up their life during COVID. So we had a corona helpline across also, and we have launched a social counseling also. So for this, like if we can do this, we can do a lot of work with the government. So I assure you, in case the government invites us, we would be help in trying to do this for blood donation camps. So we do blood donation camps, and around about 1.20 lakh units of blood has been collected till date and donated to the various government schemes also, and to the various blood banks also. Next slide. For tuberculosis control, so we were partner with the governments for eradicating of tuberculosis. So we already conducted more than 10,000 CMEs, 100 workshops across the country. We have synthesized and trained more than 234 doctors to help us and the government in treating these patients, especially in the villages. So we have been closely working with the government, and we are a partner with the government to end TB. So Save Child and Motherhood, already we are working on that. Please, next slide. Next slide. So Save the Child, sex abuse, we are doing active work, what we can do to promote this. Antimicrobial resistance, next slide please. Next slide. So we are imparting knowledge, next slide. Next slide please. So we are giving knowledge to our doctors and to other paramedical staff when, where and how long to use the antibiotics. So this is another work which we have been doing. Next one. So we were, for polio eradication program, I have played a pivotal role in eliminating polio in 2014. So we also were a part of the government initiative to end polio. HIV control in the late 90s when HIV and AIDS, next slide please. Yeah, okay. In the late 90s when HIV and AIDS were a big challenge to the society as well as the modern medical facility, we came in and we took the initiative, and with Bill Clinton Foundation, we really helped the government and the society in trying to educate the people about HIV, and so that we were also a part of it.
Right.
Next slide.
Thank you, Dr.
So there are other national initiatives which we've been doing: Safe Sound, organ donation, and road safety and awareness. So I promise you that in case we are invited by the government to help them in the mental thing, so we would be there. Thank you.
Thank you. So thank you, Dr. Bali. You raised very rightly the issues of inadequate staff and inadequate training, lack of privacy and outdated technologies can definitely affect healthcare and follow-up. And of course, collaborative care model, telehealth for private sector, crisis intervention units, creating healing and safe environment for both patients, doctors and caregivers are very, very pertinent points. And I personally feel, having worked as health secretary for nearly 3 years, that IMA help is quite indispensable. And I take this forum to also say that you did exceptional work during COVID. So thank you. And now I invite the next esteemed panelist, Dr. Hemant Datta, Deputy Director, Regional Institute of Mental Health, Tezpur.
Honorable Chairperson and members of NHRC, Honorable Chair Dr. B.K. Pal, Member Niti Aayog, and Honorable Co-Chair Mrs. P.T. Sudan, Member UPSC. I would like to request to display my PPT. Yeah. So the topic given to me was infrastructural aspects and human resource of the mental health establishment way forward. So I belong to an remote place of Assam. It is Tezpur. So although it is a remote place of Assam, but in case of mental health care services of India, this place is very relevant because it has an oldest lunatic asylum. One of the oldest lunatic asylum was established in Tezpur in the British era. Next. So I would like to cover a few aspects in my presentation. That is, the history of the LGBTMH still holds a space today in today's discussion, because we have learned today that it is very difficult to predict future, because COVID has taught us that we cannot predict what are the infrastructure, what are the human resources we will require in future. But if history, we know our history, then we can somehow up to some extent, we can predict what are the future requirements. So I will also try to, as I belong to the northeastern states, I would also like to state you a few challenges specific to northeastern states, and the adequate use of upcoming technologies, and the vision plan of the next 15 years, that is the LGBTS model. Next. So these are the few pictures which are taken in around 1980s. The institute was established, the lunatic asylum was established in the British era in Tezpur in 1876. It was governed by at that time by the jail manual, and the asylum, the patients of the asylums were in very bad shape at that point. Next. So there was the patients were at that time were meaningfully utilized at this phase. They were used in various cultivations, paddy, sugarcane, vegetables, dairy products produced by the inmates. Next, please. So there are a few pictures of the old buildings and the facilities available. The very right upward picture is the oldest ECT machine we had. And the chair is just showing that it was used for the hydrotherapy. That is, the water was poured over the patients to heal the mental illnesses at that time. A few old abandoned buildings we have at present. Next. So these are the intermediate phases for a few photographs. Next. So these are the isolated cells of at that time. A few hospital wards. These are the next. These are the laundry and kitchen setups at that time. Next. So these are the timelines of the LGBRMH, which is an institute under Government of India now. So it was established in 1876. In 1995, Honorable Supreme Court of India ordered transfer from the Government of Assam to Government of India. In 1999, it was taken over from the Government of Assam by the NEC under Ministry of Donier. In 2007, it was transferred to Ministry of Health and Family Welfare, Northeastern Division, and in 2010, it was transferred to the Ministry of Health and Family Welfare, Mental Health Division. In the last 10 years, that is from 2012 to 2018, the institute has seen its major transition, mainly in the infrastructural and the human resource aspects. Next. So three basic changes that has been changed in this institute. First is infrastructure, I have already shown to you. Then next is human resource aspect. At the asylum phase, there was the supervision was the main component at that time. We had warder, then we had keepers, we had dhubi, kind of posts were present at that point. Then intermediate phase come, then where a few medical posts are allowed to the institute, that is medical superintendent. And now it is the modern phase where academic posts are allowed to are granted to the institute. It's functional, I have already seen that it has traveled from asylum to super specialty care, and policy it was initially it was custodial care to now it is open hospital setup focusing on the rights of the mentally ill person. Next. This is the current stage, a few photographs of the institute which has shown the state of art infrastructure at the institute have at present. Next. So this is a few photographs of the present time indoor. Next. 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 So the need of integrated infrastructure and facilities, what should it contain at present time? We feel that first thing is that an institute should have some important infrastructures like comprehensive rehabilitation center it should contain. First is it should have psychiatrists, counselors, psychiatric social workers, clinical psychologists, occupational therapists, physiotherapists, special educators, orthopedician, pediatrician, ENT specialist for diagnosis and training to make the patients optimally functional and relocation and rehabilitation of the recovered patient. The rights of the mentally ill persons to be at the prime importance in these infrastructures. Then we need some previous slide. Yeah. So today the relevance of super specialty services come. And infrastructure should contain the services, super specialty services. Then technology oriented services should always it should have. My previous speakers have already stated the importance of telemanas, then telemedicine, WhatsApp video calling, message reminders, helpline, etc. Up to date infrastructure should contain. We need to have collaboration with the NGOs and up to date facilities and machineries for research opportunities, and community clinics, wellness hub, and satellite clinics we should have. Next. These are the specific challenges specific to northeastern states. Although we have some positive aspects, like abandon rates are less in the northeastern states because it has a strong social support system, and traditional healing system works as a parallel system in northeastern states. So although we have a few challenges like cultural and socio-economic factors, then mixture of the tribal and ethnic and linguistic communications. We have some infrastructure and geographical barriers. Substance abuse is a great concern nowadays, and armed conflicts and violence is another important aspect we need to consider. Next. So this is just the data of showing the last 5 years of the patients attending the LGBRMH. In the last 5 years, we had attended around 5 lakhs of patients. And we had informal interview we have done with a few patients of the northeastern states and asked what are the difficulties they face, and they mainly revealed that the accessibility to the institute is the main issue. So we have the up-to-date infrastructures, but accessibility to the institute we have to think about. Next. So this is the spoke and hub model of the LGBRMH. Now we are working as a hub for the 8 northeastern states, which will provide teaching, research, and expertise needs of these northeastern states. Now we have started 50% reservation of all the postgraduate seats of these northeastern states. Next. So next. So types of manpower we require at various levels. As it is, we know that psychiatry and the mental health care is still labor intensive work. We cannot rely on machines to assess the human minds. So at the various levels, we can utilize the manpower, like end user level, the patient care level. We can have the self-help groups, the patients who are having lived-in experiences, then training of the family members for coping strategies and identification of the early symptoms we can do. At village level, we can already utilize the existing resources of government like ASA workers, Anganwadi workers, panchayats, local clubs, NGOs, volunteer workers, etc. In PHC and CHC levels, we need to have training of the medical officers. Already the digital academy is in operational. Then other supportive health workers we need to train. In medical colleges, train psychiatrists, postgraduate training, consultation license cases we need to have to address. In tertiary care and center of excellences, then we need super specialty services and training of this monitoring of these levels and monitoring of government scheme at all levels. Next, what are the human resources of future needs? We feel that correctional home requires full-time psychiatrists and counselors. Educational institute requires full-time counselors. Incorporation of the importance of mental hygiene in school and colleges syllabus. In the industrial sector, still handling labor force requires mental health professionals. Undergraduate medical training in psychiatry needs to be more structured. Increase in number of the postgraduate seats, as my previous speakers have already emphasized on that. Then we need to introduce of target-specific short-term courses after post-graduation, and collaboration and training scopes with state-of-art institution is very important at this stage. Next. So we can increase the human resources by strengthening the mental health education and reduce stigma, then establish mental health training centers. We have to incentivize the mental health careers. We need to promote the multidisciplinary collaboration and mentorship programs. Public-private partnership is very important at this stage because it is not possible for to target all needs of the mental health care in the country with only the government manpower force. So we have to support research and innovation, creative supportive work. Then we need to improve the retention strategies because we have seen that people join their jobs, but they leave their jobs due to some difficulties they face. So we need to study what are the issues they face, and then we can at least retain them in their services. So we need to expand the telepsychiatry and e-health initiatives. Next. So these are the mental health services. Innovative techniques now are in picture. So we need to utilize at the most these innovative techniques. Telepsychiatry, we all know. Mobile mental health camps already have been seen. Online cognitive behavioral therapy, peer support program, virtual reality therapies, then digital therapeutics, that cognitive training exercises through digital mode, then collaboration care models with the primary care physicians, then text message innovative techniques like follow-up reminders, self-help materials, etc. can be delivered. Next. So telemental health services already my previous speakers has emphasized. Next. Two issues in delivering service in the telemode we have experienced. First is the need of human touch and interaction in psychological assessment to understand the complexity of mind is still we feel it is required. Then medicine availability in peripheral areas and its delivery issues are still problematic. We can give the advice, we can give the medicines through telemedicine services, but people are not getting it there in the peripheral villages and centers. So internet connectivity and digital awareness is still inadequate in periphery. So without addressing these issues, I think it will be difficult to achieve the goal of those telemode services. Next. So scientific approach to the stigma reduction is very important. We already have discussion to how to decrease the stigma reduction. Next. So we often forget about caregivers. We need some infrastructures for caregivers because they are the most who faces the emotional distress, physical health deterioration, financial strain, social isolation, legal issues. So what are to be considered? Separate residential facilities for attendance in hospitals as they require long stay. Then dedicated facilities for regular counseling and training about coping strategies, and dedicated legal cell for their help. It is the need of the hour. So a few pictures in the right hand side have been implemented in our hospital. That is a patient sofa cum bed, because we had felt that patients can stay can utilize the bed of the hospital, but it is very difficult to stay for attendance with the patient because they do not have separate beds. So for this, the sofa cum bed we are giving to the attendants. This is the shed we had to make during the COVID period to accommodate because there was a social distancing policy was adopted. So people used to stay in the hospital outdoors for a long time. For these caregivers, we need to make this shed. And this is the DLSA counter, District Legal Service Assessment Legal Service counter we have. Next. So issue of homeless mentally ill very important. In the last 5 years, we had approx 100 homeless mentally ill. Most of them have already been reintegrated. And while a few issues we have now finding it difficult in discharge. First thing is not able to trace family members, not able to reveal proper address. Family members are not willing to accept, and then economically unstable to lead an independent life. Next. So a few initiatives have taken by us in association with the few NGOs. The Sadra Foundation in the southern states is already there. They have helped us for reintegration of our homeless mentally ill patients. Next. So only the we should not focus only on the placement of the mentally ill patient in the that halfway homes or shelter homes. We need to utilize their optimal capacities. These are the few pictures and few materials that have been prepared by the recovered mentally ill patients. So it shows they are very productive and their potential can be used fullest. So these recovered mentally ill patients can be there should be some provisions so that they can be engaged in the various industries like agriculture or any other industries, so that they can utilize their potential. Next. Yeah. So it is the now we are we are aware about the artificial intelligence and AI chatbots. So this can be utilized in the mental health care. So AI chatbots which are 24/7 access, they can be used for early detection and prediction by analyzing the data. Then data monitoring analysis by wearable biofeedback machines, then reducing stigma because people can talk the AI chatbots freely. So these technologies should be used in current scenarios. Next. So this is the vision plan of LGBMH for the next 15 years. It has already been approved by the ministry. It has 3 phases. First is phase of expansion. Next is phase of consolidation, and third phase of excellence. We are at the first phase. Next. So these are the 10 centers we have proposed, which will target the specific areas like child and adolescent mental health, addiction medicines, Ayush, digital mental health informatics, integrated family well-being, psychotherapy and counseling, neuroscience, rehabilitation science, community mental health care. So we have thought that conversion of the disciplines, instead of working in silos, then people in these centers can come from various disciplines and work as per their expertise and interest. Then there will be scientific study of the traditional healing methods, because we cannot omit them. It is very important to know the traditional healing methods. It will give that diverse platform for working with the stalwarts, and courses in the line of the NEP with multi-level exit may be designed as per requirement in these centers. Next. So the take-home message is approach beyond hospital boundaries, regular training and capacity building of human resources, strengthening of the support groups, caregivers, local and self-help groups, awareness and stigma reduction, use of artificial intelligence and technology to make mental health care more easily accessible, and optimum implementation of the mental health legislation and monitoring of the implementation of government schemes, we feel it is required. Next. Thank you.
So, thank you, Dr. Datta, for pointing out the need for integrated infrastructure, especially keeping in mind the challenges of Northeast, which are so unique, and of course the need to have private sector, civil society organizations, and collaborative healthcare model. And you've been part of the Digital Academy when we first set it up. So thanks for that great work also. Now I request Dr. Rajesh Sagar, Professor of Psychiatry, AIIMS, who's also member of Central Mental Health Authority, to kindly share his views.
Good afternoon, everyone. Chairpersons, Professor Vinod Paul, Madam Preeti Sudan, and all co-panelists who are here, and respected chairperson and members of NHRC. And first of all, I am so thankful that we are having this meeting, conference, because it was planned few months ago. And I was also part of the core team last year when the visit of NHRC was made in Ranchi. And not only the visit, but also there was a discussion, there was a workshop for one day, and we spent a wonderful time. And it was a great to have spent time and to know the sensitivity that how our chairperson interacting with the patient, the staff. So that was a good learning opportunity in that way. What I will do, I know that I am standing between you and lunch, and already we have spent so much time in discussion. So what I will just quickly go through some of the important issues which are just focus on the infrastructure aspect, human resource, that too where I have contributed, where I have been involved. So I will just focus on that, quickly go through some of the things, and maybe later we can have more discussion. Next slide, please. Now we all know that the importance of infrastructure and human resource, and more so it is important for psychiatry, mental health, because for a number of reasons. And of course, when we talk of infrastructure, what is said that 7 domains are important. We need to think about that patient experience, effectiveness, efficiency, timeliness, safety, equity, and sustainability. So these are some 7 domains which need to be taken care of. Infrastructure and modes of human resource also. We need to look at that. They are very integral part, and perhaps it is said that the standard of care and the well-being is determined by the infrastructure and the human resource. Next, please. Now, we did hear from NMHS survey that 10.6% is a cross-sectional. Now, this is one study which was done with ICMR of all states of the country where the burden was assessed. And this is a 2-point, like in 1990 versus 2017. And it was found that, that double disability has happened. So it is not only the cross-sectional. One can say that why we need human resource, in that way. We only have 10%. But the point here is what I am trying to say is there has been increment, and this increment has been doubled over these 20-year period. So if we go by that, then obviously we need to look at the resources and the infrastructure, because the numbers are increasing. And this study, Lancet, which was published in Lancet, where it says that the numbers, the disability has increased. Of course, 1 in 7 had mental disorder. So the point is that there has been increase, which is very important for us to know. Next, please. Now, National Mental Health Program, we all know, and since we were part of that, and as a policy settlement authority, for last time involved for more than 18 years now, where one of the important aspect was, other than 3 objectives, then this was added that the human resource also in mental health subspecialty. Next, please. And there was something on 2009, there was manpower development scheme. We did hear about that in the morning, and there was scheme A and scheme B. Some of us were part of that, where we visited, we did inspection, where the center of excellence were there, all spread across all over the country. And the idea was that there was a kind of, it was said that with these institutions there will be increment of 1,500 mental health professionals per year. And so that was the whole idea behind that. And of course, and there was a scheme B also, where the support was given to psychiatry department. And we all know that since I was part of mental health policy also, there were 10 objectives, out of which one objective was to have a skilled manpower, and that was also important initiative. It is specifically documented in National Mental Health Policy, and of course in our Mental Health Act also, especially Chapter 6, Duties of Government. There is a specific mention of the training and other aspects. Next, please. Now, this is one review which we did about National Mental Health Program, Optimism, Caution, and we did talked about what are difficulties, problems associated with the National Mental Health Program. One of the major obstacle was the lack of psychiatrists in these facilities. That is why the term was changed from psychiatrist to the program officer. So next, please. I will not go into details of that. Psychiatry units only had the level of district, not sufficient in addressing the mental health needs of sub-district level. It was not there. Absence of trained psychiatrists was there. Coverage again and function of DMHP was non-uniform. Again, it was much better in some places, but not so much in other places. So that was very clearly evident, and there was lack of leadership at all levels, central, state, and district. Next, please. Now, I will just talk on the way forward, and I will tell you as a CMHA 2009, there was one of the agenda was made that how we can strengthen psychiatry in the MBBS curriculum. Now, there was a lot of discussion of the training part. We need to train. But the important thing is that that will not be required if the strengthening of psychiatry is there in the MBBS curriculum itself. I think that's a very, very important point that we need to know. And if at all we need to have, we think of human resource, then we need to have that, psychiatry should be the integral part of the training. And of course, we demanded that it should be a separate subject, and a lot of discussion was there. And we are happy that NHRC also, intervened, and and I'm talking of 2009, and a lot of developments have taken place. And now we know that it has increased. 2 weeks posting is there, internship, which was not there earlier. Can you imagine earlier time, out of 172 weeks, only 2 weeks were there in psychiatry. So it was, just imagine, and we all know that the people who are seen in a primary care setting, they are more than 30%. So just imagine the disproportion and the schism which is there. Next, please. So we all know that some of the issues that teaching hours and which has to be there, and some efforts has gone in this particular area. I will not go into details of that, but the important thing is psychiatry training is not only for psychiatrists. I think that also we need to understand. That is what we say at AIIMS also, that it is helpful for when you are practicing medicine, also in surgery also, like how we communicate with the patient, that becomes a key. So psychiatry training in MBBS is not only that you will become a psychiatrist, but also important for other specialty also. But yes, more emphasis needs to be there. Next, please. Now, we all know, and we have discussed that it will take 17 years. Some say it will take 100 years. We want to match with the Western world. So what is the other thing? We need to train the non-psychiatrists, and a lot of efforts have been there, which we have been part of that. Like the training program, NIMHANS is conducting, many other institutes are conducting the training of non-specialists, and there are models, there are books, a lot of organizations are working on this. So to bridge this gap, I think that becomes a very important aspect, and that we need to see that they can be very, next please, yeah. So we need to shift this specialist care to the wide range of mental health care providers. Next please. So we need, but at the same time, we need to know that they cannot be substitute also. We need to work towards having specialists, at the same time train the non-specialist also and non-professional also. We need to look at the volunteers who are there. So we need to look at the whole group of people. Next please. So in the same line, we need to also see, I think this is a very important issue, since the theme is there, moving mental health beyond institution. So we need to look towards a general hospital psychiatry unit. Now the time is there. Now we know that we have 600 plus medical colleges. We have 22 AIIMS which have come up, and these are all general hospital setting. Out of these 600, 300 plus have a psychiatry department. So this is a very important resource, and especially with regard to multiple issues, we have to see the health as a holistic approach needs to be there. Next please. So some of the points which are there, we need to see that if you want to remove the stigma, if you want to look as because a lot of comorbidity is very high. So psychiatry, when we need to provide a care, and that is very important from the human right perspective also, because we can't just look at the mental health only. We have to also look at the other medical aspect. In fact, in our visit also, we also ensure that how, if at all there is no psychiatry medicine department, at least a link should be there in the mental hospital with other medical colleges, other hospital. So we wanted to ensure, because some of the deaths they do take place in mental hospital, which some of the inspection what we did. So this can be taken care of if we have a good link with a medical college and other departments. So general hospital psychiatry is a way forward. We need to look at it more carefully. If at all we have to look ahead about that. This thing is very important to look at tap the human resource. Now, when I talk this, I think here the nurses, the potential has not been tapped yet. I think that is very important. Teachers, school teachers, We have talked about ASHA workers. We have Anganwadi workers for children. I think they are an important resource. We need to look at it how we can make use of them in our to provide a care so they can be part of good human resource with regard to mental health care and the delivery. Next, please. So these are some of the recommendations. We thought that one, there should be mapping of all the resources. The task force should be there, where based on the experience, all should be documented. So anyone who wants to take a service can take easily the services which is there in the available there. So I think that's very important. It can be there. Countrywide, statewide, district-wise, so all the people who are there, so human resource, if they are there, if they are not being used, utilized, no one knows about it, it's of no use. So there should be this aspect which is important. Then different categories of healthcare personnel which are there, their training needs also we need to look at it, and all the efforts need to be there. Of course, some efforts are going on, but we need to look at it more comprehensively about this aspect. And also the systematic approach, the interdisciplinary, multi-sectoral, the kind of partnership with the government, ministries, researchers, NGOs and all. I think that becomes a key. If at all we need to look at we have to move forward and also look at the human resource for the future. I think we have to have this intersectoral and intercoordination, and that would be important. And also the important thing is that whenever we think of a medical college or institution, hospital, we need to see that how they can be the center for providing human resource. So that things should be there, like not only providing the services, but also like Professor Gangadhar talked about, that these beds are not utilized in mental hospital. So whenever we have to think integrally about this, so how we can utilize these, how we can use it, how we can use for human resource development. If not human resource, then even training, capacity building. So all these can be done whenever we are thinking about it. Next, please. Just last, because this is one study we did, which was funded by WHO in 2019, where we looked at 10 districts of 10 different states. And we looked at the assessment of quality and best practices, and we used different scales, like patient care satisfaction was used, caregiver burden was used, quality of services, and there's a WHO important instrument known as quality rights instrument. So which we had used, and some of the issues were noted, and which had the report is there with the ministry, and that was the feedback was given to all these states in our a meeting with them. So but the whole detailed report is available with the ministry and WHO. So I just wanted to highlight that if we can do this kind of assessment different state, that will be helpful to look at some of the problems which are there and how we can plug those problem in that way. Next, please. So just to conclude, I think it is important infrastructural aspect, and human resources are for mental health continue to be grossly inadequate, and that we need to know in our country and other which we have to be careful of. Task shifting may be important, I think, which I have alluded to, and which will be important, investment in that way, and innovative thinking may be required, and effective leadership may need to be there, and there has to be development in evaluation human resource for mental health, though it's a difficult and complex task, but it will pose a substantial challenge in coming years, especially in the point what I said, that the numbers, the disability, the burden is increasing over the years. And of course, adequate attention needs to be there to achieve the objective of scaling up of care of these mental people with mental disorder. I think that is what we need to see, that how we can look at this for the future. I think the time is there where we can look at it so that we can provide the adequate services with regard to mental health in the future. With this, I will thank you. Thank you so much. Thank you for providing the opportunity.
Thank you, Dr. Sagar. You, especially for your very important recommendations on augmenting human resource for mental health care and mainstreaming psychiatry training. I have great hope in the National Commission for Allied Health Professionals, which has been recently set up under the Act of 2021, though it is still to actually operationalize. I think it will help, especially at the district and sub-district level. So now I hand over the proceedings to the chair, Dr. Paul.
Thank you very much. In the interest of time, I'll go straight to important reflections and synthesis, some repetition, because I like to emphasize very important points that have been made by way of solution, but also a couple of additional points. So we are really looking at human resources and infrastructure, first on human resources. We heard, and beginning with psychiatrists' position in the country, we heard from Dr. Dhameja that we need at least 30,000 psychiatrists in the country today to be looking like the upper middle, not the Viksit world. 30,000 today. What is our pipeline? We have a pipeline of about 1,300 to 1,350 per annum, both NMC system and DNB system. It will take us 20 years. So we have to augment the pipeline for postgraduate training. We only have 9,000, 8,000 psychiatrists. We need 30,000, and this has to be bridged, let's say, within the next 5 years. So here is what I would suggest, what needs to be done. There are two streams for psychiatry training. The predominant stream is through the National Medical Commission, represented here by Honorable Dr. Gangadharji. And here, we showed data to you that 315 medical colleges have 1,260 seats, so let's say 1,300 seats. About 400 medical colleges have 5,000 MD medicine seats. I want to look at the ratio. So the multiple there is 10, and the multiple here, sir, is only 4. That means in the same medical college, with all the requirements that we expect, why is it that we are producing less number of psychiatrists? Some corrections need to be done, because these are, standardized, largely standardized medical education system, medical college department, psychiatry, medicine, OB. But there we are able to churn out 10 and here 4. So there's something that we must do proactively to build on the capacity and use the capacity, sir, that we have. I think there are some technical issues. There are 15 beds and 30 beds. My team spotted. I may not be totally correct, but this has to be corrected. And I would urge, therefore, by way of recommendation, and please NHRC, put your weight on that we double this capacity next year, and this can be done. 1,250 should become 2,500, and by 2027, it should become 4,000. That multiple of 10 should apply. If there's some course corrections to be done by way of, because psychiatry, hell of a lot of it is outpatient. Why should we be having 30 beds which will never be occupied in general medical colleges? There seems to be some infirmity, and I apologize as BOG chair, I missed it, but I urge my distinguished colleague here, we double the seats of psychiatry next year, it's possible, and then we take it to 4,000 seats by 2027. The second stream, sir, Honorable Sir, there is a stream of training postgraduates in any specialty, well-functioning hospital, private or government, which need not be a medical college. And that stream is run by the National Board of Examinations, which is apprenticeship-based training, and at the end of it, you take a great exam, and then if you're through, you move on to get the degree. This is the way it works in the UK. We have the system, unfortunately. We only have 41 seats in that entire system from 26 institutions. And there are at least 30,000 private hospitals. Leave alone the government hospitals, we assume government part is covered by the medical colleges, even though there's a scope. In fact, recently government started diploma courses in district hospitals. I am urging my colleagues in the private sector. IMA, they said 85% of the care they give. Can we please use every opportunity, every bed, every OPD for psychiatry, for training doctors? It's not just for services. Each bed in our nation has to be used not only for services, but also for training. Only then can we meet the huge, huge deficit of all specialties and the workforce that we need. So please, I urge, and we will work with the aim of raising these 41 seats to 200 seats in the next 2 years, max. At least 200 seats in the NBE space. There are some issues. I don't want to go in that direction for lack of time. However, here is something that we all can do, and a lot of us are represented here. The same DNB system needs to be invoked for 43 government institutions for psychiatry and mental diseases. To my knowledge, my team has put forth, there are 43 of them. Only 15 of these mega hospitals are serving as teaching institutions. 6 of them are doing the NMC course. and only 9 are doing DNB. There is a huge scope of running the DNB courses in these institutions, and I'm happy to submit that I took a meeting for 20 of these institutes trying to augment that, and please, can we do work together? There is a treasure of PG pipeline waiting to be harnessed from Tejpur and more from Ranchi and even more so from other places. And likewise, there are general psychiatry departments in ESI, railway hospitals, armed forces, which should become part of the psychiatry workforce development, shall we say. NITI is playing its role, but I think if we also reach out proactively. Many of you are represented here to please work on this, because that is a system that works beautifully. Postgraduate system, sir, I'm happy to say, Chairman, sir, that does not need lecture theaters, nothing. It is a training on the spot in the OPD, in the emergency, and in the operation theaters, eminently doable. So please come forth. These are my 2 quick recommendations. Private sector, please rise to the occasion, contribute PG seats, as you have a huge workforce of psychiatrists amongst yourselves. Part 2, sir, is in relation to the issue of, I have one more point on this one. Contrary to what you may believe, MBBS training, even if when done optimally, in today's time with scientific knowledge that must come into picture, does not optimally create a family doctor. That's why specialties. That's why clamor for specialties, and therefore, and also lack of market. We must have generous family medicine program, MD level programs.
Yes.
This is a recommendation enshrined in the NMC Act. I urge NMC to please be proactive in this. At our level, and NITI is trying to work actively with new AIMSs, and I'm happy to let you know that this week we hope to get this endorsement for having generous medical family medicine programs started in new AIMS system, 22 of those institutions. The point that I'm making is, why should you be always looking for a psychiatrist? There must be a general doctor who can provide care. We have missed out on that, and the way forward, apart from improving the UG training, no matter how much training improvement you do, this is only 3 weeks posting. How many patients can I see? I'm a raw person, class 12. Not easy. Continuity of care happens only when I follow up the patient. Next time she comes, he comes. Really not possible. Yes, first line to an extent possible, but that can also be given to the CHOs and others. So therefore, family medicine is a way forward. I urge all stakeholders to please move in that direction. Very little movement on the NMC side. We are trying to do this on the AIM side. I urge that we work together on this. In fact, the way forward for this is integrative family medicine, in which some of our Ayurveda pathies can also come, and we have a unified, holistic family health program. We're trying to work on that. I hope we'll garner support from the stakeholders on that. Second area, sir, is the issue of 3 very important cadres that form the workforce, namely clinical psychologists, psychiatric nurses, and psychiatric social workers. In fact, we have had an unexpected setback on this, to which reference was made by Neha, that MPhil programs, which were qualifying degrees for clinical psychologists and psychiatric social workers, has been abrogated under the NEP. We are trying to find a way forward, and we think we'll have a solution, at least on paper, in the next 4 to 6 weeks. But what we need is 1 lakh of them. And what we have is only 10,000. So again, and I know from my data that clinical psychologist training is less than 50 institutions. Why universities are not coming forward? This is done in normal universities. And all these institutions, 43, they are also not rising to the occasion. So creating workforce would require nudging the universities, nudging our 43 odd institutions that I was referring to, and nudging medical colleges to play their role, and I plead that that should be done. Without these important workers, this is not really possible to provide optimum care, no matter how much hard we work from the administrative level. Each one of the institutions try their best, but we need this workforce. 1 lakh workforce is missing today, and therefore I urge that we take expeditious action in that regard. Third point relates to, just to mention, the training of the community health officers who are the backbone, the mid-level provider at our 160,000 health and wellness centers, which Madam Preeti Sudan had been instrumental in initiating and launching. They need to be empowered with skills, not only to make phone calls as a teleconsultation pathway. No, they should be able to counsel and they should be able to connect with the community. In fact, if required, connect with the home. We are trying to bring this paradigm, like the weight from the stakeholders, to be added, and whatever help can come in this regard, we'll be happy. This CHO needs an algorithmic-based diagnostic screening system, but excellent skills on screening. NIMHANS, please, we are working on this, but there's more to be done. We need help. And likewise, PSC MOs also need refresher training. This is just for mention. My fourth point, I strongly endorse the posting of the residents, the psychiatry residents into the Telemana system. This is very doable. We will do it in consultation with the Ministry of Health. But then these people, once they're sitting on that console and receiving calls, should be also trained, because they should not be worse than our professional counselors who are already manning them. So that they need a training and they should know what to do, but they should be posted. On this, I'm happy to inform the House that a decision taken by the BOG MCI, the then MCI, of which Dr. Gangadharji was an eminent member, and with his support and others, we have instituted a district residency program under which all postgraduates of all specialties, including psychiatry, are meant to spend 3 months of their second year in a district hospital. So for 3 months, psychiatrists are already going from the medical colleges, all these 1326, whoever, they from this year are being posted in district hospitals to be able to provide care even as they learn. So this is one little reform which will at least have house job level psychiatry trainees, especially shall we say, in the vicinity of the district hospitals. My next point relates to what can we do in schools and universities. We heard some good examples, but a lot more needs to be done. I just take one instance. Yesterday, a very senior professor from one of the very, very eminent institutions was telling 10 people who were failing in that high-end IIT type of system. He was talking to them and 5 of them said, we cannot help because we are into gaming, we are obsessed, we cannot get out of it. I think there is a huge problem out there in our schools and colleges. Addictions are back and screen addictions are in and the other addictions are all there. We need to work. NITI is working on school health program, of which one of the 6 pillars is mental health support and counseling. I invite all of you who have experience with doing this kind of a work in the schools to be a part of this. Suggestions are invited. We would extend this work to universities very quickly. Therefore, I request inputs on this. Whoever has experience on this, has ideas, we'll be requesting them to take part. My next point is in relation to infrastructure. We heard from Dr. Dhamija. No, we didn't hear. Well, 0.6 per lakh beds is what we have, sir, for your kind attention. You said that, sorry. It was the same slide that you showed. 0.6 per lakh. And the upper middle countries have 25. So at least 30 times. Now today is really, I'm not really prepared to go into that, but this is a huge issue. The government has expanded medical colleges and therefore beds through that. Other efforts have been taken, but obviously we need fresh thinking on how to augment the bed strength for our mental health patients. And that's a very major issue. I leave this thought here, but the deficit is huge. We are looking at something at least to the tune of 10 times, 8 to 10 times, even when we have home-based care, etc., etc. Huge deficit. And again, I request private sector to rise to the occasion. There is very little inpatient bed strength in the private sector hospitals overall. I urge that private sector rise to the occasion. My next point, 2 points are very brief. One, ma'am, sitting with you, I would like to remind all of us that vacancies should be filled. We have, typically in medical colleges, the vacancies are 30%. Would apply, don't have data specifically for psychiatry, would apply, so the vacancies wherever they are, state government institutions, central government institutions, medical colleges, private medical colleges, can we fill them up? because the positions are there, can we get them? Can we expedite recruitment? That will be my other suggestion. And lastly, I would strongly endorse connecting yoga systems to the institutions. We should be able to work with this as a well-tested model where it helps the patients if you systematically embrace yoga into our treatment paradigm, management paradigm, it would work. This is an idea worth taking forward. With these words, my deep gratitude. Yes, the psychiatry positions also, Madam is reminding, there are psychiatry beds in ESI, railways, armed forces. They also need to be harnessed through the DNB system in particular. I would urge, thank you for the opportunity, and I would urge NHRC to kindly put your weight on these issues and guide us how we take it forward. We assure you that we mean to work hard in this very difficult but very, very important area. Thank you, sir.
Thank you, Dr. V.K. Paul, Chair and Co-Chair Mrs. Preeti Sudan, and the panelists. May I request Mr. Surajit Dey, Registrar Law NHRC, to please present mementos to Chair and Co-Chair and all the panelists of this session before we take a break for the lunch. Dr. Paul.
We have no option. We have no option really.
Thank you, sir. Thank you, sir. With this, we conclude the second technical session and we take a break for lunch. All the panelists and the chair and co-chair and all the participants here and the dignitaries are requested to please join for lunch. The lunch has been arranged at the atrium on the ground floor. And we will be back here with our third technical session at 3:35. The next session will be at 3:35.
Hello, hello.
Hello, hello.
Check 1, 2, check, check, check.
तीन ग्लास में लिया
कर ऑन कर चेक हेलो 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 चेक ये बंद कर पोडियम माइक बंद कर एसआरई वाले हेलो हेलो चेक हेलो हेलो चेक 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 हेलो 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 1 हेलो 2 हेलो चेक बड़ा बड़ा लेवल बड़ा चेक 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 कहाँ से ऐड होगा
सात हो गया ना
हेलो 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 चेक 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 हेलो हेलो चेक Check 1 2 hello check. Check check.
सात हो गई ना, 8 है ना वो, 9 नहीं बैठ पाएंगे ना जगन वहाँ।
Hello. Hello. Hello.
to please their seats. Mr. Manoj Yadav, DG Investigation NHRC, is there. Dr. Santosh Kumar Kraleti, Senior Public Health Specialist. Please take your seat on the dais. Dr. Shruti Chakravarti, Mariwala Health Initiative, Mumbai. Dr. Rajiv Mehta, Senior Consultant, Department of Psychiatry, Sir Gangaram Hospital, Delhi. And Ms. Veena Agarwal, Chairperson, Sanjeevani Society for Mental Health, Delhi. Mr. Rajiv Jain, Honorable Member of the National Human Rights Commission, is quintessentially a curious person, and given his background of an IPS officer, he has seen and studied human rights very closely. He has been very keenly following the challenges being faced by the mental health care institutions, among other issues of human rights. Dr. Nand Kumar is a professor of psychiatry in the All India Institute of Medical Sciences in Delhi. He has a first-hand experience of the challenges being faced in the treatment and rehabilitation of mentally ill persons. A warm welcome to both of you, sir, and the panelists. May I now request the chair of the session, Mr. Rajiv Jain, Honorable Member NHRC, to please conduct the proceedings of the session.
Okay, thank you, Chairman. We are already running considerably late. So, after my opening remarks, I'll invite the panelists one after the other to give their thoughts, share their thoughts, and finally, Dr. Nand Kumar would sum up the session. So much has already been said on the issue, but most of it has been on institutional matters, physical infrastructure, human resources, government action, and so forth. Now we look at it from the victim perspective. The entire Mental Health Care Act is from a victim perspective. The very first line of the Act, it says, the Act to provide for, ... to protect, promote, and fulfill the rights of such persons, and so forth. The next paragraph of the Act says, talks of conformity with the UNCRPD, United Nations Conventions for Rights of Persons with Disabilities. So it says, whereas the Convention on Rights of Persons with Disabilities and its optional protocol was adopted at the UN and subsequently ratified by the Government of India. Consequently, the need to align domestic laws with India's international obligation. So this Act represents not only from the victim perspective the rights, but also the international obligations of the country on that subject. And you would notice that the first chapter of the Act starts with the rights, almost a dozen rights. We have the right to, not the first chapter, sorry, chapter 5, but it's right to access to mental health care, right to community living, right to protection from cruel, inhuman and degrading treatment, right to equality, right to non-discrimination, right to confidentiality, right to access one's medical records, right to personal contacts and communication, right to make complaints against deficiencies in provision of services, and right to legal aid. So the Act focuses a lot on rights and then creating institutional infrastructure for implementation of those rights. I'm not dwelling on those because previous speakers have dwelt on it, but one aspect which earlier speakers did not dwell on was the decriminalization of suicides that this Act has done. Section 115 of the Act mentions that Section 309, notwithstanding anything stated in Section 309 of the IPC, a person who's caught for attempting suicide should be presumed to be under mental stress unless otherwise established. Strangely, we are talking of sensitivity here. We are also talking of other stakeholders, including the police and other law enforcers. But strangely, I came across a case recently in the NHRC. The case was that a girl's parent complained to the NHRC that my daughter was raped. Police didn't do much. Subsequently, police registered a case, accused was arrested, accused came out on bail, the accused again raped the girl. The girl then attempted suicide. Police registered a case under section 309. We issued a notice to the police. I quoted this section 115 of the National Mental Health Care Act and said, no, this section has been decriminalized 309. You need to have a relook at why you registered the FIR. But subsequently I found the police submitted charge sheet in the case under section 309 despite this decriminalization. So there's apparent need for sensitization and education of the stakeholders in this process. This was one glaring example that came to my notice. The other issues like one important issue which has been touched by my chairperson and one other speaker was legal aid. We talked of nearly 2,000 persons who continue to remain in mental institutions despite having been cured completely. But provision of legal aid is being provided only in 9 of the 47 institutes. Why? The District Legal Services Authority is there in every district. All these institutions are located in district headquarters. None of them is in such a remote place that there's no road or train connectivity. Why should legal aid not be provided to these people to help them get their feet back, to help them get justice, to help them get this right to avail of redressal of their grievances? Now I've spoken too much and I move on, leave the floor to my panelists. Manoj Yadav, my distinguished colleague, is Director General of Investigations in the NHRC. Manoj, over to you. And Manoj, I hope you will restrict yourself to 3 minutes on.
So you have given me 2 topics, 3 minutes each, sir.
Hey, hang on. So what we'll do is, okay, we negotiate 4 minutes and I'll tap my pencil like this to forewarn you.
Honorable Chairperson, sir, honorable members, my distinguished co-panelists, assembled practitioners of mental health discipline. So I have 2 presentations. First of all, I like to speak about an issue which Honorable Chairperson has highlighted in his opening address. I would quote from his speech. He said that hospital is not a place where a cured mental health patient should be permitted to stay, even for 1 extra day. During his visit to Rinpas, Ranchi, he was categorical. He was in fact angry that it amounts to unlawful custody. A person is being held when he or she has been cured. So in this regard, the Honorable Chairperson, during the visit to Gwalior, Agra, and Ranchi mental health institutions, clearly mentioned that we should launch a concerted program to ensure that those cured patients are taken back to their families. And in the last 6 months, a lot of work has been done, and many such patients, because of the extra effort done by authorities, coordination achieved between the District Legal Aid Agency and the courts and the police and the heads of the mental health institutions, number of persons have been recovered back. So a small presentation on that. First slide, please. So next, please. So this is the data that we found, that there are 16,942 patients were admitted in all the mental health institutions of India on 31st December 2022. Out of them, 13,133, which is a staggering number. Almost 75% had been cured. However, out of them, they were cured and many of them went away. But 2,110 patients recovered, but they continued to stay. in these institutions. Next, please. So when we interacted with the heads of the mental health institutions who were trying their best to restore them with the families, reconnect them with the families, number of issues came up. The most important, these are the four main ones, and I will come one by one. Next, please. So in family constraints, they said that family members are not willing to take back the patient. Sometimes they did not mention at all, did not respond at all. Sometimes when the teams went, the family had changed the address and we do not know where they have gone next. And the family, second is lack of social support from the government. So there are no vacant beds available in halfway homes. Honorable Chairperson has already mentioned that halfway homes need to be established, preferably within the same premises, so that their connect with their doctors who treated them remains. Next, please. There are legal constraints, particularly with reference to foreign nationals, and there are other constraints, such as patient being unfit for discharge because of some physical disability. There are some language barriers, because sometimes these mental health patients get into a train, they get down at an unfamiliar place, the police, so nobody is able to communicate to them because of the language being from a different state. And since they have intellectual disability, they are not able to give their address. Next, please. So there's a study, small study, which actually highlights the issues of Mansik Arogya Shala, Gwalior. Here, there were 38 female patients who had recovered but were continuing to stay. Efforts were made to reunite them. In 2 cases, they were not accepted by the family members. But in the majority of cases, 36 cases, their home addresses were not known. And among the male patients, there were 25. 6 of them were not accepted by family members. But in 19 cases, home address is not known. So it is clear that in a majority of cases, since we do not know their home address, either because they are not able to disclose it, we have to think of some institution where these recovered patients can be kept and they can be engaged in useful activities, make some social contribution, learn some skills, etc. Next. So these are the same figures. Next, please. So way forward is this. As we said, education awareness programs, particularly for families. And training the families and how to handle. The families are also destitute. They do not have the space. They have to go for work. There is nobody left at home to take care of this person. So sometimes there are very valid reasons why the family is not willing to accept. Wherever the reasons are not sincere, such as depriving him of share in the property, I think the police and the legal system should come to their help. Next slide, please. So now I will come to the second part, where the Honorable Commission has issued recent advisory on prevention of suicides among the prison inmates. We know that in India, bulk of the about 60% of deaths which take place are due to non-natural causes. Out of these non-natural causes, 80% of them are due to suicides. And this is preventable, because when a person comes to jail in accordance with the law, his or her family expects that he will come back and join them after the prison term is over. But unfortunately, in many such cases, unable to handle the pressure, unable to cope with the prison environment, suicides take place. Next, please. So the Honorable Commission had taken cognizance of this issue in 2014 itself. But the detailed advisories were issued, but subsequently there were many developments, both in the mental health treatment protocols. The new Mental Health Act came into being, there were court judgments. So it has been comprehensively rewritten, and it is hoped that it will provide a complete framework for having a relook at this. Next, please. So first issue is filling up the vacancies in the jails, particularly of the welfare officers, psychologists and medical staff. It's a fact that in bulk of our prisons, even the medical officer is not posted. It's generally a compounder who's taking care of the medical requirements. And so we realize that in the advisory mentions very clearly that the way forward is that you train the existing staff. in identifying symptoms of a mental health condition, in identifying some symptoms that the person is likely to cause self-harm or suicide, and then create a training program for them, which should be repeated every 3 years, refreshed, so that they do not forget the lessons learned. In this regard, a gatekeeper model, which was developed by WHO, was also suggested. The gatekeeper model is that buddies, the fellow prison inmates who are suitable, who are educated, they can be trained, who are in the same barrack, into keeping an eye on those talking negatively, having some suicidal thoughts, etc. Next, please. And in an ideal world, if the mental health screening can be done when the patient is being admitted, if the inmate has a history of drug abuse or drug addiction, he has had some history of mental issues, if that can be done, then it should be possible to keep them under closer watch. And therefore, the supervision and monitoring of at-risk prisoners becomes. In that also, the buddy system is very important, because there is always a shortage of staff. Therefore, it's important that volunteers who are educated from within the inmates are trained in keeping a watch, in keeping him engaged in conversations, and if situation they think is beyond at a risk point, tipping point, then to refer him to a mental health institution. Next, please. And the most important thing today, which has come up during the forenoon, is that the care has to go beyond institutions. Existing doctors have to be trained. He may be a medical officer. They had received 20 periods of mental health training during their MBBS course, but that can be now refurbished, that can be consolidated, and that can be updated, so that the same medical officer who's doing the initial health screening can identify certain signs. Addiction is a separate issue. So this, next please. Prison housekeeping, we have suggested, we have identified through research what are the common methods of committing suicides. So reducing the opportunity for suicide, particularly by hanging, redesign of toilets, redesign of barracks, avoiding all sharp tools, corrosive chemicals, etc. from the toilets, strengthening the visitor system. Next, introducing yoga, useful activities. So it's a very comprehensive advisory, and I would like to request this forum to take note of this advisory. 3 points came up during the discussion today, which are very relevant. So Telemanas was introduced. I'll just make 1 point. The Telemanas, the prisons should be able to enter into a special arrangement for prisoners with mental health problems, so they can take help of the telecommunication facility. Thank you very much. Thank you.
I now invite Mr. Deepak Singh, Divisional Commissioner, Gwalior. He's not here. I'm so sorry. Praliti, Senior Public Health Specialist.
I think so, Dr. Ramakant.
Okay, let's put out his name.
Honorable Chairperson, sir, very good afternoon, and dignitaries on the dais and off the dais. Third session is always difficult post-lunch. It's difficult to keep us awake as well. But I shall try my level best. And I don't have slides, so I'll be speaking. So I speak on behalf of a foundation called Sushena Health Foundation, and we work in the area of maternal and child health. And the topic is so very close to us, moving beyond institutions, and especially when we are dealing with mental and child health, adolescent health, and in healthcare we call this RMNCH plus A, reproductive, maternal, neonatal, child health plus adolescence. The important thing that we deal with day in and day out is we run a chain of kangaroo mother care units, mothers' milk banks, newborn ambulances, and also work in the area of menstrual hygiene and adolescent health. Now, what we see when we work with mothers, and especially young mothers who are delivering for the first time, who are in nuclear families, who have migrated into urban setups, and they're also poor and they're living in jhukki jhopadis and they're construction laborers. We work mostly in government hospitals, so all our areas of work are in government medical college hospitals. Maternal depression is a very, very big thing that we see day in and day out. And one of the important things that I want to bring to the forum is that in India, the percentage of premature deliveries is around 22%. The world over, the prematurity rate is only 8 to 9%. And why in India we are seeing this very high rate of premature deliveries? And one of the major reasons, of course, you have multiple pregnancies, diabetes, hypertension, all of this. But one of the most underlying current is stress. And it's a lot of stress related to many things, like financial stress, stress in families, probably husband, mother-in-law, and many other things which and we have done a lot of qualitative studies on this, and we see that the stress is one of the most important causation for this. So what we see is perinatal depression, and perinatal depression causes prematurity, and prematurity again causes many other problems. So this is something which we really need to address. Just 15 days back, one of our one person who used to work with us, who's an albino, who's a Divyangjan, his sister also happens to be an albino, and she delivered a baby. And the moment she delivered, first question she asked the doctor was, is my baby also in white color? And there was no one to counsel her. I think it was a consanguineous marriage. And the moment she came to know that her child was also in the same color that she is, she went into postpartum psychosis and she died. So this is just 15 days back. So we really don't have trained staff on ground. NFHS 5 data says that 94% of our deliveries are now happening in institutions. 94%, it's whopping. Out of this 94%, how many of our staff are trained with related to postpartum psychosis, perinatal depression, antenatal counseling? It is very, very less. Another thing that I want to flag, which we are working on, I would require 2 minutes, sir, is adolescent health. Now, the other side of the spectrum, which we are dealing with in government schools. We work in an area called Araku and Paderu, and a lot of this is on the Eastern Ghats in the tribal areas. Now, what we see here, as another speaker in the second panel was saying, a lot of addiction to porn, addiction to even very, very early sets. And we have seen cases where some boys have had sex with more than 40, 45 girls. So this is the level of addiction that they've got to have for porn and all these things. And huge amount of anger issues, huge amount of all these disorders. So it is human social behavior that we have to deal with. And this can happen only in schools, and this can happen very early. And if we leave these children without this sort of work in the school level, I think we'll be seeing a different level of psychiatric problems out there. So the Rashtriya Kishori Swasthya Karikram, which has been rolled out by the Ministry of Health, should be actually more closely working with the Education Ministry, with the Department of Education, with the Department of Tribal Affairs, and these departments actually have more onus to this rather than the Health Ministry. Health cannot be successful, and RKSK has been a failure in health because it was rolled out through health. So I think these sort of things are very, very important. And lastly, I would like to tell, we had a very recent incident when we were coming to the airport. You see this road rage which has increased so much, and the road rage is purely because of anger management, and the anger management and these sort of disorders have to be treated very early. So Bhagavad Gita has a beautiful shloka called Krodhat Bhavati Sammohaha, Sammohat Smriti Vibhramaha, Smriti Bhramsat Buddhinasho, Buddhinashat Pranashyati. The moment the Krodha is not nipped in the bud, it will lead to Sarvanasha. So this is very, very important that we deal with these sort of things very early. So what we do a very, very niche program called Arya Janani or Arya Mataram, where we teach all the mothers yoga, meditation, and many such things during pregnancy, before pregnancy, and post-pregnancy. There's a 1,000-day package that we give. All this is done in government hospitals. These sort of things need to be scaled up, and we see a huge difference. Mothers who used to weep, they come back happy, and they know how to actually balance themselves. They internalize things, and they try to understand their psychological issues, and they can address themselves. They become stronger. So I think we need to have a lot of training, even in our maternal and child health workforce, on these sort of problems. We need to demystify, and we need to do convergence. These are the two important things. All the departments need ingrained knowledge about mental health, and a lot of convergence between departments need to happen. It cannot happen in mental health institutions. It needs to happen in schools. It needs to happen in communities. It needs to happen in all the other sectors. So this is the crux of the whole study that we have done. So thank you very much for giving this audience, and congratulate National Human Rights Commission for convening this. Thank you so much.
Thank you, Dr. Kraliti. I now invite Dr. Shruti Chakravarti. Dr. Shruti is from the Mariwala Health Initiative, Mumbai.
Thank you, Chair, Co-Chair, Rajiv Jain Sir, Dr. Nand Kumar, Chairperson of NHRC, and NHRC members for inviting me here. As already said, I am representing Mariwala Health Initiative, which I've co-founded. I'm also the chief advisor over there. And I also have 20 years of experience as a therapist. So I'm mainly going to talk about, because time is short, I will not go into specific programs. I think I'll focus maybe on some of the the guidelines that Mariwala Health Initiative uses in its work with mental health. So MHI is a funding organization. Mariwala Health is a funding organization based in Bombay, and we exclusively fund mental health of marginalized populations and and disadvantaged sections such as tribals, people from Adivasi communities, disabled people, LGBT community, transgender people, etc. So some of the guidelines that we follow is also in the context of the mental health history that we've had in this country. And I think through the day, certain barriers have been spoken by everybody that prevent the promotion of the rights of mentally ill people. Some of it has been that historically there's been a very biomedical approach, and though we are moving towards the psychosocial, I think it is taking some time. There is lesser focus also on the patients themselves and their participation. I think, sir, you started with how the MHCA 2017 is about the patients and their rights, and I think pushing for that is a necessary step. And of course, the connections to social factors, I think we sometimes don't make that enough, that in recovery and reintegration, even though the mental illness may be in the individual, it is definitely connected to social factors, social systems. And unless we see it in this holistic manner, just providing medication or individual interventions will unfortunately fail patients in the long run. I mean, we already have the MHCA 2017. The rights are enshrined in that act. And it is also important to recognize that it's only the government that is the largest service provider of mental health care, given the depth and the diversity of this country, the volume of work. I think it does fall upon the government to take that kind of work forward and uphold a rights-based approach to mental health. I will not go into what the steps are, those have been outlined. I'd like to just simply say now that one of the programs that MHI does is called Miljul, and it is at the Bihar Institute of Mental Health and Allied Sciences, BIMHAS, which is at Koilwar. And as it has been outlined in many presentations already, a psychosocial approach, livelihood opportunities, legal aid, contacting families, all those steps are being taken up by our team at MHI. So I will not go into those details. If you'd like to know more, we'll obviously can chat one-on-one later. So I'll wrap up by saying that MHI's approach to rights-based mental health and the promotion of rights of mentally ill persons depends on 4 interlinkages. That's what we believe in, that this work depends on interlinkages. One is the individual and the social factors that contribute to mental illness. That interlink has to be made. Second, in our response to mental illness, the personal as well as community response are very important and need to be seen together. Thirdly, governments and other support systems, including NGOs, need to work together and we need to interlink that. And fourthly, the professionals who provide mental health services must work in coordination, collaboration, and participation with mentally ill persons. I think we don't, unfortunately, uphold the rights of people and believe that they should participate and be able to inform their own recovery and care. And the kind of work that MHI has done, we have been able to demonstrate that actually better mental health outcomes are possible when the patient themselves are involved in the process. So these interlinkages is what we believe in. Thank you for giving me some time to speak.
That's not fair. You didn't give me the chance to tap my pins.
I'm sorry, sir. I'm trying to give everybody.
Okay. So I now invite Dr. Rajiv Mehta, Senior Consultant, Department of Psychiatry, Sangar Hospital. And you would like to thank your previous colleagues because they've given you some extra time. So I'll give you liberally 8 minutes now.
Right. Thank you so much, sir. Honorable Chairperson, sir, Chairperson for the session, co-panelists and delegates, a very warm good afternoon. I'm speaking on behalf of most of the psychiatrists. Most of the psychiatrists are generally stand-alone psychiatrists, clinician with a table and chair and a receptionist cum secretary. They don't have so much paraphernalia with them. So what they face during these things, during the treatment of the patients and about their rights, I'm going to talk about them. Recently, WhatsApp group was created on MSCA 2017 and everybody poured their messages. From there to you people, I'm here to speak from a clinician perspective. Next, please. So I have been hearing out all the things since morning. So how we are generally picturizing a mental health patient with mental illness. Generally, our brain is wired to see them as an extremely ill, without insight, dangerous to the society, who's incapable of taking his own charge and taking decision for himself, and he can't be easily corrected or caused. But believe me, that's a skewed presentation. That may be a significant amount, but the mental illness are on a range from mild to severe. So we have to think about the milder cases also, the moderate cases also. What we are thinking about is generally about the severe cases. Next slide, please. Definitely, their rights are hinged. There is many rights are hinged. Definitely, there is a truth in this question, but for how many percentage of those people? Can this statement be generalized that everybody right is infringed or broken up? No, it is portraying us as a villain. The family, the clinician and the society as a villain. Next slide, please. So can the rights of the person with mental illness be completely achieved without protecting the rights of their family members and the professional taking their care. We have to see that, because the PMI, the person with mental illness, can only be empowered when their caretakers, that is the family carers and the doctors who are treating them, are empowered and trusted, because that's when the disease can be arrested or controlled earlier, as has been spoken earlier also, and ultimately that will lead to a more dignified life and enhanced social value. Next, please. So basic facts have been spoken, that there is a deficiency in the resources and the actual provision of the psychiatrist and other infrastructure. Next slide, please. So what we have to look is at those 70 to 80% of the people in India with mental disorder live with their families, which is true across all the demographic and social variables. So we have to empower these families so that the persons with mental illness can be empowered and their rights can be given to them. Next slide, please. Next slide. So what the clinical issue we face generally, when there is unwillingness for treatment, the medicines can't be given unless and until the person has become harmful to self or others. And if the willingness is there, he can be given. And when the person is so harmful, he will require a supported admission till that person gains capacity to take a decision, and then again it is on his wish whether he continues treatment or not. Again, advance directive has been spoken of earlier. The person can wish that he can't be treated. So what happens in this case? Please, next slide, please. So won't the condition become a burden on and off the family, that he is still ill and he can't be treated if he is not willing to get the treatment because he cannot get admitted? And more so as the Indian is becoming nuclear family oriented nowadays. In a joint family, many persons can take a burden, but with a nuclear family, what will happen? So should such a person be separated from the family because the family members also have rights? Won't their rights get hampered by living with the person who's mentally ill, can be treated, but is not willing for treatment? And if yes, he has to be separated, who will take the care? We already have discussed that there is inadequate infrastructure and resources. And if no, then should the family be kept on suffering? Next slide, please. So suppose, case scenario is what I'm giving. There is a nuclear family. Husband is working, wife is a housewife with 2 small children. Husband is depressed and suicidal, agrees he has a problem. There is a capacity that, okay, I have a problem, but doesn't wish to be treated, and wife doesn't wish or can't admit him. What to do in this scenario? Similarly, next slide, 3-membered family, parents retired with the 35-year-old son, the only breadwinner of the family. Son is having suspiciousness towards his colleagues. He has left 5 jobs because of this illness. He doesn't wish to go to the office or join another job. He is not violent at all at home. Previously, he was treated. He improved. He left the treatment. Now he doesn't agree for further treatment. What to do? As a clinician, we are at the end. We cannot give anything. Next slide, please. So now the family member reaches the doctor with the patient for the help. But the patient is not willing for the treatment. So what should we do? We are caught in a battle between humanity and legality. Humanity wise, as a doctor, I need to treat him. But legality wise, with this act, I cannot treat him because he is unwilling for the treatment. I will have to wait till he becomes dangerous to the self or to the society. And just imagine in what scenario the patient will be likely to enjoy his more rights, with treatment at this age or without treatment in the long run. Next slide, please. Next slide, please. So problem arises when the patient doesn't wish to take treatment and can't be admitted for various reasons. Maybe it be financial, human resources, not enough severity of illness. So the importance of family carers who make up the dominant workforce in the mental health care. Remember, India is family oriented, not individual oriented. We are we, not me. So we need to think of those family carers in a way degrades their family rights, competence and guardianships. Parents will raise their children in India till he gets a job. If he remains unemployed, that may be lifelong. So we need to see the rights of the families also. The routine requirements of the patient are met by their families, who also frequently become their target of behavioral outbursts from the patient. Family supervised medicines, transports, finances, etc., etc. So there should be an option for the family members to participate in the decision making, which will ensure a continuum of care to the patient and would give the family to chance to receive a psychosocial support, including instructions how to care as well as lowering the risk of the patient abuse. Next slide, please. Similarly, with the clinician, the act can be counterproductive because nowadays we are giving highly legalized pattern of care. We need to see, we are on a defensive nowadays. So exposing clinical exercise and decision to the judicial system or curtailing the clinical decision making capacity of the treating clinician, which may have paradoxical consequences in the form of barriers to care. So what will be the long-term consequences? There will be defensive practice. We won't take up the highly difficult cases. So where they will go? They will go to the government institutes, and the load on the government hospitals will increase. And just we discussed that 85% of the workforce in psychiatry field is a private. And with all these things, explanation that you should get treatment, with all the record keeping and everything, with a standalone psychiatrist, he needs to take another 2 or 3 colleagues with him, the treatment will get costlier and costlier. The doctor will show less empathy because he is now afraid in such cases. And there, I see at least 1 or 2 cases per day, such cases. So there will be decreased empathy of the doctor, distrust for the doctor. There will be altercation between the patient and his family and the doctors, and there will be increased legality. Maybe the doctor gets saved in the end, but the process will be a punishment. So it will be like a legal terrorism. I'm sorry to use such a strong word. So not mentioning the involuntary community treatment in MSCA, it reduces the patient's right to get suitable and optimal treatment at the right time. That is early on, limiting the well-being of the mentally ill people, and there is an infringement on the rights of the patient's family also. So there have been debate. It is a debatable topic. It is not a right thing, but it needs a thorough thought that how to treat such kind of patients so that their rights are maintained. Next slide, please. So logically, we need a balanced approach. Rather than a copy-paste law, we need a make in India law considering the interest of every stakeholder, be it the family, be it the society, be it the doctor, and considering the resources available to us. Otherwise, there are chances of legal terrorism, like with the dowry or the domestic violence acts which had happened in before. And these deficits, it is suggested that should be addressed by replacing the principle of best interest that justifies paternalism with principle that promotes dignity and the right to exercise full legal capacity in order to enhance autonomy and person-centered care. Next slide, please. So there can be a fusion legislation, a single law which applies to everyone, including people with mental and physical health condition, but they do not fully align with the CRPD and human rights perspective. Or do we really need a law for the mental health? Do we really need law for the physical health? Why do we need a law for the mental health? Because there is a decision-taking capability for some conditions. Otherwise, it is similarly like a physical law, physical health. It is all biological. We just don't have the technology to tell about that biology. It's all a brain disorder. Next slide, please. Next slide. So myths are another contributor to stigma, and they need to be dispelled at mass scale using all methods. People need to get educated, and we have to come back from the fantasy world to the factual world and increase the resources first, infrastructure, manpower, financial and educational, so that the rights are maintained. Till then, the patients do have rights, so do his family and the treating clinicians. And India's uniqueness of family cohesiveness and trust on the doctors should not be misplaced for the want of just having the rights only for the severely mental ill. We have to consider the moderate and milder cases also. Thank you all.
Thank you, Dr. Rajiv Mehta. I now invite Ms. Veena Agarwal. She is chairperson of Sanjeevani Society for Mental Health. Madam, you have 8 minutes.
Good evening, distinguished guests, ladies and gentlemen, and Chairperson NHRC and my other guests, my fellow speakers. I begin by saying a big thank you to the NHRC for organizing such a forum to speak on such a relevant and important subject on mental health. National Human Rights Commission. The one word that significantly stands out for me is human. Each human has a right to health, and mental health is a fundamental requirement for every individual, for every human. Why mental health? If my mental health is good and physical health is a problem, I can very well take care of my physical health, I can get the required treatment and move on. But if my physical health is great and mental health is challenged or is compromised, then my entire life is going to be deeply disturbed. So I'd say that mental health is health. This is where Sanjeevani Society for Mental Health and humans, we join hands. At Sanjeevani, we are an organization who have been contributing in the field of mental health since 1976. We are a voluntary organization, and volunteers are our backbone. Volunteers are our strength. We volunteers, we are ordinary, common people coming from the community. We are selected from the community, we are stringently selected for basic qualities that we have: empathy, sensitivity towards other people's needs, some listening ability to be able to listen to somebody in a non-judgmental approach. The Crisis Intervention Center at Sanjeevani offers a free, confidential, and a very safe space to anyone above the age of 18 years. Anyone can come in and speak and share. We give them a safe space to talk about the problems that they're going through. The nature of problems that we've faced where people come with could be a very different nature. Somebody feeling lonely, somebody going through a bereavement, or mental illness in the family, addiction, or relationship issues. It could be many of them. Talking to a counselor helps the person get in touch with his or her own strengths, and he is able to walk out of Sanjeevani feeling empowered, capable to handle his or her own challenges today and in future. So counseling process is a preventive measure. And if mental health issues not addressed at an early age or at an early stage, I would say, can really aggravate, and it might require maybe more professional, more serious medical intervention. So prevention is definitely better than cure. Another wing of Sanjeevani is we run a rehabilitation center. This rehabilitation center is a daycare center for those people who have been diagnosed with severe mental illnesses like schizophrenia or bipolar, have been on medication, and now need to be reintegrated into the mainstream society. Our program offers behavior modification, helping them to enhance their social skills, improve their communication skills so that they're able to take responsibility for themselves as they move on. This wing of Sanjeevani is run by qualified professionals under the guidance of a psychiatrist. And our program at the Rehabilitation Center comprises of individual counseling for these people suffering with mental illness, group activities, which could be art, music, dance, yoga, some skill building. And we also have family meetings for the caregivers of these people who are living with mental illness. As a recent initiative at Sanjeevani, we have also introduced webinars and talks by specialists, by psychiatrists for the caregivers. We've also had support group meetings, which have got great results because the caregivers find that space as a great space to share, understand, and learn from each other's experiences. I'd say Sanjeevani started speaking about mental health when no one did. We've been 50 years, almost 50 years in this space, pioneers here. And we have witnessed the increase in mental health issues. When we started Sanjeevani, we would barely get 2 or 3 or maybe 4 calls a day. To now, we have a wait list of 200 plus people. We try our best to our ability to help as many as we can. But again, we are just one center. Of course, the wait list does highlight 2 points. One is, as I mentioned, the increase in the number of mental health issues growing. And secondly, is also that the community seems to be ready. They are now open to seeking professional help. And in that space, I'd like to take great pride the way Sanjeevani has been doing great work in creating awareness. We reach out to society, the society where schools, colleges, corporates, creating awareness programs where we conduct workshops for them. This is a part of our community outreach program. Very recently, we've also released videos on YouTube. They are available by the name Baatein Dil Ki, which are on different subjects on mental health. And these have received millions of viewers and have really benefited a lot of people in the community. As I say a lot about what we've done, definitely a lot has been done, yet a lot remains to be done. As was being mentioned by my fellow panelists in the previous section, where there were statistics given about how the growing large population of India and any number of psychiatrists, any number of counselors, doctors, therapists, psychologists will not be enough to cater to the growing need. So then what is the answer? What is the solution? The answer lies in the community itself, where the mental health issues lie. The need of the hour is to mobilize the community, to create awareness, to make each and every person come out and talk about mental health very freely, without a taboo. Sanjeevani has been doing our bit to destigmatize and to remove the taboo. While we are a small organization and we're doing our bit, I'd like to take this opportunity to urge the NHRC, because they are a huge platform. They have a larger reach. If they could help out in creating awareness, some concrete suggestions that I could think of is that while we are one center, we could do with 50 more Sanjeevanis, we could do with so many more centers, help out, support. Let's have more such centers to prevent mental health. Maybe support and organize more community level programs. 3, create awareness among students, school teachers, universities, parents of young children who are in close contact with young people, because mental health issues, as we understand, begins when we are young. So nipping in the bud is the need. Again, mass campaigns. We all know how mass campaigns can have an impact. Say the example of polio eradication. A celebrity lending a voice to a cause can take the voice to every house, every home. When we hear Mr. Bachchan say, "Do boond zindagi ki," we know what impact it has had on the polio program. As we are all here and collectively, I see it as how we, each of us, can join hands, we each individual, we can join hands and come forward and try and see how we can make mental health a subject, a topic of discussion, and take it to every household. Thank you. On a closing note, I'd just like to say how fulfilled and satisfied I am going back home today, knowing that mental health is being discussed so seriously and in such a mainstream discussion. Thank you, NHRC. Thank you for bringing up this forum.
also, ma'am, happy that you got a good time compared to other colleagues on the panel.
Thank you.
Full time almost. So to my co-chair now, Dr. Nand Kumar, Professor of Psychiatry, AIMS. To you, sir.
Thank you, sir. Thank you, Chairman, sir, NHRC and members for inviting me here. And I'm really feeling privileged. In fact, to begin with the first talk by Manoj Yadavji, he very beautifully mentioned that reintegration of the patient with the family. I think we talk about the reintegration of the patient with the society, but without integrating the family, the person cannot be in the society. So that is very, very important aspect that he has mentioned. Family constraint, when we talk about the human rights of the patient, we forget about family constraint. And we all know that each family has their own constraint in terms of their financial issues and job and space issue and other things. So that is very important thing that he has mentioned. We need to do that, some deliberation on that also. One of the important thing that sir has mentioned about the suicide. It is very heartening to know that, as madam has mentioned, that we have more number of psychiatrists and psychologists today, but suicide is also increasing. We have more number of suicide if you compare the last 5 years than today. So approximately 400 people die with suicide daily in India. That's so painful, and most of these are preventable, in fact. When we talk about suicide, most of the time or almost invariably we don't touch the prison. And Manoj Yadavji has very well mentioned about the prison mental health. The situation in prison is something like that, like in few states, prison in few states have no psychiatrist. Say for example, Uttar Pradesh, Madhya Pradesh, they have no psychiatrist. And in Haryana also, 1 or 2 psychiatrists. So this is extremely untouched area in terms of mental health. And the person who goes to the prison, I think anyone can go to the prison if you look at the law, and we may be at wrong side of laws at some point of time. And there is a very close connection between the mental health, judicial system, and the prison. We have some work in the prison, Tihar prison in fact, and we have been discussing about bigger resources, like we don't have the psychiatrists, that's true. We need more number of psychiatrists. But what we can do till we don't have the psychiatrists? Another important issue is that it is also mentioned several times that psychiatrists are not only the solution, because mental health is too big to be left alone to psychiatrists. And today's session is on also empowerment. The inherent system of the treatment that what we offer, there is some sort of disempowerment. Like once you go to the doctor, psychiatrist or psychologist, your decision-making capacity is questioned. So if you look at the 3 components of the empowerment, like competency and social engagement, plus self-confidence. So these all are basically taken away by the doctors. Say for example, if some patient with manic episode comes to the doctor, the treatment offered is you cannot take this decision, you cannot go to the office, you cannot go for the job, you have to be at home till I tell you, means till psychiatrist tell. So empowerment starts from the messages what we give, and the family and other social things are very, very important. Coming back to the prison, I would like to share very small experiment that what we have done for 3-4 years in Tihar prison. There was a high number of suicide in Tihar prison, and approximately 7 to 8 suicide used to happen per year. That was the reported data, in fact. If you look at the other reason for death, so that was an unnatural death, but not suicide. So that could be suicide also. So we tried to do something like what we call psychological first aid for the prison. We adopted this model from WHO, Geneva, and we took permission from WHO also. And we developed 8-hour programs. This 8-hour program is just for the inmates and the person who are willing to take part in the mental health psychological first aid prevention program. As Manojji has mentioned, we need a screening tool, in fact. So what we did, we started screening all the person who coming to the prison, all the inmates coming to the prison at the entrance. And we developed some sort of a screening tool that takes about 1 hour, 40 minutes to fill up. It's on paper, in fact. And what we observed, that a good number of people had mental health issue, in fact. And 80% of people, they accepted that they want to have some sort of help. They did not say that they have mental health, they have mental illness, but they have the problem, they want to speak to someone. So just by speaking to someone and having some sort of empathy and some sort of communication, meaningful communication, that can resolve a lot of issue. So we did this program for 3-4 years till October 22. This 8-hour program was organized by one organization, and we conceived this program. And the delivery person of this program was the psychologists, not the clinical psychologists in MPhil. They were just master in psychology. So if you look at the resources, we have huge resources. Lot of people who are master in psychology, they don't have that training, good clinical training. So what we did, we trained those people with 8 hours program and further 8 hours program to reinforce that training part, and they had gone to the prison. And with the help of the psychiatrists over there and prison administration, they imparted this program to the prison inmates. A good number of prison inmates came out to support this program, and they also become the service provider. And in this way, we try to intervene in psychological issues, and approximately 30,000 inmates got intervened through this program. And during the COVID time, we have some problem, so we could not continue that. Then again, we restarted. So what I'm trying to tell you that at a very low cost, because these counselors, they were the student, they wanted to have the training somewhere, and we wanted the manpower. So we trained them with this program. They did the work for 3 months, some sort of internship, and they learned a lot. And most of them mentioned that their life also has changed, because they are seeing the prison inmates from a close distance, and they are able to perhaps understand. And reintegration into society is in much, much better way if somebody understands the prison inmates and their mental makeup, and they are also human. So with small resources also, perhaps we can do some meaningful thing. If anyone interested in this program of psychological first for a reason, they can communicate to us, and I can share we have developed 2 manuals, and these manuals are printed, and I will be happy to perhaps share that and support in whatever best possible way. Would you like to sum up? We can do that. So the next speaker, Dr. Santosh, thank you very much for highlighting that part of maternal depression. It is almost left untreated, and unfortunately we don't recognize that in the family and society. The person goes to the doctor, but it is considered normal behavior. So that is very important concept that we have highlighted. Of course, postpartum psychosis, that is a very, very important area that perhaps we have highlighted. In addition to PON, already we have discussed in other session, and that is important part. Thank you for sharing your Ara Janani Yojana, that is teaching yoga in pregnancy for better health, both mental and physical health. Then Dr. Shruti Mariwala, thank you very much for mentioning the that MI, mental illness, social factor is very important, and that cannot be left to the psychiatrist and psychologists. So that perhaps we keep on listening that also. Your Miljul program seems to be very, very beautiful, and that may be promoted perhaps for the other part of the country. And one important part that we have mentioned is the patient involvement in the recovery. I think most of the time what we do, the patient involvement, perhaps we don't take that into consideration and we focus more on the family and the other system like job. Dr. Rajiv Mehta has very beautifully mentioned about the picture of the psychiatric, typical psychiatric patient and the challenges being faced by the psychiatrist in a practice, clinical practice, and that skewed picture that what we commonly face. And the issue of legality and humanity, that is also very, very important, and we frame the human rights of the patient, that also perhaps need to be considered very, very carefully. Of course, that matters, the empathy of the psychiatrist, but psychiatrists are also human, perhaps, and empathy is a reserve fuel most likely. So that needs to be perhaps looked into a different way. We were one of the idea like, make in India law, that seems to be perhaps very good, and a lot of issue that has been discussed and raised in the last 3 technical sessions. Perhaps that can be addressed through that. Thank you for introducing Sanjeevani, Veena Agrawal ji. And we are aware about Sanjeevani. We keep on sending patients there also. And I can say with confidence that it's doing very good job. But reintegration part is very, very important. As you have mentioned, increase in mental health issues are there with increasing psychologists and psychiatrists and multiple courses. So I think that education is very, very important. It's not about that mental illness and mental health. Most of the important thing is that still we are not very clear about the dynamics of mental health and mental illness. So that needs to be addressed somewhere. And I completely agree with you. The focus and solution is in the community. We keep on increasing that number, but there is no end point. So the awareness about your own health, that is perhaps very, very important. And it is absolutely fantastic that we have mentioned. We cannot separate. Mind, body, we can't separate. In fact, there is a very good saying, you cannot treat mind with the mind. Say, for example, if you're feeling low, feeling depressed, then you have to go for a walk. You have to activate the body. If you're in isolation, that you have to meet someone. So I think that concept of separating, segregating the mind and the body and multiple health, that is perhaps we have to rethink on that, how to get away from that. With this, I thank you all for participating in this session. Thank you very much.
I was shortly going to open it for discussion. So, okay, first.
For example, a person meets with an accident.
Sir, for the benefit of others, I would request you to identify yourself.
I am Sitaram Murthy, Chairperson, Andhra Pradesh State Human Rights Commission, sir. Andhra Pradesh State Human Rights Commission. A person meets with an accident. Because of the injury, he is only having vegetative existence. A learned person informed me that he is not covered by the present enactment. Why he is left out? The second submission is, Sri Manoj Yadav also mentioned about prisons and all. A person committed an offence, he is remanded to judicial custody for 14 days. By the time he returns back, because he is not enlarged on bail for extension of remand, his mental makeup is totally different. He is depressed. So these remand prisoners, most of them, 60 to 7%, go out being acquitted, and in the trials end in acquittal. So unnecessarily they are being subjected to depressions, and these prisons and jails are becoming brooding centers for these people with depressions. Can't we have separate centers for these remand prisoners to be kept without mixing them with convicts? That's the second submission. Third submission is the line we draw between intellectual disability and the insanity. Mostly we see this in children. They have a difficulty in thinking, understanding the limitations on their cognitive functions. they are also being taken to these mental hospitals, which is not good for children. We have separate courts for children, offenses against children. Why not separate care centers for children suffering with these disabilities? These are my 3 submissions.
Okay, so who would like to respond to the first question on the vegetative state? And do you want to respond, Dr. The question, as I understood it, sir, is that in a certain case, a person was in a vegetative state and consciously unable to take decisions in a coma, but he's not covered by the provisions of this act. Why so? Yes, sir.
I think the person who is not able to take a decision, and as per the act, there is no advance directive. So that depends upon the treating psychiatrist, the treating medical team regarding the patient's treatment part.
Treatment is something that, but is not covered by the act. Any law for the time being. What I'm told by a specialist on the field.
So you mentioned about intellectual disability also. That is the
third submission.
That's the second question.
We draw a distinction between insanity and idiocy. Likewise, earlier we used to call it as mental retardation. Now we are calling it as intellectual.
There is a provision that disability act
it would
earlier,
which we discussed in your.
Yeah.
There is a provision in that.
Disability Act.
Taken off the parents in that case.
So under Disability Act it comes.
That takes care of this.
Third question.
So on the first question, the person is in coma. In the Disability Act,
in that case, parents' consent can be taken or husband's consent.
the next to the kin, basically. Next to the kin,
There is a provision.
there is a provision for that. The next to the kin.
So
But
first
that
question,
provision is termed to be a little arbitrary, sometimes misuse.
Yes, sir.
so we have a ruling on the first question, so now we move on to the next question. Yes, Manoj. That's focused on you, the second question. The second question was women prisoners.
So I think, sir, I'm in agreement with you. As has been extensively documented throughout the country, that more than 50% of the prison population in India comprises of under trials. And there are inherent delays in our process. And most of them belong to lower sections of society who are financially disadvantaged. They cannot afford a good lawyer who can get their bail. So it also goes against the principle of equity. And lots of things happen because when we analyze the data of suicides in prisons, we find that a very large number of under trials commit suicides. And what happens is that particularly they are most vulnerable to suicide in 2 or 3 days after their bail petition rejection by the court. Because when the hope dies, in him, and he looks to an uncertain and prolonged incarceration. And therefore, I think as a system, in the Arnesh Kumar judgment, court has recognized that we should not, do unnecessary arrests. National Police Commission has said, Honorable Supreme Court has said, that the power to arrest is one thing, but you have to justify the arrest, why you need to arrest. But unfortunately, the police refuses to listen, and there are a lot of unnecessary arrests. Even the society insists. The law says you cannot arrest, but the public expects, the victim expects the person to be arrested. So I think it is a very good idea on your part to think of a separate facility for these under trial prisoners. Also, the issue of addiction among these under trials, lot of petty crime is committed by addicts, and when they land up in prison because under the NDPS Act or something, their withdrawal symptoms happen. As we already observed, there is no psychiatrist in the jail. It's not possible to give them buprenorphine or anything, and therefore many of these people are also highly vulnerable to suicides. So therefore, in fact, we need those having some symptoms of addiction or mental illness. There needs to be a separate jail in every state where they can be sent for specialized treatment. We cannot have top quality psychiatric care in every jail in a state. But if you can in one jail where the court can refer them, that will be great, sir. I think your point is very well taken.
Thank you, Manoj. Now for the third question. Okay, right, sir.
Sir, as you rightly pointed out, there is a slight confusion and overlap also. We have seen in a lot of cases where the children were either hearing challenged and had some other issues, and they had attention deficit disorders, hyperactivity disorders, and they were actually nomenclatured as mental illness. This happens, but usually they don't take the children to psychiatrist. Most of the time it is taken to a pediatrician, then referred to a developmental pediatrician, and if at that level it is not done, then it is referred to usually. So usually a developmental pediatrician diagnoses it, and it is on the basis of, not just normal diagnosis, but you do a diagnosis based on your IQ and SQ, EQ, everything is tested. So it is not very easy to label here and there. There are 10% or 5% of some issues, but 95% of the cases they are diagnosed whether it is intellectual disability or mental illness. There's a clear demarcation.
In the present day nuclear families, it is only partial parental care, not total parental care.
Yeah.
Definitely.
Joint family disintegration.
Yeah, but there is some amount of overlap for sure. There is some overlap. So yeah.
Yeah.
Sir, could I also the definition of mental illness also separates. Yes, sir. Normally after lunch there are no questions. I thank you, sir, for having endorsed the performance of this panel. Yes, Ashok, for you.
Sir, that is a serious problem. That
Only a question, not a comment. We are running short of time. So question.
It's not exactly a question, sir. It is an observation from our
then a brief
field
one.
visits.
Brief one.
Sir, it's a serious problem that our mental health institutions are overcrowded, mostly because cured patients are not being sent back to the connecting with their family, or they have to continue there. So during my field visit, the impression that I got that once patient is cured, he is no more responsibility of that medical institution. From that point onward, he is responsibility of the social welfare department in case there is no family to take him back. And when I interacted with the social welfare officials of the social welfare department, my sense is the impression that I got that social welfare department in the state level are not, alive to this problem. They are, the awareness is just absent. So this is a huge gap there. The department which is responsible does not know that it is their responsibility, and they have to come up with this all infrastructure of halfway homes and the center.
Thank you, Ashok. That problem is endemic, and that is why the chairperson had flagged it. Ketan Patil. I'll come back to you, sir. Ketan Patil.
Person, I just want to ask an important question to Dr. Santosh and Dr. Nandakumar. Dr. Santosh talk about yoga in pregnancy. Dr. Gangadhar also talk about yoga in mainstream psychiatric treatment. I want to ask question, mainstreaming of Ayurvedic medicine or indigenous medicine in psychiatric treatment. In Charak Samhita, there are more than 500 herbs which are used for psychiatric treatment. Is there any research going on, and the medicines like Brahmi, Shankh-Pushpi, Sarp-Gandha, Ashwagandha, there are various indigenous medicines available. We are just focusing on Western medicine based treatment. So is there any policy for mainstreaming of Ayush medicines in mental health ailment? Thank you.
Yes, please. Question was directed to
So, so I'm not an Ayurvedic doctor, so I'm an allopathic doctor. So I cannot comment a lot on Ayurvedic medication. But one thing for sure that we are noticing with yoga, meditation, and in yoga, Ashtanga yoga, there is yama, niyama, what to do, what not to do, how to go out, when not to go out, and all these things. We're seeing a huge difference, especially in the way the mothers and the children, they have their own, capacity to correct themselves or balance themselves or face any pressures at home. So it gives them a lot of self-confidence and also a lot of balance in terms of how to cope up with these stresses and strains. Regarding the Ayurvedic medication, I think I am not the right person to comment. But in breastfeeding, again, we are using a lot of Ayurvedic medications because that's what we deal with day in and day out. We run a chain of human milk banks. So, but for the rest of the things, if the panel has comments.
Yes, Dr. Nandkumar.
Thank you. Regarding this Ayurvedic medication, a lot of medications, say for example, primarily Ashwagandha, Brahmi, Bach, it has been used. There is some preclinical trial also that is conducted recently, and recently the regional AIIMS they have signed MOU with Ayush, Ministry of Ayush, to work in this area. But preclinical trials are there, clinical trials are there. In fact, some other medication like Arjun Chal and other things, it is also being tried, and trial is complete. They have positive impact. But the only issue is that the integration. The integration part is missing here because allopathic doctors are reluctant to prescribe Ayurvedic medication. So if this integration can happen and the barrier can be broken, perhaps things can be much, much better and people can be empowered in terms of treatment at least.
So for your benefit, Dr. Ketan, the Act permits that. The Act permits different schools of medicine to treat mental illness. Number two, Dr. V.K. Paul, if you recall, said earlier in the day that the Niti Aayog is recommending integration of these different schools of medicine. So we go on to the next question, Dr. Dhamija of IBHAS. Yes,
Thank
sir.
you. Thank you, Mike. A very small comment to Mrs. Veena Agarwal. There are many other centers also providing the same kind of crisis intervention center. Do we care about the mental health of the service providers? The reason why I'm asking is that I happen to be one of the volunteers working in this field, organization called Sumetri. So I was a volunteer there. Like you said, the volunteers are selected on the basis of their qualities of empathy, whether they can sensitive to the needs of the sufferers, and so on and so forth. So I worked for a few years actually, and then I became trainer also there. So during my work there for at least 3-4 years, so we were having all these calls, and the calls were much more during the exam results time. And one of those months of July or August when the results came, one of the volunteers committed suicide. So after that volunteer was working for many years, and one fine morning I was called upon in the morning that such and such person who is working as a volunteer, so who was providing a service on a volunteer basis without any remuneration. He was a professional person, an IIT person, giving his time and his skills to take up the calls, telephonic calls, as a crisis intervention, lost his life. So do we have any inherent mechanism to look after the
Counseling
mental
of
health
counselors?
He was not a professional counselor. We trained them as a counselor. I also was a volunteer for many years. So that was actually a lifelong mark in my mind also, that these things can happen when you're working in an environment of such a stressful, pressurized, a pressure cooker environment, where you take up the calls from different, you have a listening ability, you listen to these calls, you provide them time, you provide them listening ears, you provide them space. You think that the crisis would go away when you listen to them, that half an hour of time will go away and the person will change his mind, and that suicide will be prevented. And I believe we have prevented many suicides. So, but that incident left a permanent mark in my mind. So do we have inherent mechanism to look after the mental health of those people who provide time and energy and skill to help others? Thank you.
Thank you, Dr. Damija, for a very, very valid question. So there are various ways in which at Sanjeevani we do protect our volunteers. That's your question, right? So to begin with, our selection process. Our selection process itself is very stringent, where we take a lot of factors into mind. As I said, empathy, listening, sensitivity is a basis. At the same time, we have a very extensive form which also lets us know the stage at which the applicant is at, what is the stage of his life, how a person responds and reacts to, sensitive situations, because we also understand while we as volunteers are here to help out other people who are in need, but we also need to be protected. So it's very important that we protect the applicant before he or she is chosen to be a volunteer. So that's the first level of protection where we offer before we intake. Secondly, at our in the way that we function, we also have a supervisory system where each of us, each volunteer has been assigned a supervisor, and the supervisor in turn also has a supervisor. So none of us are left unattended. That's a huge support system where we are able to deal with our issues if something gets triggered in a session, because we're humans. End of the day, it's very normal if somebody touches upon a topic of somebody's lost a dear one, and if there's something happening back home, it's very normal that my pain, which might have been subsided, gets triggered. So we have that huge support system. In addition to that, we also have our own in-house, we have workshops where we are trained and skilled. We have our own in-circle support groups where we discuss what's happening to us. And we have our recharge days, recharge occasions. So a lot is done at Sanjeevani to take care of the volunteers, if that helps to answer your question, sir.
I think everything was in place at that organization also, but sometimes you also need debriefing sessions. So after all this kind of exposure, if somebody is having a debriefing session, that might help. So that was probably, I also advised them that we should have a debriefing session after those pressure cooker instances.
Correct. So as you said, I was talking about the supervision.
Thank you very much.
Our supervision system does take care of that.
So now we'll have the last question, Mr. Jayantu Chaudhary, Special Rapporteur, NHRC.
I'm Jayantu Chaudhary, Special Monitor from the NHRC. My question, since we have two very senior former police officer and a serving police officer, there's a lot of confusion about the role of the police after this new act. I know I should have asked it in the earlier session, but Dr. Balia talked about a violent incident that he had come across. Now, the police very often, you might say they should go to the social welfare, but they are the first point of contact. And all of them say that under this new act, we have no role. I was speaking to Dr. Datta, who's come from Tezpur. He says under the act, the police have a role for rehabilitation and something else, but not at the point of contact. So if some guidelines could be given, that would be very helpful
Sir, it is, there's a specific rule, but since I am now retired and Manoj is the serving one, he will respond.
Section 100 to 100. Section 100 to 100. 100 to 100.
Sir, it is, I'll tell you where the role is. One is at the initial point of contact when a police person comes across a vagrant who has lost his mind or something. Another is where a person in a locality refers to the police person, look, there's a mad guy out there, or someone has lost his senses or something like that. So the police officer is supposed to take that person and present him to the medical officer for a diagnosis of
Judicial magistrate.
both. दोनों दिया हुआ है, sir.
Sir, may I respond, sir? Sir, may I respond?
Just a moment, let the serving officer first respond.
So, sir, sir, to answer your question, I'll answer, sir, both in theory and practice. So the new Mental Health Act, Section 100 and 101, squarely deal with this subject. Under Section 100, a police officer in charge of a police station shall have a duty to take under protection any person found wandering at large within the limits of the police station, whom the officer has reason to believe has mental illness, and to take him under such a person under protection, and then present him before a magistrate. And the magistrate under Section 101 has been given the authority to refer such a person to a mental health institution. In fact, in the opening address in the morning, the chairman, sir, clearly pointed out that the reason to, that the power to order a person to be taken to a mental health institution includes the power to take him out if such a person has been cured. It is an inherent power. But in practice, it is clear that those belonging to marginalized sections of society, they often become, they are abandoned by the families, they become vagrant, they become beset with all kinds of diseases and wounds, and generally it is the police which finds them. Even traditionally, even before the act came, when we went to Ranchi, we discovered that bulk of these patients had been brought there by the police. And it is just the police is the first, because they are always on the streets, and a homeless, destitute person with mental illness is likely to be found on the streets. Many of them do not remember where they came from. They do not have any address slip with them, particularly older inmates. So therefore, both in practice and in law, police role is limited to identifying such persons, taking them into protective custody, obtaining the order of the magistrate, and then delivering them to a mental health institution, sir, within 24 hours. And similarly for the custodial thing also, they have a role.
Last, final comment, no more.
I think sir has pointed a valid question, very important question. Somehow after this introduction act, police and judiciary is just struggling with responsibilities. They start struggling. They are not taking care of that way. That's sad part. They supposed not to happen, but somehow in Delhi state itself, they are police. I'm just talking about WhatsApp group now, and the police people, they are not getting orders from the magistrate. So somewhere I wish let NHRC instruct police and judiciary the roles.
Yes,
at least
so
100 by 6, 106, 107. 106 meant for rehabilitation part, 107 for lodging FIR. Still now, no FIR lodged from Delhi state. Sad part. Even we are talking implementation of the act, where somehow police is not taking responsibility.
So
Even
now
judiciary.
what the NHRC is doing is, let me apprise you that we have shortly embarked on a program of training police officers in a limited way. So one is, we had already done a few years back, we had created a course curriculum, circulated it to all the police organizations, plus we had authored a digital course on the IGNOU portal, IGNOU Open University portal, which anyone could undertake. Also, in some of our orders, we order the police officers to undergo a human rights course. In addition, later in August, we are having a course of training for trainers for the police officers exclusively on human rights. In addition, we are also going to have internship course for police officers every year as a flagship event of the NHRC. In addition, finally, we are also in the process of defining minimum course content on human rights, which could be imparted as part of the basic course and the in-service course for all ranks of police, including constable, sub-inspector, inspector, DSP, etc. So thank you very much. I thank my panelists for being so kind, and all of you for being awake in the post-lunch session. Thank you very much.
Thank you
And
to
a
the
vote
chair.
of thanks for the chairperson, and the widespread participation in the discussion shows the success of this session. Thank you, sir.
Thank you, Chair, Co-Chair, and the panelists. May I request Mrs. Anita Sinha, Joint Secretary at HRC, to please present a memento to the Chair of the session and Co-Chair and the panelists. Mr. Manojian.
Thank you so much.
माइनिंग में है
Thank you. With this, we conclude the third technical session and take a break for tea for 15 minutes and reassemble for the fourth technical session. Thank you.
Check. Hello, 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 hello. Hello, hello, hello.
Check, check, hello.
Check. Hello, hello, hello.
Check, check, check.
Hello, hello, check, hello, hello, hello,
Check,
hello.
check, check.
Hello, check. Hello, hello. Hello, check. Hello. Hello, check. Hello, hello, hello. Hello, check. Hello, check. Hello, hello, hello. Hello, check. Hello. Hello, check.
दो तीन इसी के से हेलो हेलो हाँ इसी से हो गया फिर हो गए एक फोल्डर यहाँ पर सर यहाँ पर तो अरे वो मूले पर छोड़ना
हेलो 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 माइक चेक हेलो हेलो
पीछे है ना इसका रिमोट नहीं है
Hello, check, check, check. 1, 2, 3. Hello, 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 hello.
May I have your attention, please, ladies and gentlemen? Please be seated. We are about to begin the fourth technical session of this conference. देवियों सज्जनों, आप सभी से अनुरोध है कि सभागार में अपना स्थान ग्रहण करें। अब से कुछ ही पलों में हम चौथे सत्र की शुरुआत करेंगे। सभागार के बाहर जितने भी लोग हैं उन सभी से अनुरोध है कि कृपया सभागार के भीतर आएं। We begin with the fourth technical session. The theme is latest trends in critical care of mental health, international perspective and way forward. The duration of the session is about 1.5 hours. May I request the chair of the session, Dr. Gyaneshwar Manohar Mule, Honorable Member NHRC, and the co-chair, Dr. Atreyi Ganguly of WHO India. Please take your seats on the dais. May I also request the panelists of this session to please take their seats on the dais. May I request Dr. Nimesh Desai, Senior Consultant Psychiatrist, former Director, IHBAS, Delhi. Dr. Nimesh Desai. Dr. Narmadeshwar Prasad, Director, Parliament and Administrative Research Institute, Delhi, is also requested to please take his seat on the dais. Professor Rakesh Chadha, Head of the Department, Psychiatry, AIIMS, Delhi. Dr. Dhirendra Kumar, President, Indian Association of Clinical Psychologists. Dr. Chiranjeev Bhattacharya, National Program Manager, UNDP. And Dr. Bhuvak Garg, Associate Professor, Psychiatry, Lady Hardinge Medical College, Delhi, and Directorate General Health Services. And Dr. Varun Shantilal Mehta, Associate Professor of Psychiatry, Central Institute of Psychiatry, Ranchi. We request Dr. Bhuvak Garg and Dr. Varun Shantilal Mehta to please join us from the chairs there, as we have the paucity of the space. With the permission of the chair, may I say a few lines about Dr. Gyaneshwar Manohar Mule, Honorable Member NHRC, who is an author, poet, diplomat, and humanist, working relentlessly for the rights of vulnerable sections of society, and particularly the citizens of the country, facing a situation of rights violations on foreign lands. He is also affectionately known as the passport man of India when he simplified the system of getting passports in a seamless manner for the people of the country. Dr. Atreyi Ganguly is a National Program Officer at WHO India. She has been very closely keeping an eye on the health issues and the progress made in addressing them. May I now request the chair of the session to please take forward the proceedings.
Thank you. Good evening, everyone. I know this is the last session. Nevertheless, I do feel that it's one of the most important topics that we are discussing. So the title of this particular session is Latest Trends in Critical Care, Mental Health, International Perspective and Way Forward. In the morning sessions, you have discussed, rather we have all discussed the Act, then the infrastructure available for the mental health treatment and facilities, and we also discussed the right of the mental health patients. This dealt with generally what is there and what should be there. But this particular session aims to discuss what is the way forward, what are the trends that emerge from all the discussions, and as our member Rajiv Jain ji said, that NHRC and the human rights framework also makes it imperative to us that we keep a watch on the international perspective, and also all our rules, regulations, acts are also in harmony with what is happening internationally, the best practices, particularly, but also the conventions and the covenants of the United Nations. So from that perspective also, this is going to be an important session. We have time constraint, of course. I'll just put it in the context in just a minute or so. We have all realized one thing, that the approach should be holistic. There has to be an involvement of the cutting edge technology. We have to also look at the therapeutic interventions, and also the community support, the family support, institutional support, and the infrastructure as we discussed in the past. So that is very important. Quickly, what are the trends? I'll just mention rather than going into details of each of them. We have telepsychiatry and digital mental health, psychedelic assisted therapies, integrative care models, trauma-enforced care, artificial intelligence and machine learning, which is really currently in discussion to a very great extent. Then peer support programs, again, constitutes a very important part of the trends that we are seeing now. And focus on resilience and preventive care, how to really, go to these things and achieve more resilience and more preventive care, so that there is less stress on the institutional bodies. We also have to embrace innovation, evidence-based practices, and a patient-centered approach. And what is the way forward? These are the trends that I mentioned. Way forward is, again, pointers only here. Early intervention and prevention, extremely important. Integration of mental and physical health care, because that also will really lead to holistic treatment. Strengthen crisis helplines and hotlines. There are a number of them already, but there has to be a coordination, and maybe sometimes the person should be available at the other end of the helpline. Crisis intervention teams have also acquired importance now, because if you don't have on-site, off-site facilities available, we may not be able to succeed to the extent that we want. And then after crisis intervention teams, we have mobile crisis units, equally important. Then enhanced access to mental health services. We discussed this extensively the whole day and have tackled various dimensions of this particular aspect. Telepsychiatry and e-mental health. We have had e-Manas and other measures or schemes discussed this during this day. Then collaborative care model. Again, very important that the various segments of society properly coordinate, whether it is police, whether it is judiciary, whether it is social service organizations, civil society organizations, of course, mental health care centers. Research and data collection. This is one area generally we lack hugely. And even if we do research, it doesn't see the day of light due to the lack of proper journals, proper opportunities or exposure. So I think this is where India can contribute greatly, but I think currently we lack to a very great extent. Just having an act is not going to be enough. Then family and peer support, we have deliberated quite adequately on this aspect. And finally, empowering individuals in their recovery, because ultimately it is the individual who has to fight his own ailment or deficiency or mental health issues. So with this, I pause here, and I would like to apologize to two of our panelists who have to sit. We never expected that everybody will come, but this is such a wonderful thing that everybody we invited is here, and that also shows the interest that is being developed. So my panelists, co-panelists here are laughing at this.
That's humorous.
But let's cheer them. Let's.
It's great for them.
I know, I understand. So right to equal chair.
My session 2%
Didn't? Okay. So let me start, and I'll request my, a co-chair to maybe say a few words, and then we quickly move to the. Due to time constraint, we have to just see that we speak for about 5 to 6 minutes, and if necessary, maybe you can go up to 8 minutes. Thank you.
Yeah, so thank you so much, sir. At the outset, I would like to thank the organizers for giving WHO this opportunity. Definitely, the full house in this session shows the importance this particular topic has in the minds of the people, and we've seen how everybody has turned up. So this is a great success to mental health, and which is being discussed since morning. Just a few words on international perspective. Well, WHO is a global technical agency for health, and it basically, when we are talking about international perspective, I think India has showed the path. We had in the morning our minister saying that Sarve Santu Sukhina, Sarve Santu Niramaya. Essentially, it is what WHO's definition for health. It is mental, physical, and spiritual well-being, and not just the absence of disease or infirmity. Definitely, from an international perspective, the rights of people with any disability and UNCRPD do form the basis of any guidance that WHO leads out. Yes, it is very important not just to address any disease when after the onset of the disease. WHO recommends from prevention to palliation, and mental health promotion. The COVID has shown how important it is, and mental health promotion is across everybody. So mental health promotion followed by early diagnosis, treatment, and palliation is how we can ensure the rights of people who are having such issues. And definitely I would endorse the role of whole of government, whole of society. We will all have to join hands in this endeavor, and none of us are alone. So with these words, I welcome our honorable speaker today, the first speaker, Dr. Nimesh Desai, who had been senior consultant psychiatrist and former director IBHAS, Delhi, to please grace the occasion and share his inputs. Thank you.
Good afternoon. The laughter that the chairperson's remarks induced was actually a good sign of what I'm going to keep referring to. But I was laughing also, sir, because I wanted to say I would have been happy to opt out. The two chairpersons for this session, the chairperson NHRC Mishra Saab, Rajiv Jain Saab, Mule Saab, and the other NHRC officials, my friends in psychiatry and mental health profession. I think those are the only two groups that we now have with us, NHRC group and the mental health professionals. First of all, like we said, please be sure that if I'm able to pass on some humor sense through the slides that I'm going to use, be sure that's by no means any lightness of the subject or the content involved. But in our science, we know humor is possibly the best possible defense mechanism, Freudian. And as some of us will recall, one of those intellectuals of the 20th century, Khushwant Singh, used to say, the ability to laugh at issues that bother, and issues about ourselves is actually a sign of a good cultural mechanism too. And so that's about humor. Ladies and gentlemen, also be sure, I sincerely don't believe that everything that is on these slides should be read out. These slides are, as they are called, if you recall, audiovisual aids. So I'm going to request all of you to please train your both senses, read what you like or see what you like on these slides, and listen to what I have to add to that. I must say, with the fullest respect, and this is more a comment on, let me just make sure I get used to this. Am I? That's the story of India, and it's been for a while. The other one is this. But I do want to say that one observation that I've had since the morning is that while there has been the most sincere, commendable, highest level effort to identify the theme as beyond carrying mental health beyond institutions, willy-nilly, if you recall, about 2/3, if not 3/4 of the time, we're actually spent still talking about institutions. So somewhere it seems to be too ingrained in us as well as a part of the reality. But I'm saying that also to build my next issue. And I invoke Ghalib here. मस्जिद में बैठ के शराब पीने दे साकी या वो जगह बता दे जहां खुदा ना हो. There is not, and I respectfully submit. Do I point it here or do I point it there? Where? I mean, where does this work actually? At the screen, sir? Thank you. Although mental health institutions have been maligned and justifiably so most often, and they require monitoring and supervision, there is not a nook and corner of human existence where people with disability or mental illness do not get discriminated against. Let's be sure about that. And I bet all the little money that I have in life on that. Not a single nook or corner. It's ubiquitous. So it's wonderful that we are now talking about going beyond institutions. We really have to monitor all aspects of human society. Briefly, there is a huge gap. Firstly, like it has been mentioned, let's be sure we talk about the full spectrum of mental health and not just about severe mental disorders. Concern for human rights obviously is more for the people with severe mental disorders. And yet we need to be sure, if you specially take not just section 18, which assures mental health care as a right, but also 2A, which defines mental health care. Like Dr. Atre was saying, WHO's definition or scope, from identification to complete rehab. And so there is really a huge spectrum that we are talking about. It was established some years ago that treatment gap is huge just for accessing treatment once. But if you talk about service gap for mental health rehab services, or the full spectrum of services, it could be nearly 100%. I mean, with the large population that we have. What are the critical issues in mental health? I'm going to try and address the three components of the title of this session. One, suicide risk assessment and management is being talked about. Disasters, epidemic, conflict situations, homelessness and homebound PMIs. This is, ladies and gentlemen, really one of the frontline issues in the 21st century, at least on the social front of mental health. Domestic violence, DV and other such instances, alcohol, drug abuse problems, dual diagnosis and comorbidities, personality disorders, people with violent crimes, and we have seen enough of that in last 1 year or so. But most importantly, unlike the American triple diagnosis of HIV, drug abuse, and mental illness, as I have started referring to, triple diagnosis of persons with personality disorders, with alcohol and drug abuse, and severe mental disorder. That is the group that's actually the most difficult to manage for everyone concerned. What are the international perspectives? I'm really trying to give what I have learned in 40 odd years as the nichode, the distillate of how I have understood it. So bear with me if there are simplifications or reductionisms. Are there good practice models of mental health anywhere in the world? And again, with all respect, I say no. None really. Except for perhaps New Zealand, Nordic countries, or very few of those countries with zero population growth for 40 years, huge abundance of resources and everything else. Is there a good international model of mental health with human rights perspectives protected? Really, no. Are there lessons to learn from other countries in international perspective? Sure, plenty. But is there one model for the world that can work when it comes to human rights and mental health? An assertive no. There's a huge lot of relativism of human rights concepts and guidelines. And I remember having heard the NHRC chairperson, Mishra Saab, some years ago in one of those Vigyan Bhavan functions talking about this, underscoring this. I think soon after he had taken over. There cannot be one universal global model of human rights or human rights and mental health for sure. Is there a need for contextualization of mental health care models? I don't think anyone in this house would disagree with that. And so, the challenge and the opportunity for India, I don't know how, somehow that screen seems to hide that. is an assertive yes. Like it's been referred to, there is one opportunity here, besides other fields, for us to demonstrate a viable model for mental health care with human rights protected and promoted. What's the way forward? Should we be repeating the Western or the American model? And I say West in inverted commas for whatever, again, simplification that it holds. For sure not. Let us not repeat the mistakes that the American culture has already made. And my hobby horse, as some of you know, my favorite concept and concern, over psychiatricization of human existence. We don't want to do that. While we want to increase mental illness treatment seeking, we want mental health awareness, we want services, we want to make sure that we can help the society deal with day-to-day issues on their own. What are the issues for insurance? Public funded like Ayushman Bharat and privately purchased. A huge one. Of course, with the Act providing what's to be done, that's one resting ground, but the job is not done at all. What about the softer issues referred to today? Confidentiality, medical neutrality, which in mental health practice is extremely difficult, individual or group situations. Telemental health services and digital mental health services, enough has been said, and I'm going to possibly refer to one part of that, the whole issue of need for counseling services. During the epidemic, at least we heard this enough, there's going to be a psychiatric epidemic soon after this epidemic. There's been none. Is there an epidemic of psychological distress? Was there one? Yes. So was there need for some counseling services and support? Yes. But there is, of course, a problem there too that I'll refer to. That and the pharmaceutical industry, you will see in the next few slides. But there's a huge juggernaut of pharmaceutical industry which cuts both ways, especially in psychopharmacology. Please be sure. And as I'll refer to, my successor at IBAS, Dr. Dhananjay Saab, referred to that in his presentation, assertive, proactive outreach services. Mobile mental health unit that was referred to, I will not say more about that, but that's what you achieve, ladies and gentlemen, through assertive outreach services for homeless populations. For me, this one slide has been enough for any meeting, especially with policymakers. But this is the role of the pharmaceutical industry. Let's not forget, I have no hesitation in accepting that psychopharmacology has done huge help to mental health sector, psychiatric practice, persons with mental illness and their families. But there is a commercial angle to that. And I wish we had more time to discuss that. We need to guard against that. And of course, the whole issue of counseling. Beware of the day when the washing machine manufacturer catches up on the word counseling. I don't have a washing machine at home. If I go to buy a washing machine, whether I need a front loading or top loading, do I need semi-automatic or automatic? That'll be called counseling. And why not? My point, ladies and gentlemen, is, and with all respect again, I'm a very diehard patriot and citizen of this country, but we do have a bit of a tendency of expansion at the cost of dilution. We need to guard against that, especially when it comes to what will be referred to as counseling. Different grades or types of counseling. That's my major point. And towards the end, if you'll recall, Helsinki Declaration identified 3. In the 70s, 4th principle was added. Autonomy, justice, non-malfeasance, and beneficence was added. My learning in last few years has been painfully that the Western individual-oriented, autonomy-based models of human rights have actually perhaps exceeded. There is an equal need to emphasize on justice. The human rights of the carers and family members, the human rights of the mental health providers, the human rights of those faceless, nameless victims of crimes and other acts that will happen related to mental illness when untreated. So there is a larger principle of justice also to be woven into the human rights framework in general, if I might say, and certainly when it comes to mental health for countries like ours. And not cut and paste. We are legally bound to follow UNCRPD, and there is no doubt in my mind about that. As of now, the Indian Parliament having ratified it, we are duty bound. Every one of us as citizen, every agency, every dot, every comma and full stop. But is UNCRPD really to be accepted as a universally applicable document in toto, or should we have the courage to start talking about the UNCRPD kind of document or human rights framework for India, South Asia, and possibly take leadership, at least for some part of the Afro-Asian world. Macabre. But please see the depth of this slide. The issue of human rights can be carried too far sometimes. Thank you so much.
Thank you, sir, for this opening presentation. We now move to Dr. Narmadeshwar Prasad, Director, Parliamentary and Administrative Research Institute, Delhi. Sir, my humble request, due to interest of time, if you could have a presentation for 7 minutes.
Okay, thank you. Good evening, everyone. Thank you very much, Chairman Sir, NHRC and Chair and Co-Chair for giving me this opportunity. And end of the day, it has been a very illuminating discussion so far. And probably I'll run the danger of repeating a lot of things. So idea is that I should not do that. And it's a learning experience for me. Before I begin, with sincere apologies to my psychiatric friends here, it's not about you or against you. This is a book by Routledge, International Handbook of Critical Mental Health, edited by Bruce M. Z. Cohen in 2018. He says, the mental health experts have made little progress in the last 40 years to eliminate the problems of the mental health system. The science of mental illness is as contested as it was in the 1970s. The key issues, as they've summarized, the cause of any mental illness has yet to be established. The psychiatrists and other mental health experts cannot yet agree with any preciseness on the type of mental disease a person has, or indeed whether they are mentally ill or not. No treatment, drugs, ECT, therapy, and so on, has been proved to work on specific symptoms of a mental illness or as an ultimate cure for a mental illness. Future cases, modeling of mental illness cannot be accurately predicted by mental health experts. These are the facts. These are already written, and probably most of you have read about it. Now, coming to the topic, moving mental health beyond institutions. I understand this is very good document by WHO, which is World Mental Health Report 2022, and chapter 7 actually talks about this when we go to moving beyond institutions and actually depending on community health system. Now I will just go about the policy shift about the people suffering from mental illness. Historically, a person with mental illness were viewed as dangerous, lunatics of unsound mind. We had Indian Lunacy Act of 1912, which was modeled on English Lunacy Act of 1890. Then Western Australia repealed that act of Lunacy Act of 1903 and brought mental health in 1962. Some of the acts of the Commonwealth countries use words like insane, imbecile, mentally defective. See the shift where we have come from. The Mental Health Act of England and Wales of 1983 was brought telling people with their mental health problems about their rights, and that was the first time they used rights about people suffering from mental health. Internationally, this was reflected in the adoption of the principles of protection of persons with mental illness, commonly called MI principles, by the United Nations General Assembly in 1991. And that is a watershed moment. See, a French sociologist, Durkheim, in 1952, talked of structural functionalist theory that addressed increasing rates of suicide as a result of the breakdown in the shared norms and values of society, recognizing mental illness being structurally caused. So my friends, I think we have to get into the cause, how people become mentally ill or go to commit suicide. And that is where the human rights come, and an organization like Human Rights Commission is a commendable job they have done. And policy, people with a policy background who are actually not talking about the only treatment and scientific treatment or medical treatment. That is where it is required. See the farmer suicide. We all read newspaper and say that he had a mental health issue. Why he commits suicide? You go deep into it, and you'll know why he has committed suicide. Now, another shift, the UN Convention on, a lot of people have talked about it, adopted by General Assembly in 2006, has shifted discourse further towards the entitlements and rights of PWMI, a more collaborative, empowering discourse. And mental health became one of the 9 core human rights adopted by the UN. So now we are more inclusive and a humane society. Most of the countries brought about policies and laws to govern a compassionate mental health policy. Rights clearly defined, as our 2017 Act, you can see. Labeling and legal implications have changed. And we have been labeling, entire feminist movement is about this, that we brand somebody. Even now, the new generation is talking about PMSing, something which is very, very serious, and we don't even realize that how we start branding people. Even women who are spinsters, we brand them, that probably they'll have some mental condition. So with LGBT rights, definitions have also changed. For example, like Mr. Jain talked about, that we have not talked about decriminalization of suicide. So attempted suicide through Mental Health Care Act, which was punishable under Section 309 of IPC. Homosexuality was considered to be a mental disorder till 1973, which was modified as a sexual orientation disturbance, because there was voting in the DSM and the society, and that almost 60% people didn't agree. So they changed to sexual orientation disturbance, and finally removed out of DSM in 1987. So a lot of things will change from what has been there, and with society becoming humane, and when we talk about things which are not watertight. Now I'll just talk about little gaps, that is on the 3 aspects: information gap, resource gap, and governance gap internationally. The data collected are not accurate. Data reported from poorer countries come exclusively from government psychiatric hospitals and do not include interventions provided in general hospitals, community settings, schools, private sector, etc. Some of my co-panelists or panelists before they've spoken on this. This is a major limitation given the importance of moving mental health care away from psychiatric hospitals to community-based settings. The resource gap. Limited implementation of mental health plans, policies, and legislation is in fact in part due to lack of resource, both human and financial. The Mental Health Atlas 2020 shows only 50% of the countries, total countries members of WHO, with mental health policy or plan have estimated the financial resources they need to implement it. 60% include an estimate of human resources required. Only a third, which around 60 countries, have actually allocated financial and human resources. So this is the gap that affects the implementation of mental health treatment or system. Then the governance gap. 86% of WHO members, which is around 146 countries, have a mental health policy or a plan in place, either standalone or integrated into general health policy. 90 nations had a plan specifically for children and adolescents. That means 50% of the country don't have any plan for children and adolescents. A third of the members have not updated their plans after 2017, which we already have seen pandemic. Only 50% of members have reported that their mental health policies or plans are fully complied with human rights instruments. However, only 20% could fully implement their plans as fully compliant with human rights instruments. So this is the governance gap. Now briefly I'll go through technological advancement, and that is changing the face of mental health care. It has been talked about it. I have taken the case of Canada that, of course, telemedicine, we also have, the problem with us is that we do not have internet still for more than 50% of our population. These countries have very small population. They have, they have the access to internet. So tools like TELUS, EMR, Virtual Visit of Canada, and Virtual Pharmacy have done a good job. Electronic medical records, it has been a catalyst for tremendous change in healthcare all over the world. Apps. In Canada, apps like TELUS Health Specialized Digital Therapy are empowering patients to independently track their symptoms, practice mindfulness and cognitive behavioral therapy techniques. These apps offer healthcare solutions to the public, also facilitate conversation with service providers from the comfort of their homes. Wearables. Now, most psychiatric disorders are misdiagnosed. I'm sorry again. Therefore, the wearables may be able to change that by collecting real-time psychological information that allows physicians to provide more informed treatment. Virtual reality. Through simulated scenarios and prescription video games, people may be able to fight their phobias. Artificial intelligence, use of chatbots and AI technology from WooBot to Vysa can help detect even changes in a patient voice, and by reading health patterns and trends, can recognize warning signs for mental health concerns. Now, I just ignore that because this is again the repetition. Then you have, I'd like to go to the way forward straightway, because there is something should be the outcome. The community-based solutions, the very theme of this conference, community-based solution, that is triaging and getting the first point of contact. There, I believe we have to decide that first point of contact, and I go a little away from here. First point of contact for a farmer could be a sarpanch, because he knows everyone, and if there is any behavior, maybe the farmer has lost his crop, and what happens? They take a loan, and if he doesn't get it, the crop has been spoiled, and the crop insurance policy. I'll give you one analogy, that suppose you have a shop in a market and it catches fire, and then after that you go to insurance company, he comes to your shop and say that okay, your shop has caught fire, but then the entire market has caught fire, then only we can give your claim. And that is what happens with the farmer's insurance policy. I'm sorry to say. Anybody can go through, read it. So the thing is that if he has one failed crop, he goes for second, he takes loan, and the third one, he has no choice. So the panchayat, the sarpanch could be the first point of contact. Now, in the schools, we are talking about counseling students and all, the teachers are the first point of contact. Okay, they know if there is some deviation in the behavior of the child, if he's becoming silent, he's not talking, my children studied in Mothers International Delhi, it's one of the very good schools. I have seen the teachers, physics teacher and chemistry teacher, talking to him in front of me, shaming. It's like, of course, as a parent, you can't just say anything to a teacher because you are always scared. But the way, they need to be sensitized. They are not. So we have to have the first point of contact. Even I come from Parliament, I have manned a section, and then maybe 30, 40 people or 100 people. See, the thing is that if I am a section officer or a supervisor, I know my people who are coming in section. I should know if there's something missing, or he is taking leave frequently, or he's going early, and he suddenly stopped talking. His output is not working. So those are the people should be trained. I'm sorry, the capacity building, we're talking about, we have a commission, but we don't like it. We don't like training. And even when government has a lot of plans, private corporates, they'll train you for getting more money, more, productivity, but not the health development. I'm just closing. Okay. So, sufficient funding. I just want to highlight here that the government mental health organizations, they should learn how to take the endowment. Recently, I read that NIMHANS got 100 crores endowment from Nilekani Trust. You know, that is one source. And Indians are really, really rich. I see 30 crores spending on the marriage, you know, booking the guest house and, resort and all. If the manager or the head of the organization has that capacity, or, you know, he can just go and talk to people that, look, we need some fund. Funds will come. I mean, we have to work on the international model that the director should not feel shy that why should I go and ask for money? I mean, it's a government organization. But the thing is that money will come, people will give a lot of money through this. The endowment scheme, a scholarship scheme, there are a lot of things that can come in, and you can generate thousands of crores. And the Government of India has told the universities to raise their funds. So I think here, this could be one of the recommendations. And continuous, nuanced, accurate and honest data collection. The lawmaking, I was there in Parliament for 23 years. I don't want to go into detail, but yes, we need a lot of reforms in lawmaking. Research people who are there in the law drafting, legal drafting, they are very poor people. And our members of Parliament, I am sorry to say, they do everything but to legislate. They are legislators, but they are not interested. So that's a sad part of the entire story. So there, I do not know, when we can start legislating well or better. Then the exposure, international exposure to our leaders, not only people who are in mental health, but every leader who's running organization, running people, even army or paramilitary forces or anyone, they should be exposed to the international standard, that how they have to be compassionate, they have to take care of their people. They could be the first point of contact, and and they can find out. So I think with this, we should more concentrate on the preventive mode of mental health. Of course, and once somebody has become ill, he has to go to hospital, whether it's general hospital or mental hospital, he'll be treated, and whatever the resources that we have. But I think we should start working for the mission 2047. At least we have one prime minister who has started talking about developed country. I mean, so far we have been talking about developing country or least developing countries, but at least 2047 is a benchmark. 25 years is a good time, and this is the time that we should do this and start working in that direction. Thank you very much.
Thank you, Dr. Prasad. Thank you, Dr. Prasad. Definitely, we have to work for Mission 2047 now. Our next speaker today is Professor Rakesh Chadha, Head of Department Psychiatry, AIIMS, New Delhi. Sir, again, a humble request due to paucity of time, if you could limit it to 7 minutes, please.
Definitely. Honorable Chairperson, Co-Chair, Chairperson of National Human Rights Commission and members, a warm good evening. So, the theme of this conference organized by NHRC is moving mental health beyond institutions. So I'll try to avoid anything which has been covered since morning. So topic for this session is latest trends in critical care in mental health, international perspective. Fortunately, I have had experience of working in general hospital setting as well as psychiatric hospital setting. I was for around 9 years in IBHAS during its formative years. And I also have worked in UK for about a year, so that I will be able to discuss from all those experiences. If we talk about the latest trends in critical care in mental health from international perspective, something which we are not having in India, there's the early intervention services, which have been introduced in the Western countries in last 15, 20 years. And those are mainly for the psychotic disorders, early identification and management of psychotic disorders in the community. That's one area where we are lacking. India has done very well, if I say that, in reducing stigma related to mental disorders. Though it's often said that there is more stigma in India. So I would say that is not true. In last 6-7 decades, since the time of independence, India has established large number of general hospital psychiatry units, and there was more emphasis on developing psychiatric units in the general hospitals rather than starting the mental hospitals. So our number of mental hospitals, number of beds in the mental hospitals have always been limited. And the general hospital psychiatric units, they are offering services in the least stigmatizing settings. Our general hospital psychiatric settings, they are located they are easily accessible. Like if I talk about AIIMS, our psychiatry ward is on first floor. In front or other side of the psychiatry ward is the dermatology ward. One floor above is the medicine ward. Same way, our OPD is located within the network of all other outpatient clinics, other disciplines, and same is the case with most of the general hospitals, most of the medical colleges. And general hospital psychiatry units have been one of the major providers of psychiatric services, besides definitely the private sector, which also is one of the key players. And psychiatric hospitals, they come more at the second level, I would say, as far as outpatient services are concerned. Now, when we are talking about the latest trends, are critical care in mental health. Now, I'll be talking more from the general hospital setting, how we can provide services in the critical care or say critical issues in mental health. When we talk about suppose a person in the community develops a severe mental health issue or psychiatric emergency, where does he or she go? Now, family members may be able to bring the person to a psychiatric service. Now, these are the cases where the families are there. And in most of the patients, in our setup in India, nearly 90% of the patients, I would say, Dr. Mehta in the morning said 80%, I would say 90% of our patients, they live with the families. Now, where the family is able to bring the person, now there are cases where the person may not be agreeable to that, to coming to the hospital, but wherever the person is, it's possible the person can be brought to the general emergency. Now, general emergency, generally the psychiatrist is not there, psychiatrist is on call and is called when a person reaches there, but there are no adequate settings for assessment of doing assessment of a person with mental health issues. So that's one area where we need to create facilities. So that's one of the areas. There could be if there could be directions from the NHRC towards to the Department of Health and at the central government, at the state governments, that this kind of facilities should be created in the general emergencies, maybe 4-bedded, 6-bedded, that kind of thing, that can take care of, that would be a very important development in the providing the critical care in mental health in the general hospital. And we have, I think, more than 500 medical colleges would be having general hospital psychiatric services, and so that kind of facility can be created. Same way in the other public sector hospitals, district hospital definitely can't have an exclusive facility. The other thing is that creating similar kind of facilities, once the person gets admitted, similar kind of facility for critical care, say in the these are persons who have attempted suicide, some persons who are needing intensive care. Intensive care is generally required first 2 or 3 days of admission. So 4 to 6 bedded units next to the nursing station, persons who are at high suicide risk, who are not able to take care of themselves, or violent or aggressive patients. So that kind of facility in critical care. That's another facility which can be created in the general hospital psychiatry units. That's thing. The other is then critical care, critical problems in psychiatry, they develop in the intensive care units, be it a cardiac care unit, cardiac ICU, it could be a neuro ICU. And in the last 3 years, we have seen a lot of patients who are admitted with the COVID, and they were in the intensive care, or they were not, there was no, because all the carers, be it doctor, be it the supportive staff, nurses, or say other caring staff, they were full of, in the full dress and they were not recognizable. So that was creating a lot of critical mental health issues. And the similar thing happens in the cardiac care unit or cardiac ICU or neuro ICU. So that's another area where we need to have dedicated mental health team, which is not there at the moment. Though in the general hospitals, like at AIIMS, we are able to provide services when we are called. But as such, there is no dedicated team. Yeah, I'm going to finish. Yeah. So that's another area. So then is the psychiatry in the disaster settings. A disaster has, like recently we are having even the city of Delhi and many other states, there have been massive floods, people have lost houses, so they are under major stress. Sometimes we have a similar situation occurs in the background of the earthquakes. So that's another area where we need a critical care in mental health. And so dedicated disaster teams, NDMA, National Disaster Management Authority, has been working, has developed its own guidelines in disaster mental health. So that's another area where we need critical care in mental health, and where we need to have dedicated mental health teams, and which can be withdrawn definitely from the medical colleges or the mental health institutions or the mental hospitals. So these are some of the different areas which I needed to discuss, that where we need critical care in mental health. And internationally, we have lesson of early, as I said, early intervention services for psychosis. But besides that, I don't think we have any other models. We had telemedicine or telepsychiatry, which we developed, which came into popularity during the COVID, and with the Telemanas and some other these initiatives taken by the Ministry of Health, that's another area which also helps in providing crisis intervention in the critical mental health issues. Thank you.
Thank you, sir. Now we move on to Dr. Dhirendra Kumar, Dhirendra Kumar, President, Indian Association of Clinical Psychologists. Sir, another request to you, please, if you could limit it to 7 minutes.
Sure. Chair, co-chair, and chairperson NHRC, other NHRC members, and fellow mental health professionals. Much has been already told, and I would not like you to revise the same thing again and again. But there is one thing that I would like to highlight. The disability burden in 2010 was about 2.5 trillion, and it would be about $6 trillion in 2030. And the allocation of resources to mental health care is very meager if we look at it. Two major concerns in mental health care that arise are accessibility and credible delivery. And most of the things related to these are covered, but one thing I would like to discuss here, that is artificial intelligence, because that's the latest development and it has impacted every aspect tremendously. There are chatbots like VBot, and there is Vyasa, then Talkspace. What they are doing, they are providing text-based services for relationship issues. Like if we look at the prevention aspect, relationship issues and stress, and they are quite effective in that aspect, and they are building models to identify the severe conditions in which other referrals should be made. Talkspace has developed a suicide alert system also, like in the session and the communication. If there are variations in the tone of communication, it can identify suicidal tendencies, and can alert the therapist. There are many advantages of AI in the field, like it can make mental health care more accessible to people. Like the therapist can't be available 24/7, but these can work 24/7. These can help us in reaching to remote places where low mental health professional availability is there. It can also help us in countering the stigma. And AI can also help us in improving the diagnosis. There have been studies in which they have identified different patterns in depression itself. So it can help the professional in making better diagnosis and fine-tuning the treatments also. It can also identify the health risks, and it can also help in adhering to the treatment protocol so that standardized care is provided. It can also help in individualization. As an adjunct to mental health professionals, it can be a very good tool, but there are certain concerns related to it. One of the concerns is that it loses the human touch. Another is the data privacy. There have been instances in the companies related to providing these mental health care services through the AI of data breach, patient identification. Another most important thing in this would be, like, it can help in keeping the therapist on track, and it can also enhance the quality of the training by providing the feedback. AI can have biases because it would be programmed by a human, and it can incorporate those biases. Privacy challenges we have discussed, and there are other general beliefs also that can become a hindrance, like many of the people in a survey by Pew Group indicated that they would not like to be treated by these. But for the people who are willing, it can make mental health care more accessible. But at the same time, we have to remember that the technological advances are not going to wait for us. The policymakers and the mental health professionals have to look into it. And if we do not look into it, there can be unethical use of these services, and it can cause more harm than benefit. So I think there should be policy level decisions, and there are certain guidelines for these things that we are not going to highlight here. There is one more aspect related to mental health practice in India right now. Like, if we see mental health services in India, there are mental health professionals, psychiatrists, clinical psychologists, psychiatric social workers, and psychiatric nurses. There have been UGC guidelines, NEP, and because of the NEP, there have been a hindrance in the clinical psychology training programs. I, as a president of Indian Association of Clinical Psychologists, would like to highlight that here. IACP worked a lot during the pandemic. We were the first organization to run a multilingual helpline for mental health support. We helped Ministry of Social Justice and Empowerment in running the helpline Kiran. And later on, it developed into Telemanas and other things. Now, there is one conceptualization that mental health training, specifically clinical psychology, can be done in 4+1 years. And that is not possible. Like, if we see 4+1 years is okay for general psychologists that we have been discussing since morning. But clinical psychologists are specialists in making clinical diagnosis, formulating treatments, and providing rehabilitation. And as Dr. Desai said, expansion should not be at the cost of dilution. By degrading this clinical psychology program, it would be dilution in the quality, and it will hamper the rights of people with mental health to get the quality care. And this was the very reason because of which National Commission for Allied and Healthcare Profession Act 2021 excluded clinical psychologists from the allied mental health professionals. So here my humble submission to NHRC is that they should look into it, because it violates the rights of the people with mental health concerns, and should issue some guidelines to respective government agencies to work in this direction. Okay, I have got the time limit. So I would like to conclude here with the request to NHRC to write, like there is one more point at the end that I would like to add. There are about 55 training centers for the clinical psychology, and they are producing about 500 clinical psychologists each year. And many of the centers are not able to run MPhil in clinical psychology since the last year because of this issue. So it should be looked into. Thank you all.
Thank you very much, sir. Now we move on to Dr. Chiranjeev Bhattacharya, the National Program Manager, HSS, UNDP. Sir, I request if you could limit it to 7 minutes, please.
Sure. Good evening, everyone. Respected Chairperson NHRC, respected Chair of the session, dignitaries on the dais, off the dais. So first and foremost, I would like to thank NHRC for inviting UNDP for this event, and I represent UNDP in this event, and for that matter, I'm going to focus on a report which has strongly looked into mental health at the global level. So that is the Human Development Report. As you all know that these are annual reports taken out by UNDP globally, and the last report, that is the 21-22 report, in an unprecedented manner has focused a lot on mental health. And this is basically what Dr. Desai was speaking on, the causality of mental health issues. So as you go through the slides, you will see, and I'm sure all of us already know, but this is what is documented in this global report, is the relation between mental health and human development. So we all know that this is, the causality is basically both ways, and it's a vicious cycle where mental distress can affect human development, and poor human development can again lead to mental distress. So this is what has been touched in this report. And as you can see, I will not go through the details in the slides, but it talks about how mental health at individual level affects at the community level, and then at the community level, if the society's cohesiveness is not there, it affects at the broader global level. And the report also acknowledged that while addressing these big issues at the global level or society level is not something which can be done immediately, or for which solutions may not be present, we can work towards policies which build the psychological resilience, psychosocial resilience of the communities, and this is one of the strong recommendations. So next slide, please. So there they have talked about taking a capacities approach to the human development. So as you can see in the initial stage, based on the poverty in the society at the household level or at the society level, the access to education is compromised, which is known as the conversion factor. And if the conversion factors cannot be met, that person cannot move to the next stage of the capacities, which can be in the form of good education, getting good employment, good income. And then if that is affected, the person's power to choose the capacities and ultimately to achieve is also affected. So this basically reflects that the effect in the life cycle approach is most prominent or profound at the childhood level. But having said that, if there is mental distress, even after converting to a good education and job, then also in the long run, leading a healthy life may be compromised. So it can be both at the childhood level and adult level, but the effect on the childhood level is more profound. Next. So the reports talked about the causalities in terms of the broader context in the global scenario right now. So one is the Anthropocene, where you know that the current planetary changes in terms of climate change, biodiversity loss, extreme events are basically changing our world in a big way. And each of these pathways has an effect in the mental health of the individual. In case of extreme events, you can just take the COVID-19 pandemics and the mortality that was associated with that. And more so, it is now been talked about that this is definitely not the last pandemic, and with the climate change, the number of zoonotic diseases may go and re-emerge, and we may see more pandemics. So these are definitely directly related to our mental health. And then food security also related to climate change. And as previous speakers has talked about it, this is again a big factor which can lead to mental stress, both from income point of view as well as in terms of getting good nutrition. Then obviously the other factors like biodiversity loss, which unfortunately again happens to communities like the indigenous communities, where the interface of nature and human habitat, and they are more affected in terms of these extreme climate events. Next, please. The next area is again economic insecurity. As we know that the report talks about the current scenario where after the pandemic there was the war in Ukraine and the breakdown on supply chain, high inflation in many of the countries. So that has led to job loss, economic shocks. In India also we have seen our EMIs go up so many times in the last 1.5 years, but at the same time, we know that this situation is much better in our country considered to even some of the developed countries. So globally, this is really affecting the mental health. And as you can see in this diagram, this can have an intergenerational effect in terms of if the effect is in the pregnant mother in the early stage, the infant is also affected, and that is also reflected in his or her life after birth. So it can be an intergenerational effect also. Next. The third area where we have been talking since the beginning, that is digitalization, innovation. So of course, digitalization has been a boon, and there are so many best practices people have talked about. Telemanas is coming in a big way in India. Similarly, overall telemedicine is taken up in a big way after the pandemic. But having said that, as esteemed panelists have just talked about, we also have to be cautious in terms of digitalization, because it is also giving a lot of challenges to us in terms of information overload, misinformation, data confidentiality, privacy issues, which also need to be balanced while scaling up different innovations. Next. And then other uncertainties which are affecting human mind is obviously violence. So many wars, conflicts are going on across the world. At the community level also, we can see in our own country or even different countries, there are so many different kinds of community level wars are going on, which is making a difference within communities or creating inequalities within communities. For example, within the developed world, so many cases of shooting and all are happening, which we come across time and again, which basically talks about acts as a proxy of the mind of the community. So the violence is again a big factor which is affecting the minds of the people. And of course, the age-old problem of stigma, discrimination, which continues to be associated with mental health, and more so for communities like indigenous communities, women, LGBTQI communities, people with disabilities. So if you look at properly, in fact, they are affected in double or triple manner, because they already have a layer of discrimination which is sort of leading to their mental distress, and on top of that, all those global challenges that we face now is adding layers to their distress. So they are furthermore disadvantaged in this current world. Next. So the report basically talks about 3 strategies, and I think people have touched upon this throughout the day. One is the bigger thing, that is prevent the distress in the societies, where we need to have strong institutions in terms of good laws, good policies, and examples. examples are like evidence shows that if good income is provided to a household, it has a positive impact on the growth of the child, mental health of the child. Similarly, good education can lead to even positive response towards climate response as well as reduction in discrimination. So these are some of the things which have a multi-sectoral approach which need to be addressed in a whole of society manner. And the other area is, of course, when we already have a crisis, what we have seen in COVID-19 pandemic, that how to transition during this crisis, it is very critical, and that's where the social protection mechanism or social protection schemes that avail in the country play a critical role. So we have seen that how basic universal income has played a role in many of the countries, and in our country also, the slew of COVID-19 welfare measures that were declared in terms of cash transfer or commodity transfer like dry ration have played a big role in mitigating the crisis and also helped in mitigating mental health distress. And lastly, of course, that we have been talking about in a very focused manner is how to build resilience, psychosocial support resilience. And as everyone has talked about, what has to be done in mental health institution, more or less we know. Of course, as Dr. Paul was very positive that we have to increase the numbers. Considering the numbers in India, definitely we have to increase the numbers. But then for basic depression or basic psychological support, work has to happen from the community level. There are multiple good practices in India and of course in other parts of the world, and both sides we can learn from each other. But at the same time, I'd just like to end by touching on two areas which at least I have not heard during the conversation today. One is, as I was talking about the social component in terms of mitigating the risk especially for the vulnerable and marginalized communities. So we are talking about short stay home for the poor people or marginalized people within the hospitals. So can we think about also provisioning linkages to social protection, jobs and livelihoods and skilling within those centers? Not in that center, but there can be linkages further where they can be linked and further linked to those welfare measures. Similarly, and then similar in NGO settings also similar things can be considered. The other area is certain vulnerable communities, for example, the LGBTQI communities. In the long run, we need to build the acceptability or discriminatory behavior we have to reduce in our general health system. But till the time it happens, we have seen and evidence has shown that they are more comfortable accessing services in community-based settings. So can we support some community-based settings and provide holistic integrated services to this community so their needs can be addressed? I think these are some of the additional points I want to address. And personally, I'm very motivated with the discussion that I have seen today, and hopefully we'll have a very long way ahead. Thank you.
Thank you, Dr. Chiranjeev. Now we move on to Dr. Bhavu Garg, Associate Professor, Psychiatry, Lady Hardinge Medical College, Delhi, and Directorate, DGHS. Sir, a request if you could limit it to 7 minutes.
Okay. Honorable Chairperson NHRC, the members of NHRC, Chairperson of the session, Dr. Mulya and Dr. Ganguly, my co-panelists and all the delegates of the conference, a very good evening to all of you. So the topic of the panel that I have been given, can I have my slides please? So the topic of the panel that I have been given is latest trends in critical care of mental health, international perspectives and way forward. Before I start with my presentation, 2 or 3 points that I would like to make. First about the title, the latest trends in critical care. So if we break down the title, so there are 2 components. Critical care, which like Dr. Chadha had covered, includes the care in the intensive care units in the intensive care settings. And latest trends in mental health will be a different topic altogether, covering the emerging topics or the emerging themes in mental health. Second aspect, the word trends. By the word trends, it signifies more of a longitudinal kind of a thing rather than a cross-sectional theme. So while searching for this topic, while preparing this topic, I have specifically tried to cover those issues, touch on those issues, which will be showing that trend process. That is, the topics which have been increasing their presence in the publications in the various articles in the journals. The trends or the issues which are coming up across the print media and the electronic media, the trends, the issues which are coming up in our discourse among various conferences, the various mental health conferences, as well as themes of the mental health awareness days given by WHO or the themes of various forums like these such conferences. So this was about the topic per se. The second point that I would like to make is many of the topics would have been covered in the initial sessions of this panel as well as the session in the morning. So I will not go in the details of those sessions. I will try to summarize those issues and cover the other sessions. So if you look at the latest trends based on the research that I've done, so they can be divided into three major aspects: the diagnostic aspect, the treatment aspect, and the social aspect. Among the diagnostic trends which we have been seeing, one major aspect which we have been seeing is the digital mental health in terms of for diagnosis, artificial intelligence based diagnosis, the inclusion of genetic testing and the imaging testing. Some of these aspects have been covered by one of my co-panelists, Dr. Dhirendra. So I'll just like to mention, in the recent years, the research has been focusing on using artificial intelligence to collate data from genetic testing, imaging testing, the patient's previous history and all the other details to reach a diagnosis and predict that this particular person is vulnerable to develop a psychological issue or a mental health condition in the future. So this is the role of AI in the diagnostic aspect. Among the treatment aspects, the in thing these days, the trend which we have been seeing is precision psychiatry. My teacher, Dr. Desai, is one of the co-panelists. He used to tell on our rounds, a day will come when we'll have designer psychiatric medications or medications which will target a particular aspect in the brain. I think we are moving towards that. It will be a few decades we reach that part, but we are moving towards that. So again, artificial intelligence based models or algorithms have come up which will identify a particular individual's vulnerability to side effect of the medications, as well as predict that this particular person will respond to a particular treatment, whether it be pharmacological or non-pharmacological or psychotherapy based treatment. So yes, this is the current trend which is going in treatment aspect. Another aspect which I would focus on, recently now the treatment modalities, again both pharmacological and non-pharmacological, they are focusing on the neuroplasticity in the brain, that the synapses in the brain, they are modifiable to a certain extent which can help in mitigation of the mental health issues. So our approaches are gearing towards that, and also the focus on the inflammatory mechanisms as well, use of anti-inflammatory drugs in mental health conditions, as well as certain psychopharmacological agents which have been found to be effective in certain inflammatory conditions like rheumatoid arthritis and autoimmune based conditions. Chatbot based therapies, they are coming up. We have multiple apps which are available, and neurostimulation, deep brain stimulation. Enough is being discussed about repetitive transcranial magnetic stimulation. Dr. Nand, who was one of the chairpersons in the previous session, he's leading neurostimulation in India at AIIMS. So neurostimulation is one thing which is also a latest trend in the mental health. Among the social trends, reduce stigma. See, we are we had a recent theme, let's talk about mental health. So we all are encouraging that discussion about mental health, and we are trying to reduce the stigma by various awareness sessions, by discussions, etc. But I put a question mark there, that is this reduced stigma limited to metro cities, or are we able to reduce the stigma in the peripheral areas as well, which is left for discussion. Pathways to care as well. The pathways of care are changing now. Earlier, a person with mental health issue would first come to the local faith healer or the physician. Now we are seeing, at least in metro cities, they would first go to mental health professional, be it a psychologist or a psychiatrist, and even the physicians, even the faith healers, they are now referring those patients to the appropriate mental health professional. Next, please. Next slide, please. Next slide. Okay, so some of the latest trends, again, adding to the latest trends. Early diagnosis intervention, in the recent years, again, like from artificial intelligence also and certain studies, we are now trying to target that can we diagnose psychological issues in their infancy before they develop or before they reach a level when it becomes difficult to manage them. So the advances are being made in this field. Second aspect, employee mental health. Again, this is an important topic which is being focused on, has been a theme in the recent years. So employee mental health, workplace mental health is another thing which everyone is focusing on, many of the corporates, they are now employing organizational psychologists. They are they are bringing in, they are having regular sessions on mental health issues in their centers. Mental health specific to various phases of life. Now we are trying to divide mental health issues among various phases or life cycle stages: childhood, adolescence, adulthood. Perinatal mental health is something which there's a lot of focus going on, and NIMHANS has come out with the manual and the approaches that how perinatal mental health issues in during pregnancy as well as the postpartum period. In one of the sessions we had discussed about postpartum psychosis as well, and geriatric mental health issues as well. Telemedicine, again a recent trend, has already been discussed. Artificial intelligence, I have already mentioned. Insurance. So the Mental Health Care Act, as we all know, it makes it mandatory that mental health issues also be covered under the insurance schemes. And IRDAI has also given the instruction to the various agencies. But still, we have not been able to develop those norms. Dr. Desai is one of the members of that IRDAI committee, which has been recently constituted to cover those norms. Climate change and mental health. The impact of climate change on mental health is something, again, which is we all are discussing. We are discussing about global warming. We are discussing about the changed environment, the changed conditions that we are seeing. So climate change and mental health, my next panelist is going to cover this aspect in detail, as well as disaster mental health. Dr. Chadha mentioned that the situations of disaster, be it pandemic, be it earthquakes, be it different situations, the focus on the mental health issues arising from disaster is also another area which has been recently studied up. The book that has been released in the morning also has a chapter on disaster and mental health, so we all can refer to that chapter as well. Next slide, please. This particular thing, Dr. Muley mentioned that it is important to generate data. It is important to do research in mental health. And we in India, we have a minimal data available of mental health issues. We have the National Mental Health Survey which was done, but we really need to generate data. The mental health issues are increasing gradually. There are various factors leading to this. Much has been discussed about resilience as well. So we really need to develop a research which will cover or generate the data and also analyze the issues which are contributing to this increased mental health morbidity. We need a mental health information system in our country which will collate all the data about the health, the infrastructure available for mental health, and the various resources for mental health which are there. Next slide, please. Just briefly touching on because for the sake of completion, critical care, Chadha mentioned. So there are certain conditions in mental health in which critical care scenario is required. Patients who are suicidal, patients who are aggressive, violent, catatonia, patients who are having serious medical comorbidity. So next slide, please. So there are no latest trends among these particular conditions, but as this is a conference on human rights, so I'll just touch the human rights issue in these critical care settings. One is the issue of capacity and consent. Patients who are in this state, the issue of their capacity and consent becomes an important issue. The admission section, whether it will be an independent admission versus a supported admission as per the Mental Health Care Act. And if it is a supported admission, once the patient regains the capacity, that section needs to be changed to an independent admission. Issue of restraint. In critical care setting across the country, I'm not talking about only mental health settings, intensive care settings, patients who are in delirium, patients who are in withdrawal from any substance, they are frequently restrained, they are tied up. And this is the scenario, I think the NHRC members would agree if they have observed. This is a common scenario in many of the hospitals. The Mental Health Care Act and the Mental Health Care Act, the Central Mental Health Regulations, they have come up with clear guidelines about how restraint should be applied and how it should be monitored. So we really need to enforce these settings in the critical care setup as well. In one of the sessions, it was discussed about the electroconvulsive therapy, especially for the minors, being a prohibited treatment under the Mental Health Care Act. And we frequently face children who are suicidal, and we feel that electroconvulsive therapy is required. But in the absence of mental health review boards across states, this treatment is frequently not given. Quote unquote forced treatment in their state of impaired capacity. When we are treating them, are we forcing treatment on them? And the issue of covert medications, because the medications sometimes are given without their knowledge, without their understanding as well. So these are some of the human rights issues which are relevant to the critical care setting, which I could think of. Next slide, please. So way forward, technology is going to be an essential component of mental health. Dr. Thinendra has pointed out very nicely. Regulation of technology in terms of protocols, issues of confidentiality, privacy, data safety, etc. need to be streamlined. However, in a field like mental health, technology cannot replace human element. Insurance guidelines need to be implemented soon to increase accessibility to mental health care. Life cycle perspective is an important component which we all should be cognizant about. Genetic research will play an important role in the future of mental health as well. Thank you.
Thank you so much, Dr. Babu. Now we have Dr. Varun Shantilal Mehta, Associate Professor, Psychiatry, Central Institute of Psychiatry, Ranchi. Sir, 7 minutes, please.
Thank you, ma'am. I hope I don't get your white slip. Okay, good evening, everyone. Johar, Honorable Chairman NHRC, respected Chair, Co-Chair, respected panelists, distinguished audience. A lot of it has been talked, and I understand I'm the last one. I'm coming between the end of the program. It's a challenging situation for me because I run a risk of sort of repeating what everyone has spoken about, but I requested Bhau to not talk about the climate change actually, and he readily agreed for it. So I just require attention for a couple of minutes because I need to plant an inception, an idea as to why it's important to discuss about the impact of climate change in mental health. And we did have some discussion, like we do know about disasters, we do know about the floods, we do know about the earthquakes, and we do know that it can cause a lot of psychiatric ailments, problems, right from post-traumatic stress disorder to depression to anxiety. But we also know that it can lead to property damage, job loss, separation from loved ones. Now, these are the important social and economic determinants of mental health that we as mental health professionals many times fail to take into account during addressing these difficulties. They ultimately affect economic growth and affect the individual and the societal levels. It is something we also need to realize about how a climate change can cause gradual long-term changes. So say, a lot of individuals or even societies who have not experienced any of the climatic events, they do have subclinical depressive symptoms, they do have despair, guilt. Now, key contributor to this is climate anxiety. And what is it essentially where we are unaware of, we are not having any appropriate plans, skills or direct agency to mitigate it as about the impending danger. There is a sense of hopelessness, and that's something which is very, very impairing. There's something called as eco-anxiety, and Sir did briefly mention about the eco-anxiety in his report. It's actually a fear, and this fear can manifest as loss of appetite, insomnia, panic attacks. A very other concern regarding the increased temperature, and all of us, I'm sure, we are quite worried as to how hot it is, how humid it is. But there is evidence that monthly temperatures above 30 degrees centigrade have increased the likelihood of mental health problems by 0.5%. And that exposure to increasing temperatures about 1 degree over 5 years has led to a 2% increase in the prevalence of mental health problems. We do know that climate change, specifically drought, has a very huge role in contributing to farmer suicides. And there's some data from Finland to also suggest that variation of over 60% in suicides is actually attributable to climate change. That's how significant it is. And you go across, and there are a lot of data to suggest that during the summers, there is increase in the number of hospitalizations, there is increase in the number of hospital visits. In fact, the air pollution has an impact on the developing brain of the adolescent as well. Now, we do know this impact, but who all does it affect? Now, it affects the ones who are already vulnerable. Now, who are the ones who are already vulnerable? These are the ones who have pre-existing chronic health conditions, the one from low socioeconomic status, children, elderly, and certain ethnic minority groups. Now, these are more vulnerable because they also lack the financial, social, and community resilience to tackle with it. Now, there is a double whammy because these are the individuals who are least responsible for the climate change. And this is where the entire talk of climate justice has been, and also should take into account the mental health impact. And the climate justice highlights that this double inequity of climate change, in which the risk of vulnerability and the responsibility, they are distributed in reverse order. So that's the reason we need to pay a lot of attention on the importance of climate, not just on the physical, but the mental health. But we are struggling here, even though because we are still struggling with the parity of mental health with physical health. Now, there's something else regarding we need to know about the Lancet Commission on Climate Change. Way back in 2009, it stated that climate change is the greatest threat to global health in 21st century. Yet it fails because the climate The Lancet Countdown on Climate and Health Change does not take into account any of the mental health indicators that the climate change can impact. The way forward is quite easy and maybe equally challenging as well. WHO has come up with the Mental Health Gap Humanitarian Emergency Manual, the Building Better Back framework. It has incorporated the disaster-related aspects, and I was hoping that it could also take into account the effect of the climate change and include it into the mental health and psychosocial package. We need to work with ecologically vulnerable and the disaster-prone individuals, make sure we can integrate the primary health care and the referral system, and also improve the transportation and the access to care. Just like to end with a quote by Hippocrates: "Whoever wishes to investigate medicine properly should proceed as so. In the first place, to consider the seasons of the year, then the winds, the hot and the old. We must also consider the qualities of water." Thank you.
Thank you so much, Dr. Varun. So we have had a very diverse views being presented. The presenters they are champions in their own field. They are ranging from academician to UN agencies to the clinical psychologists, professional associations. So everybody pointed out to one thing, is that we all need to work together for mental health. With Dr. Nimesh Desai, his own way punching humor into his presentation did tell us that there is a huge treatment gap, and alerted us on the role of confidentiality and how the pharmaceutical practices may endanger the practices of mental health. We also have Dr. Narmadeshwar Prasad, who shared the shift in the policies in mental health, taking cue from the WHO mental health report, which was released last year, highlighting the need for community-based healthcare and also giving pointers for gaps in information, resource, and governance. These are useful tips for policymakers. And definitely, sir, we are really grateful to you for giving this target of Mission 2047, which will spur us all to march ahead. Then we had Professor Rakesh Chadha, who had, from his long experience in a center of excellence, showed how, illustrated how having mental health, Department of Psychiatry in general hospitals have been able to reduce stigma and discrimination. At the same time, he alerted us on certain inadequacies which still exist in terms of facilities at the emergencies, and definitely these are cues for planning any psychiatry facility in a general hospital. Then we move to Dr. Dhirendra Kumar. Definitely from the psychologist perspective, he shared how artificial intelligence has been, supporting the diagnosis and treatment of psychiatric disorders, but alerted us on the concerns like it does not have the adequate human touch and also data privacy issues. Definitely, these are concerns, and I think as we are here today, we should take this into consideration. Then moving to Dr. Chiranjeev, definitely the Human Development Report 2021-22 is a landmark publication which has really showed the relation between mental health and development. There is no doubt that the social context and influence and the life course approach are very key to the development of a human being, especially the factors that are affecting them in the early childhood have a great bearing on their adulthood as well, and alerting the need to have special focus care for marginalized communities. Definitely that is something we are all here to deliberate on. Then we had Dr. Bhavuk, who definitely shared the three aspects of care, from diagnosis, treatment, and the social aspect as well. Definitely, stigma reduction is the need, and there has been some stigma reduction, but we all need to see whether it is just confined to the major metros or it has been able to percolate to smaller cities and rural areas as well. If not, then we should work for that. And definitely, our last speaker highlighted, and it was a very eye-opening data that he said that 60% of the suicides are related to climate change. We've heard a lot about air pollution. Definitely, I had been the focal point for air pollution in our office for a long time. And when Delhi was declared the most polluted city in 2014, there was a lot of hue and cry. Everybody was talking about all physical ailments, but this is definitely an aspect which nobody touched on. And I'm really thankful to you to bring up this in this forum. Definitely, and today we are all gathered here to actually take points back so that we can utilize in our work. My sincere apologies on behalf of the organizers that because of paucity of time, we could not let the speakers have their entire 10 minutes. However, their presentation are really valuable, and we would encourage them to share it with NHRC so that it can be distributed to all the audience here. They are a great source of resource for us to learn, and we'll be happy to have them. So with these words, I would share it, I hand over to my chair to take forward the proceedings.
Well, nothing to add. We just conclude with this, and thank you so much for joining and sharing your very, very precious views. Thank you.
Thank you, Chair, and the co-chair and the panelists. May I request Mr. D.K. Nin, Joint Secretary at NHRC, to present a memento to the chair, co-chair, and the panelists of the session.
Can be used immediately, consumed or recycled. इसको जो मैं मुझे क्यों दे रहा
Sorry.
Stay in touch. You have the card or something?
No, sir.
I'll give you, and if you can just email me your numbers.
Sir, मेरा phone भी चला गया, but I'll definitely
You can just write maybe, and I will send them a message. I think तालियां थोड़ी जोर से बजाइए. I will do the last one.
So 2 mementos to Dr. Bhuvagga and Dr. Varun Shantilal Mehta. Yeah. Thank you, sir. With this, we conclude the 4th technical session and proceed towards the valedictory session. There will be May I now request Mr. Justice Arun Mishra, Honorable Chairperson NHRC, Honorable Members Dr. Gyaneshwar M. Mule, and Mr. Raju Jain, Mr. Bharat Lal, Secretary General, to kindly take their seats on the dais for the valedictory session.
बोलना
निम साहब को निम साहब कहाँ है?
May I request Mr. D.K. Nim, Joint Secretary NHRC, to please take the seat on the dais as desired by Honorable Chairperson. Please come on the stage.
मनोज जी
So, may I now request Mr. Raju Jain, Honorable Member, to give concluding remarks and present the summary report on this conference.
Chairperson, sir, and colleagues, while having chai, everyone told me that they were awake through all the sessions and they've heard everything. So why summarize it? Thank you very much, sir.
Thank you, sir. May I request Honorable Chairperson to share his thoughts and deliver the valedictory address.
My job has been made very lighter by my esteemed colleague. I have to simply thank all the experts who have worked like a beacon light throughout the day. They have shown what kind of knowledge bank India has in the field of mental health. Their work, slides, speeches, and the knowledge has enlightened us. Power of this collective knowledge is going to serve the purpose of human rights in India. Though we have very good legislation as agreed by all the speakers, but we have to think over Indianization of the whole thing. Just one thing I will share, that when Dr. HOD from AIIMS was speaking, it came to my mind. When the patients are being treated very effectively in the general hospitals without isolation, whether we should have the concept of isolation now, only it should be in rarest and rare of the cases, you see, isolation should be made. Family care, community care, there can be any parallel to family and community care. I'll share just one thing and then I'll not take much of your time. One of the report we have received only 2 days before from Gwalior Mental Hospital, sent by a district judge. He has said that time has come for the policy makers, lawmakers, to think those who abandon their family member and not taking them back, why they should inherit the property of that person. That policy change is required. That was working in my mind. I was thinking the night that what kind of suggestion it has come. I do not know how far it can be taken, but this kind of suggestion came to us from by district judge, that too on the inspection of the Gwalior Mental Hospital. Now we have seen that we have section 31(3) of the Act, which lays down that we have to come up to the international standards of the manpower, doctors, within 10 years of the implementation of this Act. Section 31(3), yesterday we discuss with Narmadeshwar Prasad, because in his one of the article, it was mentioned that 10 years time is there to bring India up to the international standards. So I just phoned him. Then he explained that then we thought that this provision is important. So it is absolutely necessary to increase the manpower at all, doctors, social workers, nursing staff in this to bring up to that level. And then human resources to be developed is the main challenge beside infrastructure. Everybody is here, and this shows their commitment that we are going to improve the situation when all concerned stakeholders are taking so much keen interest, and their presence up to 8 p.m. itself indicates that what unwavering commitment all of us, all the stakeholders have in this field. So I am confident that these deliberations made today are not going to go in a vain. Yoga should definitely be connected with the welfare, mental welfare, sustainable development goal, which was last speaker stated about that climatic change. It's very important. Climatic change affects everything: migrations, livelihood, agriculture, and sustainable development goal and global development goal. That's why it is very important, mental health. So there has to be investment in it also. And mental health is to be protected and prevented, and early solutions as done in Australia and other countries and England, etc. Early intervention, that we have to work on it, and then we have the system in order. Matter is only of manpower. As soon as we have the manpower and the trained doctors, physicians and nurses, nursing staff, we can train the general physician. By that time very good suggestion came. So I am confident that things are going to improve we are going to achieve the target, though with some delay, but we are definitely on the way of stepping stone. This is not the halting place. Now, I personally thank each and every contributor to this, those who have not spoken also, those who were speakers, those who were present and listened and heard these conversations and worked behind the curtain. I thank everybody, and I feel that we are going in a right path, and the way has been shown to the Human Rights Commission today by all the stakeholders that what is the way in which we can improve the situation. I am thankful by core of my heart to all of you for devoting the time, knowledge and your experience and research work. Thank you very much.
Thank you, sir. May I now request Mr. Deven Kumar Nim, Joint Secretary NHRC, to deliver vote of thanks.
2 minutes. Okay. I have been observing since 6:30 in the evening, because the official time was 6:30, that people start clapping even the speech of the speaker is over. So it means that everybody wants to rush back home. So starting from the beginning, I would like to thank again Honorable Minister of State for Health and Family Welfare for gracing the occasion and inaugurating the important conference, and also releasing the book and report. I would like to thank Honorable Chairperson and members of the NHRC for motivating and being the guiding force for conducting smoothly and efficiently all the conferences in the past and this also. I would like to thank all the members and chairperson of State Human Rights Commissions, directors of mental health institution. One of the institution I have visited, Dr. Pratima Murthy, who was co-chair also, for coming here and attending the conference on the very, very important topic. I would like to thank Honorable respected Secretary General and Director General of NHRC for their being guiding force and always motivating to do better job. I would like to thank all my colleagues, Mr. Surjit Dey, Madam Anita Sinha, and Director Colonel Virender Singh from Investigation Division, Sri Sunil Meena, and SSP Mr. Meena, all other colleagues, officers and staff, and sorry, I forgot to take name of Additional Chief Secretary and State Health Secretary of various states who came here and attending the conference. So thank you very much, and obviously all the young research consultant for contributing and always assisting me for the last 1 month to conduct this conference very, very successfully. Thank you very much. All the best.
Sponsors of